That's unmuted, but you have to mute that also for them. In correlation with the clinical outcomes. This will be followed by Mr. Majid, who will be talking about the digital healthcare. Then we have Dr. Muhammad Al Mubarak, who is a healthcare consultant, and he's going to talk about never events. And once again, we will have Dr. Muhammad Al Mubarak, who will also be talking about hospital designing for safety. So let's jump into our very first session, and I invite Dr. Assam Hamid Amin Ali for his talk. Welcome, doctor. Thank you. Yeah.
Hello, good morning, everyone. In our hospital, we have two things, major things. First, we measure the patient satisfaction, which is very important for our work, and the aim for all of us for working. We're working for patients, so always we say patient first. So we have to measure our success through the patient satisfaction. Whatever high rate, whatever it's our success. And in the other side, in the other part from the hospital, there is another team. They measure the KPI and the performance for our staff or our hospital as general, which is KPI. So we measure the clinical outcomes through the KPI, and in other side we measure the patient satisfaction. But does we think to link between these two areas or these two measurements, the patient satisfaction and our performance through KPI, we find that it's very important to measure or to link between the patient satisfaction and our performance through KPI to improve. And it will be more clear if any gap, if anything, problem, we can see it very clear if we link. So we think for this point, and we start work and we start make this study. The outcome measure, we measure through we choose initially 6 KPI to measure through this 6 KPI and to link between this and the other patient satisfaction to can see does we success or is there any problem or is this our performance affect the patient satisfaction or not. We choose the 30-day readmission for adults, and also the number of patient complaint, the mortality rate, Laminar, live against medical advice, average length of stay, patient satisfaction rate of for inpatient. Actually, the result is this study. We start to focus in the beginning for only 6 KPI and for one area to can be easy for us to measure, to see does we can measure or not. Because if we make it for all the KPI, it would be huge study for us. So we only choice or select this 6 KPI and we start to work for it. What is already known of these topics? The patient satisfaction with hospital service is one of the most important indicators of effectiveness and quality of hospital service. Patient satisfaction survey can provide valuable data for evaluating the status of quality and the quality of process improvement program and the quality improvement to health managers and policymakers. It's a concept that has received that attention today in healthcare, and it's one of the main goals and priorities of the health and treatment system. So as we say, it's very important for us, and all of us, we measure the patient satisfaction. But when we look for this one, we only put target for patient satisfaction, 90, 95, 96, and we try to reach to this one. And when we not reach, we start looking for only one area, the patient complaint. We see if any complaint, to solve this complaint, to try to increase the patient satisfaction. But this is what I say through this study. There's only solving patient complaint, it will increase the patient satisfaction, or there is some other factors we have to work for this one to can increase this patient satisfaction. Okay, what is the problem? Hospital tell you, as you say, they only measure this one and measure this one separately, but there is no link. So there is no clear, as I say, it only solving patient complaint, or there other factors affect the patient satisfaction. So we have to look at the whole picture to see where is the gap, where is the problem, to try to improve our service. The objective for this one to assess the clinical outcome is this one. To assess the clinical outcome, to assess the quality and the healthcare services in the hospital, to evaluate the patient satisfaction, and to identify the correlation between them. This is the main aim for the hospital. Okay, let's start the study. We start with the questionnaire or the survey for the patient. So we make it in focus in different area for doctor, for nurses, for hospital at all, and with some question, which is we try to be related by somehow to the KPI, to measure our performance in each area. So we put some question for doctors. Is the doctor quality of care given, or the doctor treated you with dignity and respect? Also for nursing area, quality of care given, treated with you by dignity, and response time when they press the call button. Also to measure the pain management, which is very important. We add this one. Also for administration area, we put for reception, for patient room, for patient, as a two question for patient room, and also for other service as general. For reception, efficiency and speed of admission process. For patient room, cleanliness and quietness for the room. Other service like efficiency and overall service of the room. For the phlebotomist also, because there is some, we find that there is some complaint also from the phlebotomist if he's not professional of make some pain for the patient. Some patient complain that they cannot find the vein or whatever. So we put also question for the phlebotomy room regarding your medication. The discharge, for the discharge also, efficiency for speed discharge, or efficiency for speed discharge for medication. For hospital environment, there is two parts for hospital, one for environment and one for generally for the overall the hospital. For hospital environment, convenience of visiting hours, quality of food, and also for parking facility. Overall rating as a hospital generally, overall rating of hospital, overall rating of hospital for how would you rate this hospital in terms of overall service. if you evaluate as a recommended, if you recommended the hospital to other one, if you recommend the hospital for family and friends, this 19 question we try to cover all the area in the hospital and focus in last two area for the hospital, because this is our main aim, the final performance for the hospital as whole, which make the patient satisfied, and if they have any complaint for the hospital as general. Okay. As we say, this is the KPI we mentioned before, the 6 KPI which we choose: 30 days of all course readmission, a number of patient complaint per month, mortality rate, leave against medical advice, average length of stay, and patient satisfaction. And we'll come to each one of this one later. KPI reporting we follow in the protocol for the nomination, the responsible data collectors, and also for validation, and ensure the data collector leads and adequately skilled and resources. We have trained the data collector staff, understand, identify what data is required. It's very important for the data collector to know which data they collect, and in each KPI, just I will brief for the KPI profile, what is the numerator and denominator. Create a data collection plan, when and how they can collect. Ensure adequate data collection system and tools are in place. We must facilitate for the data collector to collect the data, maintaining accurate and reliable data collection methodology. Data collection and analysis for reliability and accuracy, backup and protected data integrity. We have to have backup for our data to not miss anything, because we have to go back to this data as a reference if we have find during analysis any difference. Have in place data checklist before reporting the KPI data on time and ensure validity for the data. Review and feedback data finding and share it to the teams in order to promote performance improvement. This is generally what we're doing for the KPI in the hospital, to collect the data, to analyze, to validate the data, and after there is report for KPI. And this is what I say in the beginning. Now, this is the data for KPI reporting. We have the patient satisfaction. Now we have to start to see or go what we find. First, total patient score. How we score? We put in the scales actually from 1 to 10 for each question. So the patient has to choose from 1 to 10. 10 is excellent, 1 is a poor. And after this, we calculate for each one, we accumulate. If we put 5, and in other question, other patient put for the same question 6, so it's 11, and so on. So you'll find the number, it's 1,000 something, so on, because we put scale from 1 to 10, and we calculate regarding to these numbers. Okay, for the doctors, there was 2 questions for care and for dignity, and this is what we find. It's actually around 95% or more than 95%. For nurses, also, this is, we will not go deep in number now, because this is just what we find, and this is what we will measure. This is what I want to show, that when we measure, we have target, we'll show the target later, it's 95%. We, as a patient satisfaction, we have to reach to this target. So this is just patient satisfaction, we make it, and we achieve the target. Now in the study, we want to see this target, it's actual satisfaction or no, or what is the problem. You have to see is their outcome. This for overall rating for the hospital. This for pain management. Patient satisfaction rate for inpatient. Now we start the KPI. we see the patient satisfaction, and we see the result, and all the result, it's within target, up or down very little. The patient satisfaction rate, as we say, it's 95%. The number of patients who answered yes to the question, would you recommend to the hospital to your friend and family? This is the numerator. Denominator, number of patients who answered the question, would you recommend hospital to your friend and family? We measure the patient satisfaction through this KPI, which one question in the questionnaire which we saw. All the patients which say, yes, we take this question and we take the rate for this question to measure the satisfaction for the patient, plus the other one. Just so now for the KPI, we say that there is general paragraph we show for the patient satisfaction at all, for all the questionnaire, which is there is difference between each question. But now for the patient satisfaction rate, the KPI, we identify the KPI, the data for this KPI is the patient which say yes, that they will recommend the hospital. So it's meaning they are satisfied for the hospital as general. So this is our KPI, first KPI. This is the numbers or the data, and here this paragraph we see that there is in 2 months, and also in started in 2020. There is 2 months we achieved our target, but there is other months it was below the target. Again, it's not the total patient satisfaction, it was only for one question in the questionnaire. This is our KPI. For the 30 days readmission, what is the numerator? Number of adult inpatients who were readmitted to hospital within 30 days of discharge from index hospitalization. All the patients, adult patient only, not the pediatric. The adult patient, which is readmitted within 30 days from his discharge. The denominator, the total number of adult patients discharged from a hospital during the reporting within this month. Within this month or within this time, there is adult patient readmitted. So the denominator only against the adult patient, not the pediatric patient. So we find in Q1, it's made by quarter. Q1 there was 61 patients readmitted out of 1,825 patients. Q2 it was 42 out of 1,225. The percentage it was 3.3 for first quarter, second quarter to 3.4. Here we say the lower is better. The target here lower is better. So 3.3 in first quarter, 3.4, so it's in the same level. Here for LAMA, leave against medical advice, the denominator total number of numerator, the all LAMA patient in inpatient, we measure here for inpatient during the period for the study or certain period which we decided, a total number of admission per month. So we see the LAMA patient against the admitted patient in the inpatient, not for all the hospital, because all hospital LAMA, you know, there is for emergencies, there is for other ward, but we say for inpatient only. And this all the data, it was for 10 months. And here's the number of LAMA or the graph per month. Maybe the lowest here is May. It was for LAMA only. And all the other, it's different. Here, the rate against the total number. Now, patient complaint rate per 1,000 visits. So our target to be less than 1.7 patient for each 1,000 patient per day. So the total number of patient complaint against the total number of patient served for IP and OP. Here we measure for all the hospital. So it's coming like this. Here up is the target, and down this is the patient complaint. So we below the target, which is better. Average length of stay. So the numerator is total inpatient bed days for patient in the period of time, and the total number for inpatient discharge for those in stay period. We measure here the average of the total number or the average bed day for per patient. It's the average, not the actual, because, for example, 1,000 patients for inpatient. One, say, between 1 day and 3 days or 4 days. So we calculate the average, and our target lower is better. And here what we find. There is one comment here in these two, because in these 2 months there is some COVID patient was referred to the hospital. So it increased the bedtime rate in these 2 months. So these 2 months is exception for COVID, but generally this is the level for the bedtime between 2 to 2.5 days. Mortality rate is supposed to be less than 8 per 1,000. The numerator, number of patients death in inpatient and day surgery cases to the total number of discharge, and this is what we find. And also again we will find in the same period in April and May, zero increasing mortality, but also COVID patients. So this makes the difference, but others it's within the normal level. Now we start with the patient satisfaction with all the KPI. So the patient satisfaction and all the KPI. Is it clear now? Because we got all the 6 KPIs in the whole graph, so we cannot see actually, we cannot link by this graph. So we'll take it one. But here, just to show you that the aim of the study to link both together the patient satisfaction with the KPI achievement, and to start to study and to see. Now we start our study. Okay, let's take one by one. For length of stay, we find here the patient satisfaction, and here the length of stay. When length of stay increase, what will happen? The patient satisfaction decrease. So suppose this is the actual what going on. So we find here there is some statements for the data. So if you look here, you will find that this here is stated increase, and it's coming down. It was 1.9. The lowest one in October, and yet also we'll find that this one is therefore maybe the highest one. So yes, it's slightly affect the length of stay, affect the patient satisfaction. Even here in the graph, it's shown little, but why little? Because the study we make it in within a short period. First, second, there is some in the middle. There was some outside effect which affected the study for the COVID patient. But anyway, we find in the end that yes, effect when it decrease the patient length of stay, it increase the patient satisfaction. Come to the second one, mortality rate. Sure, if mortality rate decrease, the patient satisfaction will increase. And here also, this is 1 point. But coming here, it's going down, and this one going up. So yes, we find through the study that whatever the decrease of mortality rate, we will find that there is increase in the patient satisfaction in this time. Next one, for patient complaint. Sure, lowest patient complaint, highest, and this is the basic which we say from beginning that we measure the patient satisfaction, or we trace the patient satisfaction to increase this one through solving the patient complaint. So when we find that the patient complaint decrease, it's increase the patient satisfaction. Next, leave against medical advice. Sure, again, the lowest, the highest patient satisfaction. Because leave against medical advice, there is problem for the patient. They didn't like the treatment, they didn't like how we deal with them, whatever the reason. There is different reason for Lama. But the conclusion, the lowest rate for Lama, the highest patient satisfaction. And I think it's also shown here, even in the month of May, it's low Lama, it's high later on, but I don't measure. I measure here in the end, it's coming down, and the patient satisfaction is not coming up. What are the factors affecting the patient satisfaction? In general, after this, what we see and after this study, there is several factors affect the patient satisfaction, like the hospital environment, qualification of the staff, education, training of the staff, and the staff attitude. So the conclusion that there are some factors we must consider and put in mind when we plan and target to increase the patient satisfaction, like we must improve the hospital environment, we must look for high qualified staff, improve the quality of service for all departments. We need to look for the continuous improvement for quality in our strategic plan. These factors, after the study, it's a big study, I just try to summarize what the final conclusion or the final finding, what we find. If we link between the KPI, what we choose? We choose for example, for Lama. So Lama, what's the main effect for Lama? The attitude for the staff, the qualification of the staff, how the staff dealing with the patient. So all this is affect Lama. If we have high qualified staff, if we have professional staff, how to deal with the patient, we will have low rate of Lama. Also, regarding to the other KPI, you will find that this factor it's affect the 6 KPI what we have. So it's very strong recommended to look for our staff qualification, for our staff attitude, and for this we say there is some recommendation. I just mentioned here in 3 slides. Accurately define the scope of patient survey and tailor the questions to the scope. We have to be careful when we choose the questionnaire for the patient. We have to be careful when we choose the question which we ask the patient to can honestly and accurately measure the patient opinion. Okay. Set realistic response goals and remember to always manage in an efficient manner all the data you have collected. We have to look for the data which we collect. We have to see that it's reliable data, not fake data, not we have to validate it to see that it's accurate or no, it's correct or no, and to compare between 2 sources for the data so we can assure that it's correct data. Get feedback from staff members after the survey results have been reviewed. Important, not only the opinion, also staff. maybe they face some problem, but you didn't see. As a management from top, you didn't see what the staff facing. They have some problems, maybe in hospital environment, in friendship, whatever the condition inside the hospital, maybe it affects their performance, affects their attitude. So we have to make frequently survey for our employees to take their opinion to see is anything affect or not. When we see that increasing in Lama and decrease in the patient satisfaction, we have also to look for our staff. What is the factor which affect them to let them to be in this situation with or how they deal with a patient. Encourage patient to report on their hospitalization experience during treatment. Some hospital just they put the questionnaire and they leave the patient if he take or no. So usually the patient which has complained, he will go to this box to write his complaint or his opinion and to make. And 90% from the patient, they didn't look even to this box. So we have to find some way just to encourage the patient, please tell us your opinion. Your opinion, it's important for us, your opinion to improve us, whatever. There is some attractive expression we can use with the patient to can attract them to increase the feedback from the patient. Focusing on patient satisfaction will improve our healthcare services, which is allowing us to provide better patient treatment and care. We have to take it seriously, the patient satisfaction, because we work, as I say in the beginning, we work for patients. So we have to hear and listen to the patient to know what they want to can improve our healthcare. Designing a process to capture and address all complaints and suggestions. We have to create more channels for the patient, not only just paper in a box. We can write that you can send by email, we can send write WhatsApp number, we can write telephone to can call. So also we can make applications. There is some hospital make application. If you have any complaint, also you can make complaint. So we have to multiply the channels for the patient for complaint. To can be easy for the patient to reach to us. Not only just paper in a box. No, we have to give them more option. Implementing policies, procedures, and process to investigate and solve patient complaints and suggestions as efficiently as possible. We have to take serious all the patient complaint, and we have to have our process, which is accelerate the investigation for this complaint to solve and direct to contact the patient to tell him and to be sure that he's satisfied for the solution which we reach with him. Training all the staff members to manage patient and family expectations effectively. It's very important from time to time, as I say, if we make the employee survey, so we can know what is the gaps and what they need, and we have to also to make for them training how to deal with the patient using dedicated staff to provide resolution to problems before they escalate the problem. The problem solvers staff or employee, they are very good and they make the work easy, not the problem makers. If I find some patient and has some problems, and if I can't read this problem, it's very simple. Let me dictate it as an employee. Why to let him to write the complaint and to go to put or call or whatever and take time to investigate and so, and in the end, after all this cycle, we will let to see what he has to do. Why to spend all this time? It's wasting time. So the patient must be aware that if you can solve the problem with the patient, do it. If you cannot, and it's out of your hand, you can escalate to the next level. So we have to tell our staff and train them for this point. Employing a proactive approach to customer service, and this is what I say. We have to not wait till the problem happened with our patient. Empowering frontline staff to act as the first line of defense against complaint. Actually, always the reception or the first line, it's very, very important because the most complaint coming from the first line. And it's very important because this is the first impression for the patient when they come to the hospital. If they find smiling in the reception, they will be relaxing and happy. And you have to put in mind that this patient is coming because he has a problem. He's suffering. Maybe coming in rush, he wants very fast to go to the doctor or to the emergency room because he has problem. He has serious problem. So we have to consider this one and to know how to deal with this patient. You have to wait. Give me your ID. Give me your insurance. Tell me your details. How I can do all or to send you to the clinic without. So please be gentle with the patient because this patient coming with pain. So we have to train our receptionist, which is front line, first line, to reduce the complaint, and we must tell them how to deal with the patient. It's very important for the hospital and for all the organization. Designing and disseminating patient satisfaction survey to identify possible improvement initiatives and address trends in the industry. This is what I say, we have to be careful when we select the questionnaire to can have benefit from this questionnaire, how to improve our service, making patients the primary focus for healthcare providers in the hospital, patient first. This slogan we have to put everywhere in the hospital, and all our staff, we must be recognize this concept that patient first. All of us, all the hospital, from the top till the lowest one, working for this patient. Continuously seeking to improve their work process to address the ever-changing expectation of patient. We have always to identify what is the expectation for the patient to can apply this expectation or to working for this expectation to increase the patient satisfaction. And the last point, recommendation from me for all of us and for all of you, this study, it's very important, and this methodology we have to follow. We have to link between the patient satisfaction, the KPI, and it will show more clear photo how we can satisfy our patient. Thank you. And any question? Okay. Thank you. Okay, any question?
Any questions?
If any question online also.
Yes, please can I hear?
Okay.
Was a very, very nice presentation. For me,
Welcome. It's nice.
3,015. I want to ask you, mortality, what is your growth mortality rate? But really, the average group mortality rate, that really is patient satisfaction with mortality rate. Is it mortality rate? But you know, mortality rate.
No, it's opposite. If we increase the mortality rate, it will increase the patient satisfaction, not the increasing. Or
Yes, I know.
Yes.
I know. How much was the decrease in your mortality rate, and what is your good mortality rate?
Here in the study, we try to find answer for this question. Does the mortality rate affect the patient satisfaction or not? Here we find it's very, very slight. And also find that any patient of any group or any family has mortality. Our problem in the study is that they don't have time to take the questionnaire. So we find that we not find actual effect between this and this. We wanted to see if it affects or not.
Effect or not.
Yes.
But it's all actually all about
Yes. Right. This is what we say. Yes, we have to train the staff. We have to improve this culture for how they deal with the patient. Yes, it's cultural. It's environment, and this is what we measure also the environment in the hospital. And also, I say that not only focus in the environment for the patient, we invite the environment for the staff. It's a problem. Also, we have to come over and to solve it to convince to the ideal or there's no ideal, but the best.
And the CEOs and the manager should not all in their offices. When they got appointment, they should mix the frontline staff really to see all these things.
Sure. And as we say, all this data and all this study, it's important to the high management and discuss with them, and they aware and they share also in this study. Welcome.
Hi, Dr. Hassan. I
Welcome.
just want to make a comment that it's so important that the front line, that point of impact, the person who collects the data, the insurance information, that they show compassion and empathy when they're at their worst coming in. That'll decrease, complaints. And sometimes they don't realize they set the stage for the doctors, the nurses, and everyone in the facility. So that was a great point.
Thank you.
I have one question, Doctor.
Okay.
So, in my understanding, all these KPIs, mortality, etc., they will be for different departments
Yeah.
in the hospital.
Yes, right.
And therefore, your patient satisfaction will also be affected or will be different for different departments.
Yes.
So I have broken down, context to different departments and, compare them with the best industry benchmarks.
First part, yes. We comparing in each department, and for this I say at the beginning when I show the questionnaire that we make it separate in each department to compare with the performance with each department, with doctor, nurses, and so on. For benchmarking, this one actually we won't make it honestly because first when I go in the internet, I not find hospitals make the same study because I don't reach to the point. And this is my recommendation in the end for all of us in our hospital to make it because I don't find any hospital make this exactly. They make patient satisfaction separate, and there is a lot of study for patient satisfaction. And also there is for the KPI and the work for this performance and also a lot of this one. But to link between these two, I don't find. So I don't make any for the time and also because I don't find actually to make it.
So in my experience, there are studies which benchmark various KPIs.
Sure, for KPI, separate, yes. We're working a lot and there is the Department of Health and already all the hospital and they send reports to the whole hospital and there is benchmarking. You can see yourself, all the hospital number. We have this report monthly actually. For the KPI.
Another comment I want to make was that you have done a correlation and see exactly how your KPIs is related with the patient satisfaction.
Yes, that's what I said. You must link your performance through KPI with the patient satisfaction. It's very important. But before this study, in hospital, as I say, and in most hospital, I see most not all. Maybe I didn't know there is some hospital they do this work, but I don't know. They work separately for the complaint and for patient satisfaction. It's separate and all. So only KPI from this KPI what I mentioned, the rate of the patient complaint. This is only the rate with the patient satisfaction. But other KPI, it's not. For this we start working, continue. This one is the start. But there is after it will be more detailed and as you say, each category or under each area, what's the KPI and what's the rate, what's the threat. So this one as a state to make it, but I hope to be a start for all of us. And thank you for
Thank you very much, Doctor. It was really a very interesting presentation. Thank you on behalf of the conference. So we've been talking forward. So next we have Dr. Mohammed Al-Mubarak, and he is a healthcare consultant, and he will be talking to us about. So Dr. Mohammed, welcome, sir. You.
My assistant, my son. Good morning, everybody. And the other one is sitting there, the other son of. Good morning, everybody. Today we will come to know, you will come to know your hospital. Because most of the people, they don't know. They are going there, the doctor is treating, the nurse is treating, the laptop is taking, but they don't know what is going on in the hospital. And then trying here, according, it is a book from the JCI, which I really selected the most important thing to summarize it for you, to come to know your hospital. When you are planning to design a hospital, when you are participating in planning, it is very important. You see, planning is not only engineer and authority. It is the community. Everybody, all the stakeholders should share in the designing of the hospital. I hope I will try to really to go very quick through the presentation. If I don't complete, I'll make the other part in the next presentation, and we make the never events shorter. You know, the father of education in Harvard said one time, a course is like a symphony. يعني عمل موسيقي متكامل. The course is like a symphony. If you, after the course, at the end of the course, you can whistle some tones, that means the course is successful. You should not know everything, because it's always like this in any course. You see, there are three types of people. Those who make things happen, those who watch things happen, and those who don't know what happens. We will go all through these stuff, but we'll go very quickly. Designing for life safety. You see, these two things, they are major things in any hospital. Designing for mechanical, and plumbing, and electrical, for security, for patient flow, for emergency department, and so on. You see, our reference is Planning and Designing Construction of Healthcare Facility, third edition of the JCR. It is this. We come to our part one. We sit here, we have the planning, 4 phases in any hospital. The planning, designing, construction, and commissioning, move-in phase. Nobody is doing move-in phase, I believe, really, in our area, or even in the state. If they really move in, they have to simulate to bring all the staff before anything and simulate all the things, what will happen when the patient comes, only to try how things will go on. Organization have an opportunity during the design phase to anticipate, address many safety risks of healthcare facility. It's all because patient safety, light, flooring, anything. Design phase offers perfect opportunity to build reliability in the construction risks. There are a lot of construction risks. Many of you, I wish there are engineers here also. It is not only for doctors or nurses, it's for everybody in the hospital. How to minimize risk, isolate project, ensure effective HVACS, heating, ventilating, and air conditioning system, set up clean and dirty anti-rooms, all if we are having a project in a hospital. But if you build a hospital, it is another thing. Designing for life safety. It is challenging in everywhere in the world, believe me. The most fundamental design consideration in many healthcare facilities is life safety. Compliance with life safety code is challenging. Anyway, you see where to go, primary exit, emergency exit, really all these things, smoke alarm, we will touch on them very briefly. Life safety units of defense. I know we should know the unit of defense in our hospitals. I asked many people in my hospitals. Most of them did not know. Believe me, it is not, but we should explain to them, because if something happened in the hospital, they know. They know at least to guide the authority when they come for help, that this is here and this is there. Closing door to provide initial protection, room with fire, leave to safe corridor. Door has to be closed after that. Unit level 2 is smoke compartment. Very important. It's a type of passive protection in a building, such as walls, floors, ceiling, have appropriate resistance to spread of smoke. Smoke is killing. Really, as much as possible, we have to delay this smoke distribution. Unit level floor assembly. Unit level for building structure, fire rated doors, smoke barriers. we should know where our fire rated doors, and say in the medical records or whatever it is. We should have fire rated doors in certain areas. It should be certified, clear to investigation. When investigator comes, they have to see where. I can tell them this is fire rated door. How can you prove it? There is a stamp on that door. Those fire rated doors, they can resist fire to a certain limit that we can, that we will have time to save whatever they can save. Fire escape. Keeping corridor clear. I think this is a challenge in every hospital. Maybe, excuse me, I have to take some water. Many of you have experienced that corridor. Always we have in the corridor some cartoons and something. Some hospital failed in the JCI accreditation because of corridors were blocked with such things. Why they were blocked? Because we did not plan for that. We did not have right storage in our planning. I know in some area in this world, I don't want to pinpoint, they converted the hotel to a hospital. And how come? It's better you keep silent, please. Yeah, confidentiality. Or the authority, the top man of the authority, he comes and see, oh, we are building here a new hospital. Yes, sir, we are building a new hospital here. How many beds? 300 beds. What's the plan for 300 beds? No, 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 how come? Make it 500. Believe me, this happens. Life safety code addresses many aspects: corridors, doors, vertical opening, elevators, escalators, sprinkler system, utilities. So I promise you that you will know your hospital better. Designing for infection control, this is the second thing. And when you design, we have to know, there are two people in the hospital. Now after we were in a hospital, infection control and safety man. Well, we have to say yes, sir. That's all. It is really, we have to comply with all these things, infection control. They will interfere in our life. It is annoying sometimes, but it is for the sake of us and for the patient. Hand hygiene, it is a problem, hand hygiene. Yeah, I know some hospitals, they can have 80%, and they, oh, come on, 80% hand hygiene. Even the state, they have the best hospital, they have 50% hand hygiene. We don't want to decorate and our data and make up for the data. It's not, we have to tell the truth. If we tell the truth, we will improve. Now, hand hygiene should be considered staff workflow. I have to think about the staff, how they move. Now you will see, the staff should not move for supply more than 25 meters to get the supply what she needs. Nobody is thinking about this when they're designing. Hand gel dispenser can be placed in and out access or even between patients to reduce cross-contamination between patients and in the same room. Positive pressure rooms, protective environment rooms, PE rooms for immunocompromised people, airflow from room to general. Which area has also positive pressure? Very important area in the hospital, which must have positive pressure. Who can tell me from the nurses? If we have nurses here, I don't know. Where? Operating room. Operating room is the most important, where we should have positive pressure. Positive pressure, that means that no air can come in, driving the air out. Negative pressure for patients with airborne infections, for rooms with hazardous waste, dirty utility, those, they should have negative pressure. Anti-room is recommended, but believe me, it will be mandatory. And if you are building a hospital, it should be with anti-room for a negative pressure room. Laminar flow, what is laminar flow? Is it the area required extremely clean, such as OR, transplant units. Laminar flow is high volume airflow. It's forced from the ceiling through the object what you want to, and to the patient in the OR table. Engineering, heating, ventilation. You are saying, yeah, Mubarak, you are telling now about heating and ventilation. I mean, it is, really, we should know about it. An effective HVAC system can dramatically reduce the spread of infection, cross-contamination in high-risk area, or OR, lab, ICU, isolation rooms. Heating and ventilation system should maintain appropriately humidity, temperature. What is the humidity in? It is very important to know about humidity. In OR, average humidity. Who can tell me average humidity in OR? Humidity. How much? We should know actually, because if we go there and read it, say the quality person go there and read it, infection control go there and read it, oh, you will see in OR humidity is 70%. It will ring the bell. Should be around 50. Water supply system, if we are designing faucet, those who with curve, this is a dead ends. It's a primary infection control concern, dead ends, very important. Cold water to be kept below 20 and hot water above at 60. Decorative water features, no more decorative water feature, really. It is not all this fountain and these things and sprinkler. It is nice, okay. I hate it even really in outdoors, because I still believe even in parking or gardens, I think they help for spread of infection. If somebody coughs here, and by the way, this bringing water coming can exactly hit that particle what was coughed to come to me. It's just like this. Those water features may make this sterilize the water with bacteria or other organisms. In the States, death from bacterium Legionella have been linked to water features in hospital. Now, no water feature. You can build in glass. Okay, you can see what will be the species. Also, this healthcare generates huge amounts of waste. While designing, we have to know how the waste, how to be carried, where to be collected, how to be, we should all imagine all these things. Infection control and reprocessing from scope is very important. CSSD, it should be very close to the OR, very close to the OR, not more another separate department. And we have also in the OR we can disinfect some things. So no, we have to reduce that minimal to minimal sterilizing in the OR. The 3 stages of scope cleaning: gross wipe down procedure, initial flush. The scope is moved to the scope processing machine in clean room. We should staff competency for these scopes. You know, the most of the scope which I have seen, they are hanging like this. The problem at the end, they are touching the end and making like this. This is very bad. Really, the scope should not touch the floor, because if there is something, drops of water or whatever, it should go there. If I have a knick, it is a problem. Furnishing, choosing materials for equipment, easy to clean, reduce the risk for contact and transmitted infections. Some materials and equipment incorporate antimicrobial agent, metallic copper for sinks, toilets, silver, wood, and metal furniture. Carpeting. In the past, it was discouraged, the carpeting. But now it could be, because it has some benefits, but it should be low, يعني ما في very low file, because of that we don't carpet can decrease noise, can decrease certain type of falls, not all falls, leg fatigue, and heating costs. When considering relationship between falls and carpeting, it is important to know there are 2 commonly used categories of falls: slip falls and trip falls. Slip falls when we slip like this. Trip falls لما نتعنقل كده مش حاجه كده وتمسك الرجل في العالم. Carpeting is not recommended in areas with high risk, such lab, food, operating room. However, nursing station, corridors, lobby, because low noise, it is better. Finally, if an organization chooses to carpet, it must select low file carpet for ease movement. Actually, when we push patient, and ما تكون from down should need impermeable for soaking. And wall covering should be fluid resistant, easy to clean. Ceiling, have you ever looked to ceiling? We see in the ceiling this all had مربعات, square. How many times we see fungal accumulation in these things? We see this black. We should really watch this, yani, continuously should be changed. There's no for relaxing. Have nothing to do with the hospital. Designing for mechanical, electrical, and plumbing system. Correctly designed mechanical system are crucial for facility. Some key infrastructure, sprinkler coverage, fire, smoke compartment, fire smoke dampers. Those are the dampers. We have manual dampers, we have electrical dampers. Okay, then we will transfer to the next. We complete it in the next presentation. Those are the dampers where if something happens, or heating or smoke, it will close automatically. Sometimes you have fire and smoke damper together. Now, if I ask somebody how many dampers you have in the hospital, nobody will. No. Before also I didn't know till I till I learned it. Say, in a 500-bed hospital, maybe there will be 100 dumper. Maybe this is only lump sum. Air changes. How much should be the air changes in room like this per hour? And you think for nurses, if a nurse here, or for doctor here also, air changes in a room like this, or a normal patient room, air changes per hour should be around 6, 5. In the OR, how many air changes should be per hour? That's why I said we have to know our hospital. This is about 20 air changes per hour. That thing we have in the ventilation, the circulation, تغير الهواء 6 مرات اللي في الغرفة كله، وتغير 20 مرة في غرفة العمل. في عندك الفنتليشن سيستم تيار كذا. We talk about negative pressure and positive pressure. Humidity, we talk about that. Redundancy, you have to have water supply storage in your hospital. You have to calculate that. Fuel storage, you have to have 96 hours the fuel storage available. For security, abduction, elopement, security, your system there in the hospital, how to know if if a child is abducted or not. There is need to make sure people can figure out designing for patient flow, really very important. You don't want to see people lost in a hospital. How many times you find people lost in a hospital? Signage is very important. It should be clear and simple to follow. Because during emergency, there is no time to be lost. Time is gone. You see, designing for emergency management or required by World Authority. Now you have to, when you're designing, you have to make it that you can convert your area to a patient room. Now, particularly in this time for a disaster, COVID patient, whatever, for any disaster, you have to be ready to convert it, not to have only offices closed half of the time. I can put outlet there for oxygen, for everything, that I can convert it to a patient room, particularly in the ER. We should have big areas around the ER, like meeting room or whatever. Ergonomics for the staff, and bending and climbing to have things, shelves, another lifting is a cause of worker injury. Back injuries for nurses, really, it's very important. Back injuries is also cost for the organization, because they will stay at home. I have to pay them. It's not only because of that, I have to look after them actually. Bending for fall prevention. Should I stop here? Yes. Yes, and we continue. So we will be coming back to this presentation, yes, with the other thing. Any question till now? Thank you, Dr. Asad.
Actually, there is a point that I won't say 90% from the hospital or healthcare facility. 90% from the healthcare facilities here, not only in our country, other countries also, they're not designed from beginning as a hospital for healthcare facility. They take in a residence building and they convert it to hospital, and they stay work, and there's much work they have to do. to start on. First point, when they design this one, most of the key things they start design hospital from beginning, from scratch, from first plan. They care only for the medical side. They don't care for admin side. They don't care for the store, for disease basis, for imagination, presentation. They stop everywhere using the corridors, sometimes using the stairs to stop some points. I agree 100%. But if the authorities here, the city authorities for the country, UH, EHA, MOH, if they consider all the standards what you mentioned, they will close 90% from the hospital in the country. Anyway, I have only one point. For the carpet, because for the infection control and practically, I have doubt to use the carpet in the hospital because there's difficulty to push, for example, the wheelchair.
Yes, I know.
And also for infection control, it's very difficult to clean than the other
There is now HEPA filter vacuum machine. Yes, I have for that. If you choose to have the carpet, but it's better you have the.
Yes, this is my thought. For me, I want to choose the carpet. I choose the other than this is only one point for the village, but it's very interesting. Thank you.
We have to know our hospital.
Yes, sure, but not everyone. Thank you.
I'm Sarah. Amazing presentation, to be honest. I work in the healthcare compliance, and when we go and inspect actually on facilities, they do look at the. I work in Saudi Arabia, so one of the things that they go and inspect is the building, is the equipment and the design, as you said, the corridor. All of these are really important. I mean, yes, a lot of hospitals they don't really when they actually commission the hospital, they don't pay attention to these small details, but they do make a difference in the staff life, the patient life, and infection control, all of these. So amazing presentation, to be honest.
Yeah, thank you.
Hi, Dr. Mohammed. That was so amazing. I'm a nurse from the United States, and I didn't realize all these challenges in building a hospital. My question to you is, do you see in the future part of the design is to have like wellness programs for nurses and physicians and residents due to the high rate of like burnout and compassion fatigue? Do you see that in like future designs?
I think we have to look into that. There is no other way. We have now. It is time to. It's about time to look at it. At the end of the presentation, there are 5 points, summarization of all these things. What you have to consider when you are planning a hospital. But well-being should be considered because they will think it is costly. It's not costly. It is cost-effective.
Thank you.
Well, thank you, Doctor, for this interesting presentation. I've worked as a staff nurse in UAE for 11 years, and it's the first time for me to know all this personal information. It was never disclosed with us when we are staff in the hospital. And now I'm working in education institution, and I have one question now. Is there any future plans for educational hospitals? Because we do struggle when we go to the field, with the students, to the hospital to accommodate us.
Well, I hope that now I am retired. That's why I was before I'm CEO of the hospital. I was struggling and fighting for such at least to reach some of these things. But now I can only through presentation to encourage people to do that. But believe me, at the end it will come to it. But don't reveal the secret, please.
All right.
This was very valuable. Some of the information I know about, but some of them I'm not sure. Something I want to say in our hospital, it's a fairly new hospital. We've got like a disease. They are the people that some allocation they do. So you can't take this room as a storeroom. But the storeroom we have is a small little thingy. If you look at the people who come and check the hospitals, you can't have a box. It's international on the floor. Where do you want to put it? In my room, at my house, where in my car, because there is no space. They make these big places, but then they allocate you only to work in a certain area. It's not enough. And it's like it was very interesting. You said that you must not walk so far to get consumables. Why are we walking?
Exactly.
10 kilometers sometimes one day I'm walking while I'm working. It doesn't make sense.
Yes. Many things. One hospital it was built and they did not have any place for the administration of nursing. When I reached to be the CEO of the hospital, I took one of the villas for housing and put it for nursing. The health authority, they, oh, this is violation. I said, okay, it's a violation. I don't take it for myself. If you find some place for the nurses, I am happy. I will evacuate it. But since I did it, it is 8 years and they're still there, the nurse. They could not find any other solution. You have to have يعني a CEO have the courage يعني الشجاعة يعني what I'm going to lose. You tell the truth and خلاص. And then you are gone.
Last comment. There is one point, first for the teaching hospital, there is one teaching hospital now, licensed through DOH, and also Mobile, and also they require or they asking in hospital eligible or ready to be teaching hospital, but the most important, what they teach inside, this is the point. Second point, Doctor, you mentioned when I make my presentation, does the CEO and the top management, they know? This is a big question also here. Because the top management always, when coming to the hospital design, they looking only how many clinics we have, how many IV room we have, but they're not looking for the other spaces near the store, or the other, as I say. This is the point. Does they know you retire, but does they working for this one? As I told you, it's a very, very big, serious issue. That the top management, they're not looking for this, they're looking only for these 2 points. How many room, how many clinics?
Okay, let me, I'm sorry, but I have to comment on that. Because really, I have many discussion with authorities. We should not always blame the authority. Not always. You know why? Because they don't get the real information from us. That's why I don't overwhelm the people with data, indicators, and this indicator. And then you will lose the most important indicator. If you have bad indicator, tell the authority, I have this bad indicator because of this and this. They will try to help you maybe. But if I blame them only, well, they will not help me because I am only make up for my results to show them, oh, Allah Mubarak, he is good. Look, how nice this figures and nice presentation. He has hand hygiene of 80%. We know it's not 80%, maybe it's 30%. To satisfy, but we are actually cheating them. We have to tell them the truth. And then it will change. It is also a culture in reporting.
So thank you very much, doctor, and may I present you with this certificate? Thank you, sir. Thank you. Which one? Okay. So may I now call upon Miss Talia Al-Yafei. She's a nursing instructor at Fatima Health College, and she's going to talk about occupational hazard among nurses. It's a study that she had done in 2019 in UAE. So please, ma'am. Welcome. Let's give her a big round of applause.
Good morning, everybody. Well, my name is Talia, as I was introduced. I have worked in UAE hospitals for 11 years as a clinical experience. And I've worked in the University of Sharjah for 7 years as a clinical instructor. And now I moved to join Fatima College. Almost I finished 1 year as also a clinical instructor and a lecturer. Well, I'm happy to share with you the result of the study that I have done in the hospitals of Ras Al Khaimah. It is about perceived occupational hazards among nurses. And I think this is going to be incongruent with the presentation of patient satisfaction. And I was so happy to see the presentation about the patient satisfaction. And I think this presentation is going to come in alignment with that. So one of the most important points, I'm sorry, what's your name, doctor? Dr. Isam. Yeah, as Dr. Isam said, to increase the patient satisfaction, we have to dig and find the information related to. And I believe if we have increased the satisfaction of the nurses who are directly in contact with the patient and who are directly supervising or dealing with the patient to increase their satisfaction. So I have a strong belief if the nurse's satisfaction is high, then patient satisfaction will be also high. So let us proceed. The outline of this presentation. Okay, first I'm going to give you the introduction, then there is a background information, what have been done in other countries regarding the occupational hazards, what was the objectives of this study, and what was the literature review that we have looked at, what is the conceptual framework was used for this study, the methodology, result discussion, the conclusion, and finally the references. The introduction, I have taken or quoted Florence Nightingale as a pioneer in nursing, and it was about the act of utilizing the environment of the patient to assist him in his recovery. As Florence Nightingale believed that we should give a room for the environment to act on the patient to help him recover. So this was what guided me to take this study. And the background information was that the health and well-being of employees and in the working place are important concern for any organization. And nurses in particular, they are the direct caregivers for the patients. And so their well-being is needed, all right, to maintain their standards in relationship to the patient's care. Second, nurses also continue to report high level of job-related injuries and illness at work environment. Working environment and responsibilities of nurses put them in the front line of numerous occupational hazards. And this is proven through during the pandemic of coronavirus, which all of us witnessed that. Also, there are virtually endless occupational hazards for nurses in the workplace, regardless of their place of the employment, wherever they are employed or hired. And the categories that we have found internationally, and not limited to, but these are the most occupational hazards that the nurses are facing, which are physical hazard, psychological hazard, and social hazard.
The physical hazard could be defined as a bodily pain, any kind of aches, like the nurses all the time are complaining of, mainly, as Dr. Mubarak have said, backache. This is the main occupational hazard related to nurses. Psychological hazard, it is the negative self-perception, especially when they have lots of load in the work and they have shortage of staff, then they're experiencing burnout. And most of the time, this burnout has no room to be ventilated because they will be threatened. If they're going to ventilate that, they will be at risk of losing their job. And social hazard, like most of that, we know that nursing is a female dominant job. The majority of the staff are females. And the female, she is not also a nurse, she is also a mother, she's a wife, she's a daughter-in-law, okay? And she's also a daughter, she's a sister. So she's playing multi-roles. Being a nurse, it really put her in a social pressure. So this is one of the most important things. What is the significance of this study? So when I revised the literature in United Arab Emirates, occupational field or hazard in occupational jobs is not that much focused on, all right? And according to the literature, in the United Arab Emirates, we don't have much of studies done, or I can say there was no study done on occupational hazard among nurses in particular. So the gap in literature has to be filled because of the following reasons. So this study, what added value it's going to give to the country? It will enhance the knowledge and the practice of occupational health safety and issues among nurses. It will contribute to nursing research in the United Arab Emirates, generating the understanding about occupational hazards among nurses. Then this will hopefully contribute to return nurses by enhancing health work environment and maintaining high quality of patient care. What were my objectives? To identify the types of occupational hazard perceived by nurses working in surgical and medical units in Ras Al Khaimah hospitals, and to determine the association between the area of work and the type of occupational hazard. Then the third objective was to determine the association between selected demographics and occupational hazards. I hypothesized that there are different types of occupational hazards that the nurses are exposed to. Second, that there could be an association between the area of the work and the type of the occupational hazard. Third, there is an association between selected demographics and occupational hazards. This was the occupational framework that I have used from the system theory, input, throughput, and output. And my input was the healthcare providers at Ras Al Khaimah hospitals, the work settings which I have chosen, and the input was to assess my physical, psychological, and the social hazards, and demographic, it was used also, and the other types of the occupational hazards to be assessed. Then to identify or find the association. After that, if there will be any intervention to be taken later on, and we are going to measure the outcome. This might be in my second phase to measure the outcome. Then reviewed the literature, we have found that there is around 92.5 studies that showing there is a physical hazard among nurses. And in section 2, there is around, there is psychological hazard. And I was finding that the study which took place in Egypt interesting because they found that they analyzed and found there's occupational hazard among 125 nurses at Cuna University Hospital. And the first includes the socio-demographic characteristics of the studied nurses. And the second tool, they use the same tool, which is the work-related stress scale, which was used for their study. And I have adopted that same scale and implemented here in United Emirates. And the third objective, which is the section of social hazard, and that study which was done in Saudi Arabia, and it assessed the impact of the night duty on the nurses. and how it affects them socially. And the result of that study revealed that 90.9% of the participants reported a social impact due to the night shift, and they couldn't get involved with so many of the family occasions. Then the methodology, it was a descriptive cross-sectional study. The population was from hospitals of Ras Al Khaimah. The setting was in 2 different hospitals at Ras Al Khaimah. Sampling technique, I have used the convenience sampling method, and the sample size was 246 because my population was 396. So I tried to make it 250 to be closer to the population side. So my result will be more general, to be able to generalize the final results. Then I have used 2 main tools: demographic characteristics of the participants, which was developed by me, and the work-related system scale, which was adopted from other studies. I've done a pilot study to find out what are the primarily obstacles that I might encounter. But after the completion of the pilot study, the study actually took place without any modification, so it was easy to proceed further to finish the study. The data collection, all the let us say ethical approvals was obtained, and the study took place. So the demographic profile, I can say that we have found that 82% of all the participants were female, as it is expected because nursing is a female-dominating, let us say, career. And when we assess their educational level, 88% of the nurses were, with God praise, majority of them are bachelor degree holders, and very few were still having their diplomas, and 2.8 they're having their masters, but I couldn't find anybody who was higher than that in their educational qualifications. And we also find in their designation, majority are having qualified nurses. Then when we came to section B, which are the occupational hazards, I found that there is a different types of occupational hazard among the nurses in our hospital, which was in relation with the literature that I have reviewed. And there is different there is also an association between their work area and the occupational hazard that they are encountering. And here, as we can see, that the physical hazard are having a p-value of 0.01, which is significant. And moreover, there is an association and the psychological hazard, which has also a p-value of 0.01, which is also significant. And there is an association also in their social hazard, and the p-value was also significant. When we come to the association between selected demographic data and the occupational hazard, the selected demographic I have chosen were the gender, the educational level, and their year of experience. And occupational hazard among nurses in surgical unit, it had a significance of p-value less than 0.05, which is also significant. Then let us proceed to the discussion part, where nurses are exposed to different types. This comes in congruent with a study that have done by Sabra and Morsi in 2016, which took place in Egypt. And I like that most of the studies that's coming from Egypt to really confirming what our nurses are facing, because Egypt is one of the Arabic countries, which I said we can compare to. Like when we compare what we have to what's there in United States or in UK or other Europe countries where they are much advanced than us in nursing section. So I don't find it reliable. But when we are comparing what we are having to Arab country or Gulf country, I think it is more confirming to what we are having. Then we found that the sleep disturbance, musculoskeletal pains, sharp-related injuries, violence are the most physical hazards among nurses in United Arab Emirates. And for that, the working units have a p-value of 0.01 more in pediatric unit, all right? And that covered 27.5% of the total sample that I have studied. We'll come to the musculoskeletal pain. It was the majority of the nurses are complaining of musculoskeletal pains, in particular low back pain, and that covered 42.1% in the entire sample that I've taken. Also, the sharp-related injuries. Still, Mr. Mubarak, we are having sharp-related injuries. Okay, and it encountered for 54.9% from the total sample. So, though all the efforts have been done to limit the needle stick injury, but still we are having it. Violence, especially in the medical surgical unit, and also in male, it was in the emergency room. Lots of this, it's around 52.4, and followed the medical unit 25.1. Then we found that there is an association between the working unit and the different occupational hazard, which is psychological hazard, sadness and giving up. It's because of highly shortage of staff and lots of workload and lots of things to be met. Like we have to meet the KPI of the hospital. We have to do in-service education. We have to cover the load of the patients. So all these things make the nurse to have a burnout because they have to do it. There's no other option because they cannot spare, which put them in great psychological pressure. And me, myself, I have witnessed that. When I worked in the hospital, I worked around 3-4 hospitals when I was staff nurse. Nobody bothers, sorry to say, about the psychological aspect of a staff nurse. Okay, so what I believe that the psychological aspect of a nurse is very important if it is really taken in consideration. All right, so if the nurse is really satisfied and happy when she's doing her job, of course it will reflect, as I assume, on the patient satisfaction and on the entire KPI of the hospital. Then there's an association also in the social hazard, which was the insensitivity toward others. I noticed that as a human being, that if you encountered something really painful to the patient, we will have some empathy, isn't it? We will. But I noticed that as nurses are exposed to so many pressures, psychologically, physically, socially, mentally, they will lose that bit of empathy or the feeling. So they will become insensitive. They don't feel to say to somebody who have lost their patient or patient passed away, I'm sorry for you. They don't give a reassuring, they don't give any, they don't show any empathy, which is really, it's really alarming. We are losing our human sensitivity toward others because we are really overwhelmed with what we are having. So this study found that most of the nurses are having insensitivity toward others, and this is in accordance with the study by Ismail and Muhammad, also took place in Egypt in 2016, and it's proving that this kind of occupational hazard is really occurring among our nurses. Then association between the selected demographic data and the different occupational hazards. I've selected the age, the educational level, and the years of experience, and found that there is no significant difference between the age and the type of occupational hazard. And educational level shows that there is significant difference between educational level and physical hazards. And the more educated, staff, more qualified staff, it will really help to reduce these type of hazard because only they can prevent it if they are knowledgeable about it. And years of experience, there is significant difference between years of experience and the type of the occupational hazard because as they become experienced in the area, they know to overcome things or prevent things from happening. And in conclusion, to conclude my study, nurses working in surgical and medical unit, they were exposed really to different kind of hazards, and there was an association, as I have just shared with you, between the working area and the 3 types of hazards. And there was no association between the gender and the 3 types of hazards. And there is association between the educational level and the years of experience and the 3 types of hazards. This is the study, this is the result, these are the results, and here is the references for all the studies I've done, and thank you so much. Any questions?
Thank you very much.
Welcome.
It was really a very insightful study.
Thank you.
And I see some hands going up.
Welcome.
So, great.
Well done
Thank you.
for the study. And there is two comments. First comment that I feel that you make this study by your heart.
Yes. Yes.
Which you can explain, you explain not for me, you explain all the meaning for this one. And this leads us to the next point. I see your study is focused only in female nurse. There's also male nurse, is a father, is a husband, is a brother, is a son. So why not you include the male nurse in your study?
Well, male nurses were included, but in fact, we don't have enough female nurses to have male nurses. And none of the male nurses, male gender, are interested in a profession as a profession because of many barriers. Actually, the total number of the male included in my study were only 2%. That's why I said nursing is a female-dominant occupation. And we are really calling and welcoming male gender to include us and be our partner in. Yes, please.
So we have a couple of more questions.
This was actually so beautiful put together. Your study is so important because no one focuses on well-being of doctors, residents, and nurses. And we're coming to understand now in the United States that we as nurses are suffering from post-traumatic stress disorder, from the violence we see, the assaults we get, the emotional abuse, and then other things, witnessing death, accidents, post-COVID, symptoms have increased in nurses, and they're at the level of post-traumatic stress disorder.
Right.
And you brought up an important point about the insensitivity, and I just wanted to add that that comes from post-traumatic stress disorder. We detach from our patients because we're overwhelmed, and unfortunately others that don't understand post-traumatic stress disorder or acute disorder think, you know, she's a mean nurse. Yeah, she didn't even know I pressed the bell. They came 10 hours later. I never see them, but they don't realize it's just a symptom of this stress disorder that we actually detach from what's going on. And that's a protection factor for us. But excellent study, Talia.
Thank you.
Definitely keep on going.
Thank you so much.
It's nice again. This is very important because my whole thing changed from this to more wellness. And we must look at the most of the people that are working in these. There are a lot of expats. And what I see in the unit where I'm working with most of the staff who are Filipinos, some of them didn't see their family for 2 years.
Mm-hmm.
So what is easy for people above who says, you don't want to be here, masalama.
Exactly.
They are the people who are manning the units. They are the people who teach the interns. Because this is what we do. We help and assist. And you can't go home because the flights are closed. So we see a lot of people go to England, go to America, go to Ireland because I can have their family together. With COVID, we see this very, very eminent. And what she says is PTSD and post-traumatic disease disorder, depression. We see suicide. We see staff just don't care anymore.
Turning over. People are changing their major, they're changing their discipline. They don't want to keep their work as a nurse.
That's what I did. I worked 37 years. I did 23 years in critical care. I'm changing my whole career because of this. I'm tired.
Me too.
I'm tired.
Me too.
And this is reality. And it's actually bad if younger people start doing it. We are older. Sure, it's okay for me to change. But younger people start changing. And especially in critical care and minutes. Very enough. Really enough.
Exactly.
And Talia, your study is similar to what we did in the United States. The more practice a nurse has, that she's in practice in the hospital over 15 years, she's able to deal with the stressors more than a young nurse coming in.
Exactly.
And the newcomers that are coming in, the young nurses, there's a high percentage after they're in practice, they leave the profession totally. So just think all that, you're a nursing instructor, they're with you 4 years, studying hard, they hit the hospitals and they leave in a year because of everything.
Yes.
So we will take the last question. And after that, we will have a short break.
Thank you.
Let's do it.
First of all, I want to thank you. You have a very good English. But
Thank you.
you know why you are tired? She said she's tired. Because you are doing things which you shouldn't do it as a nurse. You have to watch the staff ratio to patient. In some hospital, you will see 5 staff to 1 day. But you see in some luxury hospital, 9 staff to 1 day, including whatever it is, MC staff. And the problem that we are really assigning nurses to do things that we do. That's why also the quality of care will decrease. Because we are giving you another responsibility. But when you compare your study with Egypt, Egypt, they are all Egyptian nurses, 90%.
Exactly.
But you have is multinational.
Exactly.
But you come also to the same conclusion. They have the same thing what you have. And this, again, she mentioned Filipinas nurses, Indian. Really, I don't know how to appreciate them. Because I know that from my hospital. When it comes to absenteeism, we have a big problem with absenteeism among the national, not among the expat. Who will cover? The expat. Who will cover? The expat. This cannot work. We should educate our people.
Yes.
Thank you.
Thank you so much.
May I now present this certificate of
Thank you so
appreciation.
much.
Thank you very much for such a stimulating conversation. Thank you very much. We will have a short break for coffee, tea, refreshments. We will come back here sharp at 11 a.m. So welcome back, and we will be resuming our session after this short break. And next up, we have Mr. Majid Al-Ghazal. He's from Ministry of Health, and he's going to speak on digital healthcare. So, Mr. Majid, please. Welcome, sir. Please come.
I think the last one, right? It's in the last one. It's an issue. This one's clear.
Sorry, I did not read.
No, I tell you that one's clear, but I don't know now. Inshallah, it's only different than now the
Okay.
title is not sure, but okay, it's okay. No.
Can be.
Yeah. Okay. For the yeah, for the title only make
Oh, it's not moving. So can you continue with this?
No.
So you can just click this one.
Yeah, okay. Yes. Assalamu alaikum. How are you, everybody? Good afternoon now. Good morning. It's still now 11 o'clock. Mr. Majid Al-Ghazal from the Saudi came from the Ministry of Health, Cluster 1, E1 from the Eastern. My job, the project manager for the science and KPIs in cluster for all BHC, especially for BHC. Today, I think, for me, I am the first one outside. I make the presentation, but maybe I tell you, I will not fixing that one about for me coming to here, tell you what the problem and what the solution. I think all BHC, they have one problem for data, how to collecting, how to make it, which the one for me, for which one that collect the data, from where collecting the data. They have one big problem in cluster E1. Cluster E1 means that for now the new name for the ministry, for the E1. Under me, 138 BHC, also plus the 81 from Al-Hazard, A2, cluster 2. They both have the big problem for data, how to collect, about no system doing, no file electronic. That's why should be coming in the strategic is bad coming. Sure. They have one issue about how many patients have diabetic, how many patients have chronic disease, how many patients hypertension. When collecting from the BHC, one by one, give me 200,000 patients. It's nice. Okay, now we will make it for strategic for that one. When we make it strategic, that one, starting from 1/1/2020, you will collecting 200. I will follow that one for 200,000 patients. Until the last year, 30/12/2020, only collecting from the 138 BHC, only 35,000. About the difference between the first January 2000 and the last only collecting 35. That's why asking where is that patient? That's why the important here using the digital for health. That's here a very, very important. Then I make it one systematic. Okay, you can using for everything. For me, I make it solution. For now, when you see here, that one I take it that picture from the online. But for me, each one system I using and make it applying where in under the BSc. Everything you see here for breath monitoring, for BP, for everything, that one, when you go in there, you can see that one. For each the patient have blood pressure machine by monitoring. When coming the half, when you check the patient, the BP in the room, when coming the high, the one message coming to him, ask him when you are take that medicine. If he said yes, I am taking the medicine. Before how many? Then came in for him again one message. Ask him when, before how. After if he the machine, ask if the systematic see that patient has the some wrong, he will give him appointment from the wait. He give him the one appointment should be coming tomorrow in the 8 o'clock, 9 o'clock. What the available for him? One appointment. That one for chronic. That one using. That one for touching the patient. That one for importing or digital health. That's why using Fmea in the BEC, in the cluster, that one using. Then the patient, he likes that one. Then he say, if not available, I can pay. But just coming to him, to me, they make it for that one, and for contact with that my system. Then he said, goodbye. For monitoring everything, that's why I tell you for blood pressure. Also, the diabetic patient have one machine by also connecting by the system. That's why I'm very rest. If you are asking me, okay, that one, how many guide working? That one should be needed the team. But I have one email, but now I cannot be used. One email, he said have one problem in one area in Canada, here in Saudi. He said have some problem for like that, for touching the patient, how to collecting, how. But the answering from the ministry said, there is one IT team in E1 cluster, you can talk with him how to make the solution. Then coming one team to me, but he don't know who will meeting with who. When I come in there, he asked me, where is your team? I said, yes, me and table and chair. That's one team. About really have big problem for patient diabetic, for our patient for chronic. Big problem, that one. For following, for also for proceduring for treatment, but for me, I am not responsible that one. But I doing for one sheet or one program, he doing for everything for doctor. The doctor said, I am very tired about writing everything. Have that you are smoking or no? Yes. You are make like you have a cardiac family. That's why for me I doing for him one sheet electronic. Just put press. He will give you for that. For the one, what's the level and what the number for him for segmentation. Also, he will give you when can patient that coming back after 1 month or 3 months or 6 months. He will give him appointment also, and he will alarming before 3 days for appointment, and also before 1 day for appointment, and plus 1 hour before appointment. Yes, that I think last meeting with me about one doctor, he said that I have big problem. I said, why? He said, I have between the ADA for that evaluation and my data. Then I touch him where this that one problem. I see if the patient left from your PC, you are giving him the appointment. He said no. Just I tell him go make it coming after 3 months or 1 month. I said that's one problem. If you are made for appointment about that one, I said for importment for digital health machine. If you are make it for him appointment, that one for reminding the patient, then patient he rest inside him. He said yes, that one doctor here, he followed me. Then he shy from you. That's why he coming to you. Maybe he will not coming. He will calling you. I say if patient not coming, not show that time, okay, you can make another reschedule for him. But the important for evaluation, the patient have every month or what the systematic said. I tell him you are not under you about same before by papering. There is 5 paper, CMR1, CMR2, CMR5, then like that. Then I know that correcting result. Sure. About every for result coming 1.2.3 and also for hypertension. When I doing that sheet, the one cell have 250 formula. About he bring it what the good and correcting number and correcting the segmentation for patient, which the level. That one all this one I tell you how many patient you thinking now written to whom I said goodbye. What number? Give me the number for I said for diabetic and hypertension patient. From 35,000 in the last year, I tell him bye-bye. When I saw the data, when I put the data under fixing about the import, but how? By hand cannot be. That's why using by digital health machine. I will take it the program, put in the data, he will helping me. Just give him 1, 2, 3, 4. He will give you the clear data. I know some people or some employment say, no, cannot be. Some patient like coming without, he don't know. Yes, he don't know make it appointment, no, he didn't know have the registration. Help him. When I talk with him in the 15 seconds, I tell him, now I do for you, you can see mobile, I do for you registration and appointment. He said, yeah, really. I said, now see 15 seconds only. About the system, just put for him ID, then he will give you the date for all details. Then just press, just choosing which the date. That one very little for the timing, and also for he did the patient, he will go complain, calling the 999 or 937 for the ministry about that one. He will not help me. Really? Sure. That old patient, old age, sometimes you don't know really. If you are not helping, you are tired in the last time. Sure, you are in the last time. That's why we can make it for every digit. I tell him how many now system it with you. That one I put it on one system. One doctor said you are magic system name. That's why I put my system magic system. The name first is about put it in the data. He will give everything about patient. Everything, what you need from the patient, from 18 details, he will give you anything you want. You want control or not control, you want the patient even pregnant. The important patient under me, pregnant patient, vaccine patient for the one child for 2 years and 6 months. Also the hypertension. That's why I like it that people. How to when they put the system. That's why I tell you I am not see that one, but I will reading in that one by one. when you are putting that one about, for me, I am in the back for my certificate nursing, but in the never fight paper. One time coming to me, how that boy that day or that time, I am changing for my mind. One patient came to me, said, my daughter already here delivered before 10 years. Please give me that number for him. I said, how can be? For me, I am not here in that hospital before 10 years. Then also, I will check in paper by one by one. But I said, okay, I have legal side. I said, what? I said, after 5 years, I throw everything. But he knows about me not throwing. But I have official paper, can be throwing. Then said, no, he will go the press that area, then becoming official paper should be do. I stay with the 20 register in one room in hospital for checking if be one by one. About I want to search where is that, when they coming that patient, when coming, when deliver here, give me the number. After 15 days, I stay with the 20 register. I am not going to home. I am not searching that name. I call him that time. Please, brother. Oh, I want to call you before 3 days about you. My daughter not deliver in your hospital. I said, what? What? You know how many days I staying in that room? 15 days. That's why I lock that room. Then I eating that key. I not give you that key, that room. Oh, this my now he's sitting with me for 15 days. That's why my life. No, really, I am not giving that about that. That's why from that time I'm changing my no, stop the paper. If the government, if the ministry not give me to me one system about my area, no have patient, no. I will do from my pocket. Really, I doing for my small system under me, two hospital and 5 BC. When I going to hospital, I say, no, this is one official. I said, your pen now official from ministry. He will tell you using that one. No, the ministry said using Parker 400 riyals by Berwell. This one not official. But I lucky after 3 months, they accepted from ministry my system for following that patient, the important patient. I put the name in my area, the big PHC. Not I want to be a PHC. I put it big PHC. If the patient, chronic patient, pregnant patient, about should be I need from the pregnant patient 4 times visit, right? That's one KPI is needed. But if that one pregnant patient going to 4 BHC, I lose it in the 4 BHC coming down in the KPIs. That's why my system putting for when any patient going to where you will show the name and details. The government there, so for the system, that one E1 using one system, E2 using another system, the E3 using another system. That's a problem for the patient. If me going to Riyadh, cannot the patient, my daughter giving faxing about he not have any details in the system. He will say, where is the card? I touching in my cloth, the card cannot be the card, the paper. That's what you say, why not using the system? For me, I'm doing that's one. I make that project name Mawrid with the ministry for should be that system big system. Then all HIS coming inside. really coming to that one. Now, I said for the patient, I tell the patient that one throwing for the paper, for card the patient. If any doctor or any nurse asks you, where is that one? Tell him, I don't have. Please open the system. But I know the name, I know that one. He will not do me. That's one important for digital health. Sorry for about presentation. That one I can give you the free, but needed sure that at that one I will tell you about everything. That one important. What important for digital health? What he give to me digital health? How touching the patient? I have one big dashboard, very, and really I am not telling about very nice for me, but when I am sleeping in my home, he will tell me, get out, you have red point with you. Red point coming in the map, he told me, where is that patient coming? What's the problem that patient in my dashboard? Every doctor, he have that one in pocket. I tell him, please, same tawakkal now. Give me your mobile, I will see the dashboard. Should be with you or no. About he will come message to you. If you are near that PC, should be going to him. The last projector for me, clinic virtual. All this one in COVID, this is very nice for me about monitoring for BB, monitoring for diabetic patient, and also for virtual. The virtual in the publication there, how to do that virtual. You will see the patient, what you have, fever. Okay, take the Panadol, take that one, right? Then he will make prescription electronic. Okay, you can ask him, where you will live? Maybe no, don't have any pharmacy. He accepted the electronic what? About only one farm or two farm income. That's why maybe in the area no, didn't have, really have many area. Didn't have. I'm changing that one mind for virtual patient. Should be the virtual patient. He's going to one doctor in the same area. He's sitting with him. You are for consultant, right? Talk with the patient, but the doctor he doing everything for him. Prescription about the same area, papering or what? Also, only ask him for that one for hypertension. That one, okay. I have medicine green color. I have tool. Have what was green and yellow about that patient? He had only for designing for the medicine for him. That should be needed for result or needed for analysis for blood or anything for lab. How you will do for him? Virtual, only virtual for prescription. No, should be doing for him. That's why I'm changing my name for virtual. Then in digital health for me, I put it that one. Now you will start this. And after 1 week, that another project can be the doctor doing every order, then coming one code number to patient going to any BHC there, he will give him the code, then he will printing everything for him, then he will doing for that one. About the patient said, right, I am need rest in the home for make virtual. About I have the card, yellow card for every medicine for me. I will show the doctor, he will give me. When I have one team calling in the center, he called that patient. You are today coming to the BC? Nice, how are you? No, alhamdulillah, that doctor, he will help my daughter, he give him the medicine. No, tomorrow coming to me. The doctor, he will think, he will coming to where? I will make investigation with him. Why you are give the medicine to daughter without checking that one patient? How knows that patient? I am not giving you that I am sorry to tell you that the by patient 12,000 patients from diabetic, and hypertension. I tell them, goodbye. Going to home, please. Don't take medicine no more. It was 1,000 patients. After make that procedure, the patient, the two from that 12,000, my ankle. I don't know about your father and mother, grandmother and father. You are not diabetic, not chronic. How you are come to him? And that's one important. How come to you when checking that diabetic five? You are taking medicine. Yeah, 5. How many months you are taking the medicine? Sure, both the under program. You checking that one, everything. Say goodbye. 12,000. That's not a big number from 35,000. That's one important for digital health. Sorry about for that one, but I think only writing generally any things about internet for me, outcome in economy, platform. Just I will show you about what the important for digital health for the people. That one, but for me, big important, not for the patient. Maybe the patient he don't know for what the important. For me, I know everything, but I working only me in E1. I have 4 people now with me. Alhamdulillah, that one, and I choosing who that guy can be, who like the number. I want this one guy, he like the number. I want when he show the number, he knows where he show that number. Not only he put the formula, sometimes the formula comes checking formula more time. You will not see any issue. But when you see the data, you will saw one data coming tool, that one short. That one, that's same. Sorry again for lecture. Sorry. Yeah. Okay, thank you. Okay, only that one I'll tell you about this one, the general things for what the important for the patient and also for me. But I like the digital health. When I saw the patient, anyone asked me, I tell him, give me your mobile. I want to see that how many program in your mobile. I want to see. Give me. About I will put that one about no need coming, no need like that. No. If you don't have that one, sure you will call me every day. You ask me, please make that one, please check. Now I have one clinic name, know the number. When he coming to me, take some for BP and everything. The next day he opened that program, he will see everything for him. Just if he don't see, just put appointment, that one coming. The message, he will give me the number for him direct in her mobile for everything, for heart rate, blood pressure, diabetic, for everything. Sorry again for that one, but that one general for me. I am very headache when doing like that. Do you have any questions?
Okay, so we have a couple of questions. I think maximum 2 questions, please. We are actually running pretty late.
This one, very good presentation. The only comment I have is that we find in the United States, in our nursing profession, this is so helpful, but we have computers all over the units. We're dragging computers all over the place, and the patients feel that it lacks human touch. Now that you're noticing that we're not nurses anymore, there's lack of eye contacts with nurses and doctors with their patients. And like I said, this is all wonderful technology, but we have to get back to, and I don't know how, with the human connection.
Right.
That's my comment.
Yeah. I will just tell you. When in the COVID time, have the issue from the bed, from the big hospital. Then he said, Majid, please come to here, make the fun solution. Sorry, Mike. When I come to there, I saw the bed, but the nursing, he will not discharge that patient from the system. I put another system. Who then included that system? Cleaner. The cleaner I included in that system. Why? The cleaner, he make the round, he will see the one bed, should be he will clean. When he put the system like that, the big number and where the coming yellow color, after 13 minutes, he changing to green, the ER, he will not have one bed. That's why the nursing said, why?
Yeah, we also use something that from our monitors in intensive care, all the data goes through to your tracking. The tracking is a little bit of a problem, but it's also the reporting system and everything. And that, actually what she said, gives us as nurses more time with the patients. Because you don't need to write everything, you just put it through. But I also want to say, if I'm in Emirates now, if I go to any hospital here, I've got all my data on it. So I don't need to say, oh, they can see what my blood results is, my medication is, my vitals.
That's right. That's right. That's one should be from the PEC or hospital. That one. If you want to know what doing your hospital should be, see the system. I will not see the paper. I will see the system. What in the system? I will give you the evaluation in the last year. If you're not doing, I said you are not doing. Sorry, sure.
So thank you very much.
Welcome. Thank you.
Once again, thank you very much.
The last one, anybody want to share from my system or mine or just told me by what I was saying for them, everything free. Free for following the region.
Okay, so moving on, we once again have Dr. Mohammed. Sir, let's give him a big round of applause.
Continue the previous and go quick to the other events. No need because it's too problematic actually. No, I want the previous. Yes, I want the previous. The week to complete it. Which no, this is never events.
Yes.
I don't want mirror events. I want the previous one.
Okay.
We not complete it. You have to complete it.
Okay.
Bring the old one because he is not finished. Oh, I'm muted.
This one?
Hospital design.
Hospital.
Yes. Okay.
I will give you a warning 5 minutes before.
Yes.
You have got 25 minutes.
Which
Thank you, sir.
slide?
I don't know where you go. Next one. Yes, we are here again. Actually, when you are working in the place, the people should know the message of the place. You know, I saw many places with very complicated message. Too complicated message. Let the message be simple for the people. I'll tell you one story. Everybody went to NASA, the United States, Texas. When we came in, they saw a cleaner. They asked the cleaner, why you are cleaning? He said, I'm cleaning to send people to the moon. He knew the message. He knew the message of the institution. When your people know the message, it is also for the safety of the patient. Now we said we'll incorporate the nature. Maybe you are telling you are dreaming, Dr. Mubarak, but this is the truth actually. It should be like this. And it will come, inshallah. Access to nature can produce a number of benefits: reduction of pain, reduction of stress level of patients, staff, and visitors, improving sleep, positive feeling for patient staff, reducing noise. WHO recommends that we should have only not exceed 30 decibel. We are working with 80 to 90 decibel. 3 times the recommendation of the WHO. Strategies: sound listening materials around high noise areas such as workstation, privacy and confidentiality, social support, both for patient and staff. For staff, and studies have shown peer visualization. And they should know see their peers. If they need help, they can call immediately for help. They're not closed in a patient room. They can see. I can see my peer. Oh, he can call me immediately. That's for the safety of the patient. Technology and safety, and you see, we again to Mr. Majid and the files. It's a big problem. Electronic files. It's not everywhere in our area of technology. You see, mix-up of IV lines leading to misadministration of drugs, ventilator disconnection, caught because of missed or set or missed alarm, dose creep. Now, take-home message from this. I wish they have more time to stop in the slides before to explain more about things and tell stories, but we don't have time. But take-home message. Remember 5 things when you're designing a hospital. Equipment dictates design. Design does not dictate equipment. What happened here? Dr. Isam said, we convert one place to a hospital, and then we want to bring MRI, we want to CT scan, we want to do all these things. No. Equipment dictates the design. Design today for tomorrow. Start with design by reviewing key departments: emergency room department, radiology department, operating theaters, and intensive care units. Each of these departments, they feed each other of patients. That's why it's important to have them not far away from each other. Always, while think about PDR, privacy, dignity, and respect of patients. Fourth thing, solve problems with pen and ink instead of hammers. It is easy to, by designing, okay, you can delete, you can, not after building, and then we start with hammers. And always, remember always that you will pay for mistakes 3 times. Once to build it, once to tear it down, and once to rebuild it. Design with caregivers in mind. They should not move more than 25 meters in any direction to get supply. Locating sharp disposal boxes at the site of the injection is a simple measure that has a great impact. Final notes, despite the undeniable tragedy seen since early 2020, a positive is that it has forced the healthcare system to think out of the box. That's what we have to start doing. It is good, you see, negative things can be positive. Okay, can we go to that? Now we will go to the never events. All of you know what is never events, that are events that should not happen. It should be in our control. It is preventable. We have 7 categories of never events. It's about 29 events. I mentioned them simply. And how can we do with a little bit solution to prevent it? Again, here, actually only, don't stop learning. You see, even after I retired, 2 weeks ago, I get my last certification as a CDI, specialist in clinical CDS, certified clinical documentation fellow. Yani, keep learning. Okay. Introduction, we have 7 categories, a few reported examples. It is a nice, I took it from one hospital and I saw it in one hospital in Saudi Arabia. As everyone knows, it is devastating. It is a sentinel event, all. Because if you see 10 JCI listing is, or Sibahi listing 10 sentinel events, but they are under the categories under them. That's why it comes to more. And as long as you have healthcare and technology, you will get more also different never events. Was by King Kaizen, former CEO of the National Quality Forum, who was the one who termed the never events. Only this to see this JCI sentinel events. What is the top 5 sentinel event? Unintended retention of foreign object, falls, wrong patient, wrong site, wrong procedure, suicide, delay in treatment. Is the most, okay. Everybody knows what is this. It is, you see about quarter million died between 2003 and 2005 from potentially preventable mistakes. Many of you know already this graph, pie chart. As we said, we have 29. Could be more, could be less, but it is 29. 5 surgical, 3 product device, and so on. Surgical events. Surgery or other invasive procedure performed on the wrong side. Surgery or other invasive procedure performed on the wrong patient. Simple to proper identification. Proper identification. Wrong surgical procedure or other invasive procedures performed on a patient. Unintended retention of foreign bodies, proper count, fear, too much delegation. Sometimes maybe the nurse, he will not tell. Why fear? I'm a friend of nurses. I told them the time is خلاص, no more. Where is the Mr. Doctor? He is the hero there. It's not more. خلاص. We are all team. We should and we should educate our doctors. لا تزعلوا مني زملائي الدكتور دكتور عصام، يعني دخيلك لما نطلع من هنا. لا. Intraoperative or immediate post-operative procedure death in ASA class 1 patient. يعني somebody coming for 20 years old patient come for appendectomy and he died. كمان الأعمار بيد الله، لكن كمان how come؟ Production device or events, patient death or serious injury associated with the use of contaminated drugs, device, or biologic. There are a lot of stories. Meningitis through contaminated vaccines. It is not only our part of the world, it is everywhere. But if it happens here in our part, we will say, oh, well, because we are, no. Even in the States, in Europe, a lot of these things are happening. We are all human. Patient protection events, discharge, release of patient resident of any age who is unable to make decision to other than also proper identification, hectic environment, patient death or serious injury associated with patient elopement, security problem, nursing supervision, how he could run away from the war, patient suicide, attempted suicide or self-harm, again insufficient evaluation and observation, healthcare provider failure to install functional collapsible curtain in the shower room. It should be collapsible curtain, otherwise he will hang himself, the patient, if he is prone to suicide. We really should take care of postpartum depression. It's a very, very important issue. We have really to notice that. I had one patient who tried to make suicide after postpartum, because postpartum depression, because of the insufficient evaluation of the doctor. Care management events, patient death or serious injury associated with the medication error, wrong drug, wrong dose. How much is coming in? You see, medication safety program, look alike, sound alike. It is in our hand, and we will save life. Training, read back policy, patient death or serious injury associated with unsafe administration of blood products. Again, patient policy and identification. Maternal death or serious injury associated with the labor or delivery in a low-risk pregnancy, well-being, competency, lack of supervision. Patient death or serious injury associated with the fall, again, fall policy, stage 3 or 4. It is a nursing problem. Actually, we should, but not to blame the nursing if we are assigning them to do other things. We bring in the shift three nurses for 20 patients. This cannot be. Care management events, artificial insemination with the wrong donor sperm or wrong egg, proper identification again. Death or serious injury of neonate associated with labor or delivery in low-risk pregnancy, patient death or serious injury resulting from irretrievable loss of irreplaceable biological space. Do you know what happened in one hospital in the States? There was a patient for kidney transplant. Ready, they operate, they put the kidney. But the kidney is a very, very precious thing. The kidney were there. The patient was ready, anesthetized for the surgery, all ready for that. The doctor looked to to hand him over the kidney. By mistake, the nurse threw the kidney in the garbage. It is really, just imagine, it's irretrievable. Yeah. Of course, they close the hospital, they make investigation, all these things also proceed. But look what can happen here. It can happen everywhere. Patient, staff death or serious injury associated with the electric shock. Any incident which system designated for oxygen, they give him some mushkila. This is again another problem with the outlets. Really, the outlets should be really very clear to everybody, particularly after maintenance. Sometimes you want to make maintenance, and sometimes the worker, they mix up. This is very important. And we have such a sentinel event in Saudi Arabia where the wrong oxygen, the wrong gas was given to the patient. Patient, staff death or serious injury associated with the ban. Patient death or injury associated with the use of physical restraint. Physical restraint, you have to have a policy, restraint policy. I can't restrain him for 1 hour, more than 1 hour. And every now and then you have to come and look. Radiological death or serious injury of patient, staff associated with the introduction of the metallic object for MRI. Again, this is again a pediatric neurosurgical patient, again in the States. By mistake, there was their oxygen cylinder. For what, I don't know. And then when they started the MRI, the cylinder flew and hit the head of the patient, of the child. It happens in my hospital. I was CEO. It happens, but alhamdulillah, God, there was no patient there. But I forgot what was the reason. There was an infusion pump or something like this. They wanted to restart the MRI, and it flew again like this, but there was nobody there. But those are serious. That's why it is added to the. As long as you have technology, you will add to the never events. Any instance of impersonating physician or whatever, this is against security. Criminal sexual abuse, assault and battery, death or serious injury, remember, resulting from physical assault or battery. Assault when you threaten somebody, something, this is assault. Battery if you touch him. You have to know that if I threaten somebody with the knife, it's threatening. But battery when I touch him. America had the best, most advanced medicine in the world. 3 episodes involving a doctor performing brain surgery on the wrong side of a patient's head at a large hospital. It's not only in this area of the world. It's time out and marking. All are simple. I cannot say, wallahi, oh, the authority did not give me that. It is only marking and time out. Minnesota became the first state to adopt never events law. Now, Medicare, they will not pay. Insurance company, they will not pay for those events if it happens. Mayo Clinic reported 6 events, including total fatal medication mistake and 1 surgery on the wrong body part. 31 cases involved object left in patient during the surgery. The 5th wrong side surgery on the wrong finger at the same hospital. a lot of things can happen. Again, Massachusetts Hospital reported 36 instances since January 25 in which doctors performed the wrong procedure or operated on the wrong site. Final notes is never events. Whenever they happen, they occur, they are devastating. 71% of events reported to Joint Commission over the last 12 years were fatal. An incident, fundamental safety problem. We have a fundamental safety problem in the hospital. Thank you for listening to me. We could make it a song that about sometimes you have to stop me because I talk too much. I know myself.
Welcome. Thank you very much, Doctor. Do you have any questions? I think everything was very crystal clear. So no questions. Thank you very much, sir. Here is your certificate.
Thank you for the nice audience, really. I have my
Next, we have Mr. Amar Aruri. He's from Flinders University, and he's going to make his presentation online. And this is about, the title is A Synthesis of Critical Care Workforce Wellbeing Framework. So, Mr. Amar Aruri, welcome, sir.
Thank you. Can you hear me?
Yes, we can.
Yes, I will share my screen. Is my screen shared now?
Yes, it's fine.
Yeah, okay. Good morning, everyone. First, I would like to thank the Knights of the UCG conference for all their inputs. And my presentation today is about a synthesis of critical care workplace wellbeing framework. The authors of this piece of work are myself, Ammar Aruri, Sarah Hunter, Hela Daphne, Nurul Dahlia Adnan, and Diane Chamberlain.
Mr. Amar, I'm so sorry for disturbing you. Can you just 1 minute?
Okay. Is there any issue with my audio?
Can you try it now?
Okay. Is it
Yes.
clear now?
Yes.
Yes. Okay. My presentation is about the synthesis of critical care workplace well-being framework. It's a novel framework we have created. I'm the first author, and this is our team of this piece of work. Is it okay? Can I proceed?
Yes.
Yeah. Okay. Today I will speak about the background. In the background, I will tell you about the aims of this study, then the methodology of our study, which is framework synthesis. After that, I will show you our result, the produced novel framework. Then I will speak about the implications of this framework for healthcare organizations and for future research. Finally, I will conclude my presentation. First of all, in the background, the workforce mental well-being audio is not clear. Is it clear now? Because there is a message sent to me that the audio is not clear. Is it clear now? I can't hear any response. Hello? No. Hello? Can you hear me now?
Yes. Yes.
Yeah. Sorry, this technical issue with online conferences or any online using any online interface. Okay. Workforce's mental well-being has become prominent in literature, and which actually created the healthy workplace, which made creating a healthy workplace is essential for healthcare organizations. In particular, when we speak about critical care areas, these areas are complex, challenging, and stressful, especially nowadays with the COVID-19 pandemic. Healthcare professionals in critical care settings are in the front line, and they are facing high demand and high stress in their work. This could lead to more psychological hurts, burnout, moral stress, and I'm happy that my topic is related to the previous speakers. They were speaking about the nurses and healthcare professionals' satisfaction, well-being, the practice environment, which all of these topics are related to each other. And eventually, when we have unhealthy workplaces, that means unhealthy professionals will not work well, which will affect the safety of our patients. Therefore, healthcare leaders and researchers should address both individual level and organizational level interventions. Healthcare organizations have their legal and ethical commitments to protect and enhance their critical care professionals' well-being. However, several studies have revealed that organizational level interventions, programs, schemes have failed to attain these anticipated outcomes, the well-being of healthcare professionals. And we have many reasons, but the explanation actually for these reasons are uncertain yet. Therefore, we are looking for more comprehensive, inclusive, rigorous, practical, and effective frameworks, models, programs that will protect and enhance the critical care professionals' well-being. These programs or the framework that should be used by the health organizations should be embraced in the strategic plans of healthcare organizations, not only during this COVID-19 pandemic, but we should be ready for any future uncertainty like this pandemic. Therefore, the focus of our study, we have two main aims. The first one is to review, summarize, examine, and critically evaluate the selected frameworks and models about workplace well-being and the practice environment. Next, to synthesize a new novel framework, integrating elements from these frameworks and models to best fit the workforce in critical care settings. Our methodology in this study is framework synthesis. We have started by searching for frameworks and models that could be suitable for our synthesis. The search method actually was a combination of different methods in different steps. First, we have done extensive browsing in the library database, for example, PsycInfo, Web Science, Google Scholar, Scopus, to find, and we have used subject headings like framework, models, well-being, healthcare professionals, and other subheadings. With this extensive browsing, we have refined the research strategies. For example, the framework should be published between 2000 2021 and published in English language and other research strategies. The next step was to narrow down by further research, by further search using these refined strategies to find key documents. Key documents actually are documents first published in the literature for the selected framework or model, written by the original author and representing the framework stages or the key stages of developing their frameworks. Then we have done backward and forward snowballing method, reference tracking and citation tracking to find more about papers talking about the framework that we have chosen, to get more idea about this framework and how they built their own frameworks, and the consecutive studies that critique and contrast different frameworks, including our chosen or the chosen frameworks and models that we use in our synthesis. I should highlight that the aim of this study is not, or was not a systematic review or appraisal of our selected frameworks. No, we have just only selected some, or actually we will see 5 frameworks according to our criteria that are related to the workforce well-being and could fit the workforce well-being, the workforce of critical care settings. Selected frameworks that were considered in our study are: first, the dynamic model of workplace well-being, written by Grewich, Ballard, and Erb, published in 2017. Actually, this framework was built by integrating 3 other frameworks, which are the circumplex model of affect and well-being, and the job demand resources model. This is a famous one, and the personal resources allocation PRA framework. The authors here collaborated these 3 frameworks, and we used their framework incorporating our own framework. The second one is the global healthy workplace framework and model, published by WHO in 2010. The third one is the magnetic recognition program model, which was published by the American Nurses Credential Centers. This is the first publication, 2005. Then we have more recent versions. The fourth one is the Pathway to Excellence Program framework, also published by American Nurses Credentialing Center in 2020. The last one is Healthy Work Environment Standards, written by American Association of Critical Care Nurses. The first version was in 2005. The second one is in 2016. Each framework model has a different perspective and focuses on several aspects. I will just speak about some points in regard to these models. First, the dynamic model was the most generic one. It was speaking about factors and the causal relationship between all these factors and elements. That's why this framework was the basis of our framework synthesis, because it was more generic. It was speaking about general elements. Both the dynamic model and the WHO model or framework more inclusive in regard to the boundaries, the context, and the aspects related to the workplace environment. Also, they are targeting broader community. That's why their elements are very essential, because they could target other healthcare, other workforces, or workforces other than healthcare professionals. Whereas Magnet program, Pathway of Excellence, and the Healthy Work Standards were designed for nurses in particular, and they are focusing on organizational commitments rather than other personal level interventions. Finally, the Healthy Work Environment Standards is directed to critical care nurses. So we gathered frameworks and models which are general and some which are more specific and related to healthcare professionals, in particular nurses, and one is related to critical care areas. So we claim that we covered all aspects are related to the well-being of healthcare professionals in critical care settings. What we have done, actually, the approach was a comprehensive examination, matching, few comparing and contrasting, and theme building, and at the end, we have done compilation or integration of these selected frameworks. Our novel framework, the critical care well-being framework, consists of 21 elements grouped in three domains. The first domain is structure. We have three main subdomains. We have three subdomains, and we have a few elements here under this domain. We have first resources. We have external and internal resources. Internal resources are also named personal resources, time, energy, and money, three elements. External resources, we are speaking about the workplace environment and non-work life organizational practice. I will speak more about these and I will give some examples in the next page. Demands, individual differences or individual variations. These are under the domain, the structure domain. The process domain, we have the personal process, which is the resource allocation. We have resources, internal and external, and we have demands. Person have his own dynamic process to face his demands by allocating his resources toward his demand or his issue that he's facing in his own life or in the workplace. The second one is the organizational level. In the organizational level, we have first the core value and ethics cultivation. Every single point should be considered in the strategic plan of the healthcare organization. So we are speaking about the core values and ethics of the hospitals. Then when we speak about programs or schemes that are targeting the workplace well-being, either individualized or non-individualized. The third element is adopting a systematic process. This should not be haphazard. It should not be done haphazardly. It should be done in a systematic process. Finally, the outcome of the healthcare organization is either patient outcomes, organizational outcomes, or organization outcomes, and workforce outcomes. And we are considering workplace well-being in the category of workforce outcomes. This is our framework. As you see here, I just want to choose the pointer. As you see here in this framework, first, if you look at the circle round, you will see this is the systematic intervention. We mentioned here adopting a systematic process. So systematic process means to mobilize, assemble, assess, prioritize, plan, do, evaluate, and improve. So adapting this process in every single program that we conduct in hospitals. Now here, the green lines are related to the personal or individual level interventions, and the orange one is related to the organizational level interventions. We grouped the themes or the elements based on resources and demands, rather than including, for example, the workplace. In the workplace, we have demands and resources. This is a different approach of categorizing elements related to the workplace environment and well-being. We made the categorization based on the demands, then the resources. So we consider the work environment or the workplace environment as an external resource. And every demand that we face in the workplace is under this category, demands. The person, every person and every employee in the workplace area has his own different has his own different social and familiar issues that could affect his demands and internal resources. His own familiar issues. Is he a parent? Is he or she have any social support? Have any extra money that he can spend and allocate when he needs some rest and have a few days vacation from his workplace, etc. So we are speaking about that persons are different, and we should consider that when we design and when we conduct any workplace program. Here are the external resources. When we speak about the workplace environment, we categorize them in 4 environments: the physical one, the psychological one or psychosocial, the professional one, the leadership. For example, when we speak about the physical one, we are speaking about the space, the noise, we are speaking about the safety of healthcare professionals. Psychosocial one, we are speaking about recognition, the emotional feeling, the feeling of belonging to our department. Professional environment, each single healthcare professional should have programs to develop his skills and be competent. The leadership, we are speaking about here the transformational and authentic leadership. Okay, we will be explaining the framework. The relationship between elements will take more time. Just I highlighted some examples related to the workplace. And here, when we speak about the workplace environment, and when we talk about the outcome of healthcare professionals, we are targeting actually their well-being. The implication of this novel new framework to the healthcare organizations. First, it will help in addressing and efficiently resolving disruptions related to the critical care workplace environment. Rather than applying a collection of separate programs, they establish a long-term, I mean the health organization, they should establish a long-term comprehensive policies and schemes and cultivate the value of the well-being of their healthcare professionals in the core value and ethics of the healthcare organization to promote the workforce well-being. Our framework draws attention to the importance of the organization's proactive nature to approach workforce well-being. We should not be just reactive, we should be proactive to promote the well-being of healthcare professionals and to target each single person in our team. Optimizes the organization's ability to effectively respond to any fast-moving crisis, such as this current COVID-19 pandemic. We claim that using the framework will optimize the organization's capability. For future research, the implications of our study, it gives several opportunities in terms of content and empirical validation to refine and further elaborate this framework. For example, the critical care workplace framework will provide a tool for a qualitative synthesis of a mixed systematic review. We have started this mixed systematic review. We have done about 70% of this systematic review, and we will use our framework in the thematic analysis. Actually, it will be framework synthesis and thematic analysis together to analyze the mixed systematic or mixed method systematic review. And this is part of our large research or our larger research. Also, this framework requires statistical evidence for further validation. We need some statistical evidence, and this evidence could be longitudinal, which will extend our framework and will give more validation to our framework. In conclusion, the framework is the first integration of various aspects influencing critical care workplace well-being from 5 previous frameworks and models. It considers all work-related and non-work-related aspects. It provides the basis of interdisciplinary decision-making. It's not just related to nurses, not physicians, interdisciplinary team. So interdisciplinary decision maker, they have the opportunity to address the subject of concern, which is the well-being of healthcare professionals, and to guide the individual and organizational level interventions. We claim that our framework offers the best fit model for any size critical care settings in any country. It should be embraced in the organization's missions, values, structures, and policies. Utilizing this framework or optimizes the organization's ability to effectively respond to any fast-moving crisis, because we are ready. We are embracing the well-being in our mission and our strategic plans. So we'll be ready to any fast-moving crisis, any catastrophe, any pandemic in the future. Especially now we are facing the COVID-19 pandemic and any uncertainty and any future uncertainty. Thank you. And if you have any question, I'm ready.
I was wondering if there are any questions from the audience here or anybody in the chat. So I really do not see any questions here. So thank you very much, Mr. Amar.
Thank you, Doctor.
Yeah, thanks a lot. So next we have Ms. Sahar Alakul, and she's going to make an online presentation. She's from Johns Hopkins Aramco Healthcare, and she's going to talk about cost effectiveness and outcomes with early or same-day discharge after elective percutaneous coronary intervention in Johns Hopkins Aramco Healthcare. So Ms. Sahar Alakul.
Yeah.
Hello.
Yes, we can hear you.
Good
Hello.
morning.
Good morning.
Okay. Let me share my screen first.
Yes. Are you able to do that? Yes.
Can you see my screen?
Yes.
Can you see it now?
Yes, it is visible.
Yes.
Can you make it full? Please enlarge it.
Okay.
Yes, perfect.
Good morning, everybody. My name is Sahar Abdullah. I'm the data manager in Heart and Vascular Institute in Johns Hopkins Aramco Healthcare. Today, my presentation will be about cost-effective and outcome of the same-day discharge after elective PCI in Heart and Vascular Institute at Johns Hopkins Aramco. So as we know that the major goal of treating ischemic heart disease is to reduce the angina and improve quality of life and ultimately reduce mortality. The medical therapy can effectively address this aim, and still much research and debate about the role of percutaneous coronary intervention in treatment of this spectrum. So the data supporting revascularization for survival benefit came from the patient who underwent of bypass prior to the introduction of the effective medical management. Although both physician and patient continue to believe that the life-saving ability of coronary artery stenting is there. So we went to the PubMed data analysis basis study, over 760 studies, and then we minimize it to 30 observational study and 7 randomized study. It turns out in the research that 1.2% are discharged post-PCI was successfully demonstrated in these studies, in spite of the fact that there are a very low rate of the adverse event and uncertain benefit of keeping patient to stay overnight after the PCI. So in my presentation, we will just show the proof of that the same day discharge post-PCI is just safe as the overnight stay. It's just the people that use traditionally to keep the patient overnight, and it's the fear of starting a new practice. So, as I say, the research provided that a same-day discharge is feasibly clinical practice with significant potential saving to the healthcare. Same-day discharge is not currently standard care in Saudi Arabia. However, there are published reports successfully done this task. The same-day discharge program outside of Saudi Arabia has shown added benefit based on the evidence of the research and the given investigators. So my report period time frame is from September 2019 to September 2021. The total patient in the day surgery is 788 patients. Total PCI surgery patient is 648 patients. Total percentage of the discharge patient through the same day discharge of the cardiac catheterization was 82.25%. The total successfully discharged after we implement this program was 35 patients. The percentage of the same day discharge is 10.9%. We can see that there is a decrease in some numbers, and these decrease in the below schedule, it can just be labeled by the quarantine and lockdown that affected the whole world last year. And the total percentage of the same day discharge complication was 0. So the aim to evaluate the outcome of the same day discharge following percutaneous intervention versus the overnight hospitalization. Starting the STD program is largely 1-1-1 criteria for the patient, hospital, and the cath lab operator. From the patient side, they can go home and stay with their family in the same night. Hospital can save the bed resource and do not incur the reimbursement observation cost for elective PCI and the cath lab physician can potentially reduce the unnecessary service with the overnight stay. The same-day discharge for selected patient, it may lead to hugely reduce the healthcare cost and the increase patient satisfaction. So our aim from this to increase patient satisfaction first, to evaluate national trend in the same-day discharge, a significant reduction in a hospital stay cost, compare the clinical outcome with those among patient admitted overnight, post-PCI for stable angina, and implement safe clinical practice, improving inpatient bed management and reducing hospital-acquired infection, of course, and reduce the non-value operation. And we have showed for these patients that were selected in this program that the complication rate was extremely low. The methodology, so if we start the SDD program, it should include some planning in regards to prompt the provision of oral antiplatelet medication prior to discharge, and patient and caregiver education, and ensure close follow-up for the patient post the procedure. A written hospital policy should be described the criteria of same-day discharge and ensure that no patient who want to be observed will go over this reference. Ideally, the facility starting SDD program have a multidisciplinary team who included interventional radiologists, coronary care staff, and hospital administration, pharmacists, quality staff, and IT staff. Discussion with these individuals allowed them to share their opportunity and to share the insight, examine concern, and ensure the success of this program. Each of these group that identifying the role of the SDD program and show their responsibility and how it will be changed. And their input were essential and qualified with a different pathway in Johns Hopkins Aramco. The post-care staff nurses would be needed to adjust their care and facility of the patient. And we make sure that all the nurses know the new pathway that the patient should be discharged within 6 hours, including the criteria for selecting PCI. So I will share here our inclusion criteria for selecting patient of SDD. It shows that it's divided to 3 factors: a baseline demographic factor, angiographic factor, and procedure factor. If we go to the baseline demographic factor, it's mentioned that the age should be less than 65, living with 40 kilometers in the center, and blood sugars should be less than 250. The creatinine clearance should be above 60 ml per minute, absent of active congestive failure, stable CAD, and the LVADB should be less than 30, absence of significant valvular disease. The angiographic factor, the PCI not involving any protected left main, proximal, and bifurcation, and vein graft lesion or signal vessel supplying the heart. For procedure factor, we make sure that we have absent of major complication of significant hemodynamic shift, and there is no GB or 2B or 3A infusion following the procedure, and complicated vascular access with successful deployment of the closure device. The post-procedure factor is we should make sure the safety of the patient, ability for the patient to ambulate within 5 minutes, and absence of any complication, which is significant bleeding, and any complication during the insertion side. We should make sure that the patient have a working cell phone with him for a post-procedure follow-up care, to call him, and a family member to carry up the patient. And here I can share with you the Fmea, which is the failure mode effect analysis, and the journey for the patient that we have just established. The quality metrics and the data definition of each metrics that we have to evaluate post the program. And here there are some quality outcome. that we should just measure it and watch it after the implementing the program, the quality metrics following up of the STD. So in the results, we can confirm the safety of STD of PCI demonstrated provided that selected patient has discharged with a low risk. So the STD program was performed for 35 patients, and the total, if we compare the financial cost, the total overnight for the 35 patients is 265,790 Saudi riyals, and the same day discharge, it's cost that 188 and 20 Saudi riyals. So we can see the difference between the same day discharge and the overnight stay, that we have cost saved for 77,770, which is around 23,000 US dollar. And this is over only 35 patients. And if we see here the service saved, we can see this is the step down, saving cost, and this is the nursing cost. So as the improvement of our performance metric is not the financial metric, so we go through improving the patient experience. We implement a patient satisfaction survey, which is contained of 8 questions, yes and no question. And through that, we want to see the feeling of our patient, their satisfaction of being discharged within 6 hours. Also, we extend after our successfully implementing this program after 1 year. So we extend our inclusion criteria to be extend the number of distance, and the age will go up over 75. Distance is more than 40 kilometers instead of 40, and multiple stent excluding the left main. Thank you. Any question?
So thank you very much, Ms. Seher. Do we have any question here from the audience? So there are no questions here from the audience, and I also do not see any questions here in the chat. So once again, thank you very much. We appreciate your presentation.
Thank you.
Yes. Any announcement for the lunch? Okay. Yeah. So who is next? So next up, we have Dr. Noha Ghanem, and she's going to make her presentation online. She is from the General Authority for Health Insurance, and she's going to talk about medical error and patient safety. So let's all welcome Dr. Noha Ghanem. Dr. Noha.
Dr. Noha, are you there?
She's muted.
Yeah. We're not to wait.
You can go. No, I am searching for other speaker.
We are searching for the next one, Mr. Mir.
Dr. Noha, can you please unmute yourself? Are you there? Dr. Noha, are you there? Yes, she's there. No, she's not unmuting herself.
She's not giving any response. We are texting her.
Dr. Noha, are you there? Yeah, it's your presentation time. Please, can you hear me?
Miss Lini is there. Online.
Okay, then we'll have a lunch break. Then Dr. Sahar can continue. Oh, sorry, Dr. Noha can continue her presentation.
Dr.
Hello. Assalamu alaikum. Hello, everyone. It's with a great pleasure to welcome you to Day-3 on 10th Nursing Healthcare Patient Safety Conference in Dubai. I hope you're enjoying the network and debates for a morning presentation, and it's my pleasure to sharing the chairing position with my friend Freya and starting the online presentation now with Dr. Nuha Ghanem. Let me introduce Dr. Nuha first. Okay, first the speaker for the online presentation after the lunch session will be Dr. Nuha Ghanem from Egypt. She's a total quality management manager of healthcare insurance clinic at General Authority for Health Insurance Quality Manager at Ministry of Health in Egypt. Her presentation will be about medical error and patient safety. It's such an honor to have Dr. Nuha as a speaker for the second time. Dr. Nuha, the stage is yours.
Good morning. It's a pleasure to be with you for the second time. Now we will talk about medical errors. Could you please let me share my slides?
Yes, please. Click share screen.
Okay.
Perfect.
Patient safety is a serious global public health issue. Estimates show that the developed country as many as 1 in 10 patients is harmed while receiving a hospital care. Even though evidence are limited in developing countries, the probability of patients being harmed in hospitals when receiving a care might much be greater than that of the industrialized nations due to a number of complex reasons. For instance, a report claims that the risk of healthcare associated infection in developing countries are up to 20 times higher than in developed countries. Occasionally, when people receive a healthcare errors associated with the care may result in a serious harm such as death, disability, and additional prolonged treatment. In addition, it may also cause indirect healthcare costs or productivity losses. It also affects a customer perception, attitude, and trust. On the other side, it may also affect the provider's confidence and integrity. Freedom from accidents injury due to a medical care or a medical errors, it would be the simple definition of patient safety. A medical error is defined as a failure of planned action to be completed as intended to be used a wrong plan to achieve an aim. Errors can include problems in practice, products, procedures, and systems. There are two main causes of medical errors. It could be human or system. First, the human factors. The problem associated with the healthcare providers include variation in training, experience, fatigue, depression, or burnout, diverse patient, unfamiliar settings, time pressure, communication error, or system failures, such as in healthcare delivery, include a poor communication, unclear lines of authority on physicians, nurses, and other care providers. Complication increase as increased patient to nurse ratio. Disconnected report system when a hospital inadequate system to share information about error and so on. A number of healthcare organizations and government agencies have a list of medical errors on which they focus, but on 7 discussed there appear across the lists. The most oversight organization and are the ones most commonly encountered. Medical events, healthcare associated infection, surgical errors, laboratory errors, patient fall, pressure source, documentation or computer error. Medication events are medication errors as the first one. The National Coordination Council for Medication Error Reporting and Prevention defines the medication error as any preventable event that may cause or lead to inappropriate medication use or patient harm. Common causes of such error includes poor communication, ambiguity in product name, directions, or use, medical abbreviation or writing, or procedures or technique, patient misuse because of poor understanding of the direction of the use of the product. Number 2, adverse drug events. Adverse drug events are harm resulting from the use of the medication, include allergic reaction, side effects, over medication, or medication error. There are 3 main causes adverse reaction. It may be as many as 2/3 of all patients visit doctors, resulting in prescriptions, and there are more drugs and the combination of drugs being used than ever before. More than 4 billion prescriptions were filled in 2017. At a trial pharmacies alone, nearly 10 prescriptions per person in the United States. ADRs increase potentially when patients are taking 4 or more medication. Number 2, healthcare associated infection. Healthcare associated infection are some of the most common complications associated with hospital care. The National Action Plan to prevent the healthcare associated infection adopted the following 6 priorities: catheter associated urinary tract infection, Clostridium difficile infection, central line associated bloodstream infection, MRSA, surgical site infection, ventilator associated pneumonia. In July 2004, the Joint Commission enacted the Universal Protocol with the requirement to perform a time-out prior beginning surgery, practice that has been shown to improve the time work and increase the overall risk of wrong-side surgery. Developed through expected steps to preventing the wrong side, wrong procedures, and wrong person. The Universal Protocol accredited hospital, ambulatory care, and office-based surgical facilities. Wrong side, wrong procedures, and wrong patient errors are now considered never events, a medical error that should not occur. Laboratory error. Up to 70 of the clinician decisions are influenced by the laboratory tests, indicating that the clinical laboratories have an important role in helping to reduce the avoiding medical errors and improve both patient safety and outcome. 5 causes of testing-related diagnostic error. Number 1, an inappropriate test is ordered. Number 2, appropriate test is not ordered. Number 3, appropriate test result is misapplied. Number 4, an appropriate test is ordered, but delay occurs somewhere in the total testing process. Number 5, result in appropriate appropriate order test is inaccurate. A customer's has best protection is to be informed. Now we are there. Now here's the problem can rise and what to do. Ask to avoid these problems. Make sure that the right test. Ask why it is not why this test is being or not being ordered, and the result will what will add to my care, and what will be the risk. That will help the doctor to decide. Use the right sample. If the test is relies on patient provide sample, be sure you understand how correctly collect the sample. We should help the patient to do that. Inform him how to collect the sample right, and to handle it, and to care about it after collecting it. Understand that errors can happen even under the best conditions. Your best defense is using a reportable lab to employee verified method. Understand that your result is contested. You use a trusted information sources for details. Patient fall. Patient fall is defined as unplanned descent to the floor with or without injury to the patient. Such fall can result in fracture, laceration, or internal bleeding, requiring additional health care. Research has shown that close to 1/3 of the falls can be prevented. Falls happen for the number of reasons, including number one, person is weak, tired, ill. Person is not physically fit. Person may have a problem seeing. Medicines may cause weakness, sleepiness, confusing, or dizziness. Sleepy or wet floor or stairs, obstructed byways, darkness. What can individual do to reduce their risk to fall? The Joint Commission provides guidelines targeted towards the patients at home and in hospital for nursing facilities. At-home guidelines including number one, turn on the light when you are enter the room. Don't walk in dark. Make sure that your pathway is clear. Use the handrail and the staircases. Sit on a chair, don't move, and have the armrest to help you when you sit down and when you stand up. Wear shoes that have a firm, flat, and non-slip soles. Don't wear shoes don't have a back on them. Reduce the the rubber tips of cane or walkers when they become old. For patient setting guidelines include use your call button to ask for help setting out of bed or feeling unsteady. Ask to help going to bathroom or walking around the room or hallway. Wear a non-slip socks or footwear. Lower your high beds and side rails. Talk to your doctor if the medicine makes you sleepy, lightheaded, sluggish, or confused, and ask to reduce these side effects if they can to another medicine. Pressure ulcers. Pressure ulcers, sometimes called distributed ulcer, pressure ulcer, fissures, areas or of damaged skin caused by staying on one position for too long. The commonly form where bones are close to skin, such as ankles, back, elbows, heels, and the hips. Patients are at risk at the bedridden or wheelchair or unable to change their position. Pressure sores can cause serious infection. Some of them can be life-threatening. Because of muscle and subcutaneous tissue are more susceptible to pressure, including injury than skin, pressure ulcers are often worse in their initial appearance. Pressure ulcer can cause considerable harm to patients, hindering functional recovery, frequently causing pain and developing a serious infection. Pressure ulcer can also be associated with an extended length of staying, sepsis, and mortality. Preventing pressure ulcer. Preventing pressure ulcer entails two major steps. Number one, identifying the patient. Number two, implementing preventing strategy for every patient. Basic prevention of pressure ulcer involve number one, keeping skin clear and dry, changing position every 2 hours, using a pillow or products that relieve pressure. In a healthcare setting, key change recommendation how to guide include inspect the skin daily, manage moisture on skin, conduct pressure ulcers admission assessment for all patients, minimize pressure, optimize nutrition, raises risk of all patients daily. Documentation errors. Central of many types of medical errors are issued by documentation. While illegibly physical handwriting is over-recording and shorting errors or omission can have a serious consideration. The American Health Information Management Association identified the top 4 documentation errors as a disaster. Number one, mixed messages from physician, vice versa, misunderstood dictation or illegible handwriting. misuse of a copy-paste or a copy-forward function in the electric health record, incomplete or missing documentation, misplaced documentation. After identification of the most frequent error, the next step is putting procedures in place to prevent them. In response to their needs to increase patient safety, change to pay for performance programs, and closer monitoring to the outside agencies, clinical documentation improvement. Programs are growing, making changes to training healthcare professionals in a new habits is challenging and critical. Thank you. Any questions? I hope my lecture will be informative.
Thanks, Dr. Naha, for your informative and important topic. Actually, I have 4 small questions for you. Let's start with the first one. What are the most common medication or medical errors are faced at your organization?
Commonly, يعني literally I screened the prescription of the patient come to another patient, misdiagnosed, and the prescription of a patient, timing and the concentration. I have a patient with the Clexane 18 at 6 o'clock, given a prescription of Clexane 16 at 8 o'clock. This was a huge mistake and commonly occur.
Okay, in your opinion, how do these medical errors affect the working at your organization?
It is fatal. It could be fatal.
Okay, is there any challenges for that, or how it affects?
Excuse me?
How this medication error or how these errors can affect the working flow of your organization?
Yeah, first it would affect the patient. It would be I could lose the patient. This affects the facility, put us put the facility on an illegal possession, and we will lose our integrity, and we lose the everything. We lose everything.
Yes. Okay. How do you think that the healthcare professional can do to prevent the medication error at your organization? And the last question, how can medical error can be improved?
We making an improvement project by making a step by step and document it, and the reassessment for more times. There are more supervision on the documentation of the prescriptions and the intake of the medication, more supervision on the patients in his rooms, more supervision on the workers, or more supervision on the medication prescriptions, hoping we can decrease the medical errors.
Thank you, Dr. Naha, for answering all of my questions and for your informative topic, and for being for us as a speaker for the second time. Hope to see you at our next conference and enjoying our conference now. Let's move.
Thank you.
You are more than welcome. Let's move
Thank
to our next conference. Next speaker from my lovely country, from my country. Let's all welcome Mr. Nail Saudi, a Chief Quality Officer at MedLab Consultancy Group from Amman, Jordan. And he will share with us the MedLab Group experience with managing COVID-19 uncertainty. Welcome, Mr. Nail.
Good morning, all. I just need a second to share my screen, please.
Yes.
Okay, just 1 second.
Okay, you can click share screen.
Yes, and I'm trying to go into my laptop.
Yes.
I can't see it. Okay.
First, open your PowerPoint presentation, then press share screen.
Okay. Okay, can you see it?
Yes, we can see it.
Wonderful. Well, good morning all, and I would like to thank you for taking some time on a relaxing Friday to be part of this beautiful conference, and I'm also privileged to be part of it as well. So today my presentation will be about how MedLabs were basically able to navigate through all the challenges that we had because of COVID-19. And of course, it's still going. So basically what I'm gonna talk about is our experience. So this is based on true stories, as they say. The work has been done by my colleague, Sarah Sharif, and myself. So basically, this is my presentation outline. We are using what we call the lean, agile quality improvement methodology. We will talk about the project and the teams. We will talk about our journey with COVID-19 when it comes to the timeline and the changes that we went through, the challenges we went through. We also talk about the voice of our customer and what is critical to quality. We also did some root cause analysis for the issues that we were having, and we also applied Fmea. Eventually, we will talk about the lessons learned. What did we learn from all this? So just to give you an idea of who we are, MedLabs is a Jordanian company. It is based on group practice. It was born in 1993. We have 56 branches, and I have plus, meaning maybe as of next week, we will have two new branches. We are spread in 3 countries, in Jordan, Palestine, in Iraq and Kurdistan, and also we have about 600 employees. This is what we do in our company, what we provide in services in our company. So we basically are a medical lab testing. We do referral lab testing. We also manage laboratories. We also consult for other labs to get accreditation. And our biggest dream will hopefully come true next year, will be creating the MedLabs Academy. These are our achievements. So our referral lab is accredited by ISO 15189 and also CAP accredited. Our management is accredited by ISO 9001, the 2015 version. And all our branches in Jordan are accredited by a local accreditation called HCAC. And as we create new labs, we also get them accreditation. We also have a plan to accredit our labs in Palestine and in Iraq and Kurdistan. So we're going to talk about the pandemic of COVID-19, which we are still living as we speak. And every time we think it's over, actually it is not. So at one point we were asking, is it real? Is this a science fiction? Is there a conspiracy? And actually some people still think that way. So I'm going to take you back to Jordan, to March 2020, when we had a nationwide curfew. And this lasted from March 17 to April 30th. Of course, the big thing was to stay at home and not actually live with this pandemic. And it's always interesting to look at things and how we are now looking backwards and looking in the hindsight. So basically going to work and we have our habits, waking up at 7, then having the coffee, and then going to work, is actually trivial. Because now it's all about our health, it's all about our well-being, it's actually about having a job and continue to have a job. And what we took for granted when it comes to family gatherings became actually priceless. So you are stuck at home for about a month and a half. You cannot see your friends. You cannot see your family. And in Jordan, this was really the big topic, is we were all glued to the TV at 6 p.m. to hear about how many cases we have for that day. And this was interesting. So this is the Minister of Interior, and he is actually the spokesman for the government. And this is the Minister of Health then. So if we go back in time again, the first case was discovered in Jordan in March 2nd, and the first death documented was on March 20th. There was really a big hoopla, even when the first case was discovered, because somehow we thought that Jordan is immune. And we also thought if we have a nationwide lockdown, then definitely the pandemic will not hit us, or actually to minimize it. So as of a couple of days ago, this is the global numbers, and this is the Jordan numbers. Okay, and as you can see, the ratio is pretty much the same. But in Jordan, we're getting very close to have a confirmed cases of about 1 million. So let's talk about med labs. And let's talk about journey, which, as you can see, is not easy. Going to different directions, try to meet customer expectations, try to serve your community, because that is really the expectation of a company like ours. So we decided actually to document what we have done since March and until now, our journey, by discussing this with different sections of the laboratories, different branches, different departments that we have in admin. And we decided to package all this as we went along in a project called the Lean Agile approach. So what is Lean Agile? Well, let's try to divide them. Lean is actually a systemic approach for improvement of quality by identifying and eliminating waste. Okay, we have to be very rapid when we do the changes, and it has to be always on continuous basis. When it comes to agile, okay, is basically trying to do what you're supposed to do in a very quick manner, and also be able to respond to what is happening around you, or else you will not be able to catch up. Okay, so the process is flexible, and we also have to understand the changes that are happening. And with COVID, as you will know, there were so many changes that are happening. A lot of regulation changes. Even the prices were different at a certain time. Yeah, also the customer and their demands, they're traveling tonight and they expect the PCR test to be done in 2 hours or 3 hours, and so forth. So if you want to identify waste in healthcare, okay, we can talk about all these different things, which I will not take too much of your time to discuss. But as you can see, waiting is a waste, the motion is a waste, over processing is a waste. But I would like to really focus on this aspect. Untapped human potential is a waste. So if we have staff who have potential, and what we do is micromanage them to get things done, or we tell them what to do without giving them the space to do that, without challenging them, then that's definitely a waste. So in the Lean Agile methodology, there's a model, and it starts from here. Customer. We need to know what the customer wants. And I know in healthcare, this has changed drastically, because in businesses, in manufacturing, they always listen to the customer. And somehow we believe that the patient or the customer has not much choice but to come to us, whether an institution like a hospital or a laboratory, and we don't really treat them as customers, that they need to be satisfied. Okay, so we start with the customer and what brings value to the customer. We look at our current state. we go and analyze the root causes. We come up with a future state, we design where we're going with, and then we start implementing and controlling the changes that we have done and they are working. So we like to actually talk about the problem. What is the real problem that we had at that time? And how did we were able to really evolve with all the changes that are happening? Okay, so what we wanted to do actually is to provide our patients excellent service. Now this comes from two reasons. Number one, we value our patients. We are committed to our community. And number two, we want to make sure that they are satisfied. Okay, the challenge was actually the waiting time. Okay, and the other challenge was actually to keep our quality and safety standards high. And that is very difficult because things can get very chaotic and you start getting things too comfortable. We start not really observing that the quality and safety standards are being implemented. We also wanted to make sure that the cycle time is reduced or turnaround time is reduced. So between the time that we get the specimen until we release it, we did our best to minimize it within, of course, different reasons. We also had to increase our staff and patient satisfaction. So I'm focusing on my staff as well. And I want to make sure that they're satisfied. And why do I have it here in red? Because if our staff are not satisfied, trust me, our patients will not be satisfied. So we also had to look at our staff first and see how they are doing. What are the challenges? Many of them got sick, as you will know, at certain times. They need to go home, then someone else has to come and replace what they're doing. So it is really ongoing. So basically our objective is to improve the process from sample collection to result reporting. Who were the team members? Actually, everyone at MedLabs were the team members. So basically our leadership that starts with Dr. Hasib and his two vice CEOs, the call center, the drive-through, our King Hussein Bridge team, marketing team, IT team, quality and safety, which I represent, human resources, finance, materials management, the molecular lab, and the referral lab. So basically everyone is involved. Okay, so what is our scope? Now we cannot make any changes unless you define what is your scope. And many times we make a mistake and we want to change the world, and that's something really we cannot do. We need to look at something that is very specific, work on it and improve it, and then go to the next and make sure that we have priorities. So our services, and I will talk about this in a minute with some detail, is our house call and booking service, our drive-through service in Amman, and our King Hussein Bridge service, and then the molecular lab. They are all connected. Of course, we have our sample collection team. We have our testing team in the molecular lab. And then we have our directors who review the results and approve it, and then make sure it reaches our clients at the best turnaround time, the fastest way, and definitely make sure that it is secure. It doesn't go to other people. So we have used different tools that are part of Lean, from process mapping to workflow motion studies, to the voice of customer and critical to quality, to the Ishikawa diagram or fishbone, to do the root cause analysis, to Fmea, and so forth. And again, you can see a cycle because they are all connected. So our sample collection services to start with are the call center, where you call our center and you book an appointment, and the team will come to your house or to your school or to your factory or to your bank or whatever, and we get the details of all this as we go in a minute. Then we have our drive-through service in Amman, and then we have our King Hussein Bridge, which is actually the porter between us and Palestine. And we have many people who come back and forth from Palestine to Jordan. Okay, this is a busy slide, but I'll try to make it simple for everyone. So if we have some timeline, Our start date is actually March 2020, then November 2020, then December 2020, then present from May, and then the future. And as you can see in red, these are actually our points that we made a difference. Okay, so basically in 2020, we had no dedicated staff for the call center. And I will explain that to you in a second, because everything basically happened all of a sudden. So we had to create our own call center. We were not prepared for this like everyone else. So in November, what we did, we actually outsourced this the center or this calling or this booking service to other, which is called Crystal Call in Amman. And they helped us really to navigate through this whole chaos of people wanting the staff to go to their homes and collect the samples. As you will know, they were very nervous. There was a lot of anxiety. We created an express team for the elderly, so they don't have to wait. And of course, in November 20th, we were awarded the King Hussein Bridge service to give our visitors and our guests coming from Palestine the service for PCR collection and testing. Another milestone in December 20th was actually creating the drive-through service in Amman. I'll show you pictures of this. And then in May, in the beginning actually of January 2021, we created our dedicated call center along with its staff, so it can help individuals and groups. We went to schools when they opened, and we were able to collect about 500 samples per day. The logistics are really, really complicated because the demand is high, and you want to make sure that you are really committed to your community and service the patients. So what is happening between May 2021 and now and going forward is definitely promote online registration. It makes life easy for everyone, and definitely become a paperless process through QR code. So the call center actually receives inquiries. They ask questions about the test. How long does it take? Excuse me. And how the specimens are collected. And we get appointments for, like I said, banks, schools, and so forth. And then we really assist patients after the resulting. So they will call us back, inquiring about the results, if there are delays for the results, if there is a misspelling on their name and they need to travel. So we have all this service. So the call center process map, as I mentioned, which is part of Lean, has both the before and the current. I'm not going to go through this, but I can tell you the things that are crossed are actually the improvement. So basically what we did, as you read this and I'm talking to you, we decided to actually create our own team, our own call center with all its dedicated team, and having a manager there, which basically have a team that receives the calls and book the appointments. And then we have a team of sample collectors. So we book the appointments when we get the calls, and then at the end of the day, we distribute the workload based on the location in Amman and the areas around them, okay? And then we spread to other big cities in Jordan, like Zarqa and Irbid and so forth. And then we call the patients the day before, and we tell them we're coming to you between, let's say, 10 a.m. and 12 a.m. So we give them a 2 hours window, okay? Now, if we have requests from banks, let's say, or schools, and they have a lot of people or a lot of guests, patients, we go to the site itself, and then we collect them all at one time, okay? One thing that we have also improved is the Google Sheet. We basically created a shared sheet for appointments among those who receive the call. So if I was receiving a call and I book a patient at 10 a.m., if the guy or the lady next to me gets another call, gets a call from another patient, she will see that 10 a.m. is booked. So all these changes are also very important. Okay, one thing we have done also is making sure that the results get to the patients not manually. Meaning, and believe me, this is something we went through with the IT to make the proper changes because we were not ready. I don't think anyone was ready for the amount of the logistics that we have to do. And one of the challenges was actually giving the patients the results. So basically, at one point in the beginning of March, when we were doing about 200 or 300 per day, all the results were basically paper. So we had to actually send them via WhatsApp one by one as a PDF file. Now this has changed. This can be done with a click of a button. Okay. One thing we also have designed is color-coded specimens. Meaning, if I go to a bank and they have, let's say, 50 employees, I will color code all the specimens on the tube with red, because they will be treated as a group for the processing and the resulting. Now, this will actually decrease the anxiety because the coordinator in that bank will start receiving the results, and then some of them will not be received. So we learned by listening to our customers, what is the best way to do it? We also created color-coded specimens for different methodologies, meaning the real-time PCR is pretty much straightforward, okay? But then if someone wants to do, let's say, AIGS, which is a faster test, and they pay more, or if they want to do another methodology, which is also faster, and they will pay more, in the past, they will get all mixed up together. So what we did actually, we created a different path. When these specimens come into the lab, someone will sort them, and they'll say, this is for the group, then it's highlighted, then the tubes are all marked in red, and they will go together, okay? Or if this is an AIGS test, then they're all in green. This way, the patients don't wait for the results, and the rest will go as usual per the PCR. And here we identified all the non-value added steps in the call center, and we defined what part of waste they are. And then we also figured out how is that actually affecting the productivity and the customer experience. And as of today, they were all checked and all taken care of. And this is in the beginning of the pandemic, as you can see the dates, okay? And so this is our conference room in our admin building, and there's also a referral lab, okay? And when this whole thing started, we had to come up with all these different computers and be able to answer them and get booking for the patients. But here's what's interesting. All these staff members are not part of the call center. They were never part of it, okay? So this individual, Asma, works in marketing. Akram is actually the manager for our expansions and projects. Nabil is also a manager in marketing. Shireen is part of the quality and safety department group. Same thing with Lena. And this is one of our colleagues who works in the lab. So all of a sudden, we had to do what we had to do, okay? The whole country was shut down, and we were asking people to come from their home and do what we do and make sure that we are really on top of things. And having 500 calls per day, for those who are not really trained to do it, was actually a challenge, but we did our best. We also did something else. We had to pull all the males, or many of them, from our labs and train them within 24 hours on infection control and how to actually take the specimen so it can be satisfactory. So we created our own, all of a sudden, right on the job, a specimen collectors team. They were all given cars, and when we do the booking, as I said, we will give Malik, for example. Okay, this is Malik. His work for the next day, and he will go out and call the patients and so forth. Now, this is what's happening in the call center. So this is the new call center. Okay, this is one of the rooms where we get the calls. Okay, this is how we organize our day, or the groups, for example, for the next morning. Okay, and this is where we have the data entry and customer service team. And this is our let's say the new, what we did from the first team, they were all back to their work in the laboratories. And then we had to create another team, a permanent team who will do the same job. For the drive-through service in Amman, we got a piece of land which was considered used as a parking, and we rented it, and we had also to create our drive-through. In the beginning, we proposed this diagram, and as you can see, it is not efficient. This is the caravan where we have the stocks, where we also get the samples from patients as a drive-through. And then we thought about this, and we said this does not work. We changed it totally. So we have the cars coming in from the entrance, and then we create two paths, and there's a station here, and there's another station where we do the collection. Here is the payment and the registration. And we turned the caravan into a break room, into also where we can keep the stock. Even the exit, we thought of it, that this is a busy street. If the car stands here and will go out, it's going to be difficult. So we had an angle for the exit. So we actually thought of everything. Okay, for the car flow, when we started and until now, we made a lot of changes. We had manual entry for the data. It became automated and interfaced. Okay, we were waiting for MedLab's couriers to come and pick up the specimens. We actually had our own car in the drive-through to take the specimens back and forth. So we don't wait. So the specimens do not wait in the drive-through until they go to the sample site, which is about 20 minutes away from the collection site. And of course, we turned into the manual resulting via SMS and WhatsApp and even email. And this is the waste that we identified in the drive-through, and they all more or less having over-processing or defects. And ultimately, they were all corrected. This is our drive-through team. This is our tent, okay? And here's the interesting part. This is our CEO, Dr. Hamid, and this is our Vice CEO, Dr. Manal. And this is myself. So we made a lot of visits to different sites to make sure that the staff are motivated and do what they're supposed to do. This is the queue, as you can see, how far it is to come to the drive-through. They will go in, as you can see. This is the first station, second station, and then they get divided and they get served from this side and this side. Our King Hussein Bridge, it's pretty much the same. And these are our guests and family members who are coming from Palestine to Amman. We did some on-site sample collection and even testing. And then for our VIP visitors, we also had a special line for them. Also, we did a process map, the before and current, and without really going through a lot of a lot of details about it, what we did actually is we made a lot of difference with the data entry because that took a lot of time. We made the whole data being interfaced between the mobile when they enter the information on their mobile or through the website of the government into our CareNet or our LIS system. We also added a drive-through, a vaccination check service, and we also created a small molecular lab. So basically we can help those who are traveling the same night and leaving from Amman airport that they have time to get the results. Again, we did a lot of work concerning what was wait. The big one actually was waiting till the end of the day when we have all the specimens, then go to our molecular department in Amman. So between King Hussein Bridge and Amman, there's about 45 minutes or 50 minutes. So the specimens are taken at 9 o'clock in the morning and they wait till 4 until they are delivered to the lab. So we made a lot of changes. We created our own small lab, which I'll show you in a minute. And here is our reception. We made it bigger and all the way around so it can actually help more guests to go in and get the registration and sample collection as soon as possible. And we created another service, which is basically the vaccination check. We created a tent and a waiting area. And this is our small molecular lab for those travelers who would like to leave Jordan immediately at night. Of course, this is done with the maximum quality and safety requirements and compliance. And we actually, as a Department of Quality and Safety, we go and audit them to make sure that they are compliant with the standards. And this is our recently introduced drive-through. We duplicated what we were doing in Amman. And as you can see, we have our own carrier. So basically at midday, they will collect whatever specimens we have and take them to Amman, or those who want it faster, it will get done right there at the site. Our molecular team are the heroes. Okay, they started with 300 tests per day. On the onset of the pandemic in March, they had maybe four staff members. We went up to 2,500 tests per day, and we increased the amount of staff to about 12, operating 24 hours a day, 7 days a week at different shifts. And it is really difficult to get those staff who are really very well trained to do the molecular and PCR testing. So what was the customer telling us? What was the critical issues that are critical to quality? And how did we do the cause and effect diagram and the failure mode and effect analysis? Just to take you briefly, our patients in the beginning were very unhappy with the service. We were really actually unprepared, like everyone else, to give them the service that we like to provide and they expect from us as med labs. So what we did, we actually created the call center, the independent, the drive-through, and also our med labs branches were trained how to do sample collection. So anyone can go to the branch itself and take the sample and send it to our referral lab. Now, all the tests are done in the molecular department in our referral lab because it is CAP accredited. We wanted to make sure they all come to a centralized location and really follow the CAP standards. For the Ishikawa diagram or root cause analysis, we looked at our service failures. And I have to say, I'm very honest by saying service failure. We really cannot hide the problems and keep praying and hoping they will change. Unless we really address them, they will never change. And of course, you have to do this very quickly, okay? So you don't wait for a month or two to make decisions. You have to take the decisions quickly so you can really evolve with the changes and the demands of the staff and also our patients and the government as well. And this is our Fmea. And as you can see, the biggest problem we had is the calls and registration. We were unable to take so many calls in the beginning because our staff are not trained. Even our system is not used to it, okay? And the same thing was sending the results. We also had a lot of challenges sending the results to our patients to be electronic. And in the beginning, many patients will come to the lab and say, I need a hard copy because the airline wants to see a hard copy. Now, all this has evolved, as you will know, to a QR code where you just show it to, let's say, to the authorities, whether you're leaving the airport or you're coming to another airport. So we did a lot of interventions to get our RPN, which is the risk priority number. And as you can see, it is a multiplication of the severity of the issue, the occurrence, how frequent it will occur, and is it easy to detect it or not. So it went from 800 to 150. And here it went from 392 to 150. So what have we done to make this gap really closer? We created, like I said, the dedicated team with a dedicated manager. We moved to a new location. Everything became online, either on website or an app. We interfaced our registration to our LIS system. We were able to cache, the payments through also something, through an electronic website or even cash. As I said, we color-coded and labeled our samples so they will have different paths depending on what is required. And I think that all made a difference because basically it increased and improved our productivity. And ultimately, the results were sent automatically to patients through SMS, through WhatsApp, and or email. So the challenges and improvements we went through, as I said, our phase 1 was between March to November. phase 2 between December and May 2021, and then from June onwards. And in these phases, as I explained previously, we had milestones. So this is a table where we looked at each department, HR, quality and safety, and I'll go through the others. And what were the challenges at phase 1, at phase 2 and phase 3, and how were we able to actually improve them? Okay, and as you can see from HR, in the beginning, the difficulty was getting permits. We had actually to go to the Ministry of Interior and work with the crisis committee that we had to create permits so the staff actually during the curfew can go and collect samples, travel throughout Amman, okay, and also get permits to those who will work in the lab. Now in phase 2, things have changed. The staffing was an issue. So we had to hire immediately new staff, and get trained, of course. Number one, to make sure that we can always get up to par with the demands. And at the same time, we also considered that if some of the staff get infected, which is a very possible thing, then we have enough pool of staff to cover this person's absence. When it comes to quality and safety, the difficulty always was to make sure that we really adhere to the quality and safety standards. So if we opened, for example, and if we had a new machine installed in the molecular lab, it will not start before doing verification. This was not easy to do because they had to wait for a couple of days to get verified, the testing get verified, the instrument get validated, and they can start working. And there's also pressure that we need to get the demands for the patients as quick as possible. But that's something we never compromised. Okay, if we look at marketing, at IT, at for example, our material management department, they had also a lot of issues to make sure that our supply are enough, and those who are expired are sent back to the vendor. We also had to come up with a backup plan to make sure that we work with more than one supplier. And as you can see, each department had its own challenges. Okay, our referral lab had also its challenges as well to make sure that they are able to handle all the demands from patients, whether walking patients to our branches, King Hussein Bridge, which was probably giving the lab or sending about 2,000 specimens, same thing with a drive-through, about 500 specimens, and so forth. So it wasn't easy, really. And if we go back second to the drive-through, winter season was happening in November, December. So we had to actually get another tent to make sure that the air flows nicely and it's not too cold for those who work on it. So we had to think about every little thing. So moving along, especially with the molecular lab, the capacity had to change, starting with 300, going up to 1,200, and now they do about 4,000 samples per day. Making sure that all our staff are trained, making sure the tests are validated, and everything is done really by the book. So if we have a positive sample, we repeat that sample. We don't release it right away. We actually use a different technology, like Gene Expert or AIGS, to make sure that the result is confirmed. Of course, with quality, you have to use indicators. So we looked at our patient complaints, whether it's service related or technical related, the number of calls that we were taking, and the number of COVID tests. So just quickly, I will take you through this graph. And as you can see, the percentage of patient complaints has decreased, and they had different reasons. One of them, they were complaining about the results. The other, the results discrepancy, meaning they will come to our lab, we will report a case as negative, they will go to another lab, they will report it positive. Of course, there are many reasons for that, and we actually analyze case by case why there are differences. So many patients in the beginning of the pandemic, they will feel some, أعراض خفيفة, they will feel something wrong, some clinical, they feel something that is not right, whether they're coughing or or the nose is coming out, or whatever secretions. So basically what we did, so they will come to our lab and it's negative because the virus is not enough there to be shown by the machine, by the instrument when we do PCR. They go to other lab after 3-4 days and it's positive. So they come back and they complain to us. And we show them the quality control results. We explain to them this could be due to the early onset of the disease and so forth. So we would take case by case and really understand what is happening. We write an incident report. And if there was something that we are blamed for, let's say the delay of the result, and someone was traveling and they had to do the test, trust me, we gave them the money back if we felt that we were at fault. And this is all documented. So our patient complaints went down all the way to 3%. We don't expect 0%, as you well know. There will always be complaint, but we try to minimize them. The number of calls in the beginning, it was not documented because they were really out of control. And then, as you can see, the number of the percentage of answering call was 79%. It went up to 89% and currently at 96%. There's a lot of improvement. Our workload or the volume has increased also to up to 67%, going in less than 6 months. Okay, and now we are at this number approximately. Okay, so now I'm going to conclude my discussion and presentation to you with few words. Okay, now we worked as an integral organization, meaning everyone was actually there to help out. We also were very aware of what are the needs of the staff and the patients. We created dedicated teams so we don't overlap. So in the beginning, for me, as an example, as a chief quality officer, and during the curfew, I was asked, or I had to jump in and call the patients. I would make about 200 calls per day and call all the patients who had the results as negative. Okay, we had also to evolve with all the requirements of the COVID pandemic. Of course, we definitely have to be flexible and agile, and we really cannot forget about the support from our upper management. Okay, we had to maintain our high quality standards. We were not pooling samples together. Each sample will go in on the track one by one. We were not pooling. If it's positive, like I said, we confirmed it, and we were very transparent with the patients. If we are at fault, we will definitely give them their money back, whatever it is. I personally gave one of our patients about $700 worth of a ticket because we were delayed. The results was delayed. Okay, and of course you have to have a sense of urgency to make sure that you are up to date with everything that you need to do. So what are our major improvements? Okay, like I said, we created our call center. We had a better structured workflow. Excuse me. And I think the staff and the different departments we were always ready to work with us as a quality department to further improve what we were doing. For the future, we have to monitor our quality indicators. We are definitely auditing. We of course audit all our labs, whether regional or local in Jordan. We go and do unannounced audits, and our collection centers, they also fall under this criteria as well. So we make sure that we give our collection sites and the molecular lab a checklist, and we go and do an unannounced audit, and they have to close all our findings. What have we learned as an organization? And as you can see, these are our different departments. Okay, definitely the quality and safety department had to make sure that the quality and safety standards are being compliant all over, because when you have a lot of pressure, when you have a lot of demand, you start becoming too comfortable and things become very chaotic. Our finance helped us out and helped the patients with an online payment system. Our HR, until today, they keep looking at the staffing needs and make changes and moving staff around to cater to our patients. What about the staff? What did the staff tell us? The first one, definitely empathy. The staff felt empathetic towards their colleagues when they were sick and they had to take some time off at home, or maybe a family member is sick. an elderly is sick. So I will take some time off and someone else comes and do my job or help covering. Our work ethics did not change. Okay, when it comes to pricing, we had to follow the Ministry of Health pricing. Other labs, with due respect to them, were really lowering their price so low to get more tests. And I'm sure they were doing something that is incorrect, or they were cutting corners. Okay, we felt very proud and very responsible to make sure that we cater to the patient's needs. And at the end, of course, we have to appreciate our staff. Okay, and let me read this quote for you. And it says, "A person who feels appreciated will always do more than expected." And that's very true. And the way we appreciate our staff is definitely, going around to different locations and see how they are doing. If they need more staff, HR is very responsive to give them staff ASAP. And in the beginning of the pandemic, we definitely gave our staff who really went above and beyond, and they left their homes in the curfew, a thank you gift. It has some monetary part of it, but also they met with our CEO one by one. And we had different groups coming, and they were all given a thank you from our CEO and a small gift inside, just to tell them that we appreciate all we do. Our molecular team, as I said, they were the champions. This is an old picture, having only a few of them. Now there are 12, as I said. So what happened to our organization? We went from the classical organization where we have a CEO, vice CEO, managers, supervisors, into a flat one. So our executive team will meet online every couple of days because we were all, as you know, we had curfew. And we were always updating ourselves, what's happening, listening from each department. And I would like to say, we had no titles. Everyone does anything, everything at any time. So for example, this is my colleague, Dr. George. He is the head of the referral lab, and he is the chief scientific officer. He was calling patients, me and him. We will go to the headquarters and we will call patients for their results. So everyone did everything. I strongly believe that the quality department is the one who leads all the quality improvement activities. Everyone is busy doing what they're doing. Then we, as quality people, will come and say, let me document this for you. Let's work on improvement. What is happening in your lab? What is happening with IT? We are listening to complaints about delayed results. How can we make them faster? So I strongly believe that the quality and safety department in hospitals, in a lab, or what have you, has to connect with each branch, has to connect with each department, and each individual in the quality department has to connect with each individual in the organization to make sure that the staff are inspired, they keep implementing quality and safety to make sure it becomes a way of life. This will also improve the quality culture. So the quality culture will not change through emails and memos. Our quality team has to be visible, has to be there, has not to stay, in their offices, writing SOPs and receiving calls and going to different places and say, please, you need to implement 1, 2, 3. We have to be there with them. So you change the quality culture through relationships, one conversation at a time. Quality is a journey. This is Ajloon, one of the very beautiful areas in north of Jordan. Quality is a journey. We keep improving, and there's really nothing wrong with looking at our shortcomings, looking at our failures, looking at where we can do things better and keep improving them. It's all about teamwork. This is my favorite team, Liverpool, and it's all about teamwork. One star will not take the whole team. Everyone has to be involved. Now, in times of uncertainty, we definitely have to count our blessings, not looking at the problems. And if we have some humor, it helps. So here it says, this is your pilot speaking, I'm working from home today. Now, the concept of working from home did not exist anywhere, but as you can see, it's becoming the norm. until now. Again, I would like to thank you for taking the time on a Friday. I would like to thank all the healthcare workers in Jordan, in Palestine, in the Middle East, everywhere, about their dedication. They're putting their health on the line, leaving their families at difficult times. And also special thanks to our med labs, superstars. We are all in healthcare, unknown soldiers, doing our best so everyone will stay healthy. These are my references. And this is my email. Please let me know if there's anything I can help out with. If you have any questions or any concerns, please let me know. Thank you again for the opportunity.
Thank you, Mr. Nael, for this amazing, great presentation.
Thank you.
Actually, I saw the walking through or drive through and the services of King Hussein Bridge for Midland, and it was amazing. Also, actually, I met Mr. Nael at the third quality conference in Amman, was on November 2019, and his presentation was great as usual. So thank you for having you with us for today. If you have any questions, please write in the chat box or raise your hand. Let's check the chat box. Actually, we don't have any more questions. Thank you, Mr. Nael, for your time, and hope to see you again.
Thank you.
You are more than welcome. Okay, let's move to our next speaker, is Ms. Lenny Matthew from India and working in Saudi Arabia. She's a registered nurse and a quality specialist at Saudi Arabia, and we'll talk about change management. So welcome, Ms. Lenny, and finally we met.
Thank you so much, Amal. I hope you all can hear me. Am I audible?
Yeah, we can hear you.
Okay, let me take 1 second to share. Amal, yes, finally I'm seeing you. By the way, thank you so much for helping me out, contacting me, and making everything super easy.
You are more than welcome, dear.
Okay, I know that you all had a heavy lunch and probably feeling sleepy, and that too on Friday. Well, I'll try my best to make it short and sweet. I'll not take your time. I have hardly 15 slides. I'll finish in 50 minutes. Super easy and fast with one example. Well, I'm a nurse, as Amal told, I'm a nurse by profession, but recently joined in quality. And why I'm in quality is just because I get a lot of support from my management. And that is the reason I took quality all on a sudden. And coming forward, I'll tell you that I recently joined just 4 months back, and my management here is so supportive that they agreed, and we are on the process of 2 accreditation, Sibahi and ACHSI. So that means you know how much pressure is there on my shoulders. But my colleagues and team are so supportive, so I'm able to do it little by little. Now I'll tell you the change process with the example. And when you are new in an organization, you get a lot of resistance. You cannot change everything all on a sudden. You need to get the support from the staff, build the trust, everything. Well, moving on, I'll be today taking about the concept of change agent, explain the stages of change, list various strategies in change management, and finally the role of a nurse leader in change management. Whether it is a nurse or a doctor, it doesn't matter. You as a leader, what should be your strategies to implement the change? Now, talking about change.
Can you move the second slide?
Hello?
Can you please move to the second slide? Only we saw the first slide.
Can you see this one, second slide?
Actually, no, we only can see the first slide.
Okay, now?
Yes, we can see it.
Okay, then I'll keep like this. So this is like, everybody, I hope everybody can visibly see this one. Yes?
We can see it. Go ahead.
Yes, okay, thank you, Amal. So let me talk about what is a change before I go further. Change means any deliberate action designed to move an organization or a part of it from one state to another, okay? Any improvement requires change from what is there before, then the change is happening, lot of stuff involved, and then to the change, okay? It is important. So whatever change we make, especially in healthcare, especially when it comes to hospital, it is very necessary that those changes are according to the country where we are working, to the population or to the patients we cater, so that there is a connection. It's not that we are bringing something which is practiced in another country to this country. It may not work. Not every time it will be successful. So understand your culture, understand your patients, understand what type of people are coming to your service, and then make changes which will be easier for them. Anything you do should be simple and easier so that people can relate very fast. When it is complicated, people don't accept so easily. So when you want to make people to accept it, make it the simplest way. Personally, I believe that you can create things complicated. It's not difficult, but to simplify the things is more difficult. This is what my feeling is, like my opinion is, to make it very simple, avoiding all the unnecessary things, and to keep the core item is more difficult. Now, who is a change agent? Who can be a change agent? A change agent is a person responsible for moving others who are affected by change through its stages. So he can be a leader or an organization or a policy or whatever it is. It could be government regulation also. Now here we divide change agents into two categories: internal agents and outsiders, and that is external change agents. Internal change agents means basically it comes to the management team, like CEO, managers, managing directors, or administrators, the nurse, even the doctors. It could be anyone. External change agents are investors, your suppliers. It could be government regulations or even the customers, because when the customers complain so much, we need to satisfy them and we need to make improvements. So your customers also can be your change agent, external change agent. Now, government regulations means it could be any policy implemented by the government, by MOH, or if it is in Dubai, it could be HAD or DOH, any agency. Now, when you're going for Sibahi, Sibahi is same like NABH. Here in Saudi, we implement a Sibahi as a accreditation board. So they, when you go for it, it is like basically accrediting your organization that you are meeting certain quality or standards. Now, when you implement that, you need to make a lot of changes from previously what was there in the organization. So these all bring changes in your organization to improve the quality. Going through the stages of change. So Kurt Lewis, he was a psychologist by profession, and he has actually explained this is the most famous version. Yesterday, I guess Nuha Filfilan from Taif University, she was explaining change through another model. There are different models, but I would like to go with the simplest and most commonly used model for change. And it has three portions, like unfreezing, moment of change, and then refreezing. And Kurt Lewis is a person who has formulated this, implemented it, basically to understand human behavior. He, as I told, he was a psychologist. So he wanted to make changes in the behavior of people and how we can make the changes. So he derived this model, and this is now implemented in any change cases now. I hope I'm not going too fast. Now, let me tell you the simplest way of 3 stages. See, suppose we want an ice cube, okay? Now, those others who don't understand the exact features we want, they will say that, why you want to make change? The ice is already there. See, it is an ice. But the ice we have is not in the shape or the size or the way we wanted it. So what we have to do, we have to make changes. That means refreeze it, make change, make it water, and then We may need the eyes in a particular shape, so we have to refreeze it. So this is the basic simple example I can give. I'll take you an daily example of OVR here, what I have faced and how I have made the changes. So this could be better explained the next stages of changes. Now, these are the 3 stages of change and what we can do about it. So here unfreezing again has different stages, movement has changes, different steps involved, and refreezing has. Let me tell you one example of OVR. OVR or incident variance or quality improvement report or incident report, it is known as different name. Now, as I told you, we at KIMS at Danatasara, we are going for Sibahi accreditation. As a part of accreditation, there were so many forms I had to introduce. First of all, I joined few months back, let's say exactly 4 months back only at KIMS. So I am new, people don't know me, and I had to build the trust. But at the same time, as we are on the process of accreditation, I don't have enough time with me to extend it to build the relationship or trust or everything. Now I had to implement it. At the same time, I had to gain the trust of my staff also. So one of the criteria here is that any form you introduce should be bilingual. That means it should be in English and it should be in Arabic. And now, as you all know, that Saudization is there, and we have a large number of Saudi nationals working here. So I had to make this form into Arabic also. Now, when it comes to that, I need to study what was the culture and what was the practice in the organization and how can I change it. When I'm making change, it's not easy that every time you can keep on changing the form. So I had to consider all the things. That means gathering the data. What is the culture, how often we are writing it. So when I gathered the data, I found out that there was a small gap of period that there was no quality person in at KIMS. So, and 1 month before me joining, there were new set of staff who have joined. Now, since for them also it is a new organization, they didn't have the habit of writing OVR. They will just verbally complain to the senior and get the things done, but that is not the way. Anything different from the normal, you should write an OVR. So I had to teach the new staff, plus I wanted to gain their trust also. So I gathered all the possible data about OVR. So first I thought I will start with OVR. Why I started is because I need these data to start training, to start my quality improvement project. All these data, the easiest way is to go and get the OVR. So I know that what is happening, where are the loopholes, where are the issues, where are the weaknesses of the organization. Now I gathered everything, I diagnosed, I understood the problem is, I understood that one is there are new staffs. They don't know if they write OVR, what will happen, whether there will be any action taken against them, or they may be called for investigation or anything. So they were like very doubtful. Second thing, misconceptions among the staff that these OVRs, what they are writing will be kept in their file. No, it will be kept in the quality office only. So I had to make them clear that no, it will not go to your personal file. It will be kept only in the quality office, and this is just for improvement, nothing else. I'm not going to punish you, nothing is going to happen. This is to understand what improvement we have to make in the organization, like that. So all these I had to diagnose the actual issue, what is happening with the staff, make them understand how I can make it simpler, make them aware that this is not for punishment, or I'm not going to take any action or anything. This is only for improvement and training. And okay, if there is a serious issue, we have to consider involving others. Otherwise, I will try to maximum solve the issue at my level and finish and close the OVR. This I had to make them understand. So that comes in unfreezing, where build up trust, make conversation, show can I change the form into English and Arabic, where the local people or those who are like not fluent with English can write in Arabic in their own language. And then I had to develop the new OVR form, whereas in our previous OVR, we had a lot of gaps, like, so much to write, like so much description which was needed. Now they felt it very difficult to write the whole story, what happened, when happened, everything. What I did, I made it into points. Like I grouped the event, whether it is incident, occurrence, sentinel event, or adverse event, and then into category, looking the previous OVRs, what are the common issues, whether it is patient related, whether it is communication related, whether it is medical record related, whether it is a failure of equipment, like that. I made it into small categories where they can just put only tick mark. So no need of writing a big story. They just can put tick marks and then write the issue in one sentence, where it happened, when it happened, and who was involved. Put a signature and give it to me. This was like converting it into a simplest way. So I set a goal and objective that let me make it simple and easy for them. At the same time, I have to keep English as well as Arabic. Now, giving the first copy. So here I wanted the support of the staff and the trust. So I told them this will be the new form, but since I want to get them involved, I told, see, I am not printing into booklet, or you will get only limited copies, as I want to make change. And I want you all to tell me what changes you want in the new OVR form. So they also feel that, okay, fine, they are also going to be the part of the team. So teamwork, making the staff aware that they are also a part of it is really important, and so that you get the team support. So I told them, you use it and tell me what are the difficulties. If you have any difficulty, I am ready to make the change. So giving them the option, giving them the chance, making them aware that they can suggest changes. This helped me a lot. I gave it. I told them, you write as much as OVR as possible for me and give it to me, because I needed enough data to implement risk analysis, CQ, improvement projects, everything. So this is the best way that I could get everything. If I want to plan training also, I should know whether it was lack of knowledge or they, even after knowing, they are like failure to implement it. So all these I got. So I went in the moment. So these steps, developing the plan, setting the goal and objective, implementing it, and evaluating it. I gave it. I told, like, you have 1 month time to tell me all the changes needed. Then I will make changes as per your request. And then only I will make it permanent form. So that comes the refreezing, making it as permanent after making required changes. So these are the steps in changes. I hope I'm clear with this example. Well, thank God, the after effect was that in 3 months, I was able to increase the number of OVRs to 100. I know that it's a small amount, but something very less than 50 to 100 is a big journey for me. And thanks that my staff has really supported me with it. They trusted me, and I had to go down to the level that, okay, I'm not going to take any serious action. This is for another thing, for the accreditation purpose, everything. And I hope now you're clear with the stages of change. Unfreezing, moment, you're planning everything. And then once it is done, you're freezing it or fixing it. And then later, whether you can see whether any further improvement needed. Now, change strategies can be rational and empirical strategy. There are 3 types, like normative, re-educative strategy, power coercive strategies. How to implement it? Rational or empirical strategy is that you're providing current research or evidences which is needed to support your change, why it is needed. Now, initially, when I was changing this, they thought that because I am new to the company, I wanted to show or I wanted to change everything. Actually, it is not like that. My nature is not like that. I don't want to think, don't want things to get complicated. I told, no, it's not that I want to change something. It's because of the accreditation process. We have to make a bilingual form as per Sibahi criteria. So we had to make English and Arabic. When we had to do that, I thought we will take your suggestions also. What is the easiest and simplest way that we can make the OVR? And the same I will keep in the Arabic also. So previously we had only English form. Now we have both English and Arabic only in one sheet. One side is English, the other side is Arabic. Now, normative or re-educative strategy is using the group norm to socialize or influence people. What I did, as I told you before, we had new staff who were joined. I picked up the senior staffs here, explained to them everything, and I told them that, see, you being the senior staff, you should act as a leader, train the new staff, make them to write it, help them to write it, be with them, let them practice writing it. So this is how you are using the groups to get your things done. Then power cohesive strategy is using the authority. Authority is now being an nursing supervisor, I have to get the support from the team. So I went to the administrator, nursing director, and the CMO, explaining that these doctors, nurses all have to write it. They also put a word. So being in their position, when they put a word, definitely the subordinates will listen to them. So this is using your authority, your position and power to influence people to bring the changes. Now, commonly, this is a very common complaint heard that there will be resistance. Of course, I have faced the resistance. I'm not denying that. But the resistance more will come when you are forcing it. Imagine that without explaining, without communicating any of these things, all on a fine morning, I am making English and Arabic forms and making all the changes and going and telling them that, okay, from today onwards, this will be the new OVR. Do you think that people would have accepted it? They don't know whether I made changes or it is as per the accreditation requirement. I didn't explain anything. So when I am forcing it, they will say that, who is this lady? She just joined 2 days back and she's changing. This will be the opinion, or in their mind, they will think like that. So never force any change. Before making it, tell them that you're going to change it. And this is the requirement and this is why you're changing it. Then people will be ready to accept. See, it took me, let's say, more than a week or 2 week time to formulate it, get approval from others, get approval from my quality GCC head. And then only I could introduce. Before that itself, I told with the staff that there'll be change in the OVR form. So they are like giving them time to understand that, okay, our OVR is going to change into Arabic and English. They have already accepted it. Now, when I introduce, they are already accepting it. It is easy for me to introduce it. So any forced change, it will not work. You will have to face so much of resistance. The best thing is make it simple, communicate everything, be transparent with your staff, gain the trust, then it will be much easier. So here in communication, I would like to explain with a simple model. It is called as a 4A model in communication. And now here what it says is that I felt this is very simple and this is more relating to what we do on our daily basis than the other models. So here it says there are 4 A's: acquaint, align, act, and adjust. Acquaint means know the staff. What are their thoughts? Here what I did, I went and talked to them, and then I realized that they had all these misconceptions about OVR. They don't have a clarity. Align it. Now you know what is happening, and they are like seeing me every day. They understood that I'm trying to help them out. And then you align it. Like create a shared purpose, creativity, build the trust, and ensure planning. Then you plan it and say that, okay, this is my plan and I need your help. Act. Do the planning, then you try to implement it, and then afterwards you can go with the adjustment. But here all the basic thing is communicate it, be transparent, tell them exactly what it is, than hiding any information, so that they understand that you are transparent and you can be trusted. Leadership roles, risk-taking in assuming the role of change agent. Be bold. That doesn't mean that you need to be rude. No, be bold, be strong, know what exactly you're doing. You should do your homework and know what is needed and what you want to achieve. Demonstrate flexibility. Flexibility in this term that open to suggestions and changes, because they are the one who is going to use it than a quality person. So it should be in a simplest form. Whatever you are introducing should be simple and easy for those who are using it. Seek subordinates input. Ask everyone, is this okay? What do you feel? Should I change anything? So they also feel that their opinions or their suggestions are considered or they are given importance. Anticipate, recognize, and creatively problem solve resistance to change. See, I know that it will take time for me to, make the trust or develop the trust and communication with the staff. So you need to realize that it is not easy to get into an organization or a system just like that and make changes. No, it doesn't happen like that. Serve as a role model to subordinates. There were times that I had to literally go and sit with them and make them write it, and this is how you can write it. Now, telling this, I will tell you what exactly happened. I told you that our OVR form right now is having the Arabic version also. So they know that definitely I'm an Indian and I really don't know Arabic or I cannot speak Arabic. So when they are writing in Arabic, one girl asked me, I am writing in Arabic, how will you understand? I told like, no problem. I always have a solution for that problem. Dear, you write in Arabic. We have something called Google Lessons. Now we have technology, we can translate it. So I told, her doubt was that, are you going to show, like, am I going to show it to any other staff who can read Arabic? So what she has written, sometimes OVRs are like, personal. They don't want to have no to other people, or they don't want to make it very public affair. So I do like, okay, no problem. This will be confidential. I don't need anybody's help to read Arabic. Now we have Google Lens, and I had to literally show her that what is Google Lens, how it is translated. So I told like, no, this paper or complaint, what you're writing, nobody will see. I will read it, and the actions will be taken as per your complaint. Then she was convinced. This is how you have to be a role model, and subordinates you do during the plan change. Then now people know that. See, once she is comfortable, I know that she will tell her colleagues, her friends that no, you can write, she can read Arabic like that. So, okay, fine, get the support of that. And that's how you have to implement it. Improve interpersonal communication skills and providing support for followers undergoing rapid change or difficult changes. So this is the same thing. See, one step, you go down, you tell that, no, I'm going to use it. Or imagine that instead of telling and explaining about the thing, imagine me telling rudely that is none of your business. I will read Arabic. How she will feel it. So you cannot answer like that. You have to explain to them so that they will trust you and then get the reply. Identify alternative to the problem. Same. My alternative is using the technology. It takes time for me to learn Arabic and then learn how to read. It's not easy that in a week that I can get trained. No. So I had to make another alternative plan where I can understand what it is written. Demonstrate sensitivity to timing in proposing plan change. When you promise something, make sure that it is done. Or else tell a solid reason why the change has not happened or why you were not able to fulfill the change. Prevent change in the organization. Prevent aging means it's not that I told in the month of July that, okay, our OVR form is going to change and then implementing it next year. No, then half of the people will forget about it. They will say that this, she will say it will not happen. It will take another 6 months to happen. It should not be like that. You should be consistent. They should not feel that lagging is there. All these are important things when you're considering about any change. Support and reinforcement of subordinates during the change process. Identify and uses appropriate change strategies to modify the behavior of the subordinates. So you need to understand what they are facing, what problem they are facing to accomplish the task. And then you have to make necessary changes. If it is training, if it is educating them, if it's like they don't know the technology or they don't know how to go about it, it's just because they are confused with decisions, like whether I should go with the decision A or decision B. You should be always with them and support them. Periodically assess the unit and department and signs of organizational aging. You should go for evaluation. Periodic evaluations has to be done with each department and each unit, whether this is comfortable for them, whether everything is going on smooth. Change should be implemented only for a good reason. I hope that I didn't make you all feel sleepy. I tried my best to complete it with one example so that I'm not shifting it. Anyway, concluding it, change should be implemented only for a good reason. Don't do anything just because you wanted to make change. Make sure that the organization or wherever you're working really need the change and this is necessary, then it has a purpose, go for it. The level of resistance to change depends upon the type of change you want. Now, you want to make a big change, definitely you have to explain and convince everyone. If it's small changes, then it's fine, it is easy. So I will always suggest that go step by step. OVR was not only one thing that I wanted to inform or I wanted the change to happen. I wanted change for all other forms because all forms should be in Arabic and English. Taking OVR, which is commonly used or everybody will use, was the first step. Then slowly I convinced the doctors that change will be there in the dental form, in the dental numbering, all other things. So then it is easy to go step by step. You organize, you plan everything and do small. Just imagine that I'm one day putting all the forms after making it that, okay, tomorrow onwards, all these forms have to be implemented. It doesn't work like that. One form, during the implementation of one form, tell that all other forms or checklist or whatever they are using is going to be changed. Then you're giving enough time to them to prepare. There should be a trust between the employee and the manager or the employee and the organization. This is what I told. I'm really happy that the management of the Nadsara or the Kims really trusted me that I will do the proper way, or they evaluated me the first 2-3 months during my probation and they found out that, okay, I may not go out of their control or I'll do in a simplest way and easiest way. I am seeing the comfort of my staff or others. So this is how you have to build the trust. And then the things will, once the trust is gained, it is easy to move forward. Thank you so much. Contribution and acceptance of change is essential for the progress in nursing profession. I will not say that nursing alone. This changes or changes in a positive way, in a good way is required in all professions. And we should be ready to accept changes. Then only there'll be organizational growth. I hope there's no doubt. And I made it very simple and easy for you all. Thank you. Thank you, Amal.
Thank you, Ms. Lini, for this important topic, and thanks for sharing us the strategies of change and how we organization are dealing with change. I have one small question regarding the
Yes,
change management. Are you using the SWOT analysis for this process, such as strength, weakness, and how do you face the opportunities and threats for this?
Definitely, I'm using the quality tools because this is the easiest way you can do or you can understand everything without missing any points. So as a quality person, definitely I'm using it. So whenever there is any serious issue, I am using root cause analysis also, so that I am not missing any points. See, the basic nature of humans that you can make errors and it's not a fault. We make errors and we learn from that. So being a person in quality, I cannot afford to make too many big errors in that. So I make sure that everything is written down, everything is planned, and I don't mind going and asking with my seniors, with the person who are having more experience, is this okay? Shall I do it? And there's nothing wrong in asking it. It doesn't show that you are down or you don't know. Just getting double sure that what you're doing is correctly. So strategies, definitely I'm using, tools I'm using, I do root cause analysis, but I make sure that it is comfortable for everyone in a way that, it is like easy and they know that, okay, this will be it and it's not going to be really bad unless the situation or the issue is too big.
So what's the most opportunities that you face when you're working on the change strategies and the training process?
Come again, I'm sorry. What?
What's the most opportunities and the threats that you face when you're working during the process of the change?
Opportunities, talking about that, I really got, acceptance. That is because of the management support. They also helped me out. As I told you, even the CMO, the nursing director, the administrator, and from the GCC head, we at KIMS have a GCC quality head. So he also was like, I just text him. He was always ready to help me out, talk to the administrators or even to the staff, to listen to Lini, support her, and this is what we needed, like that. So I faced resistance, a lot of resistance, because nobody was ready to accept a new person and what she is doing. They all thought that now I'm trying to, bring just changes. This is like, personal decision. Definitely not. And I had to explain to them that this is as per Sibahi criteria. In Sibahi, the point so and so says this is needed, and we are going ahead with accreditation, and we need to fulfill it. So this lot of communication and explanations I had to give them to get the acceptance.
Thank you, Ms. Lenny, for answering my questions. Is there any more questions for Ms. Lenny? Kindly write in the chat box or raise her hand.
I would like to request all the speakers to evaluate me also, because I'll be really happy if you point out the negatives in me, like I was too fast or something like that. I will be really happy about that. And thank you, Amal, so much. Yesterday also, I was listening to speakers. All of them were amazingly good. The amount of information with the test example, Dr. Neil just now, how beautifully he explained the COVID situation. He pinpoint even the parking lot changes. And this is how it's not possible that we can visit all the institutions and get. So tomorrow, when you face any of this, you know that, okay, these are the changes. That was a beautiful presentation, actually, but by Dr. Neil. Thank you so much.
You are more than welcome, and this is Jordanian people. Thanks, Ms. Lenny, for your time, and keep with us for the end of the presentation for today. Let's move to our next speaker from my childhood residency country, from Saudi Arabia. It's with a great pleasure welcome Ms. Ghada Naimi, General Secretary of American Society for Quality, KSA section. Her presentation is about transformational leadership for health transformation. So welcome, Ms. Ghada.
Thank you, Amal. Welcome, everybody, and Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Lenny, for that nice presentation on change management, and I hope you listen to my presentation, because it will be a complementary to your presentation. Let me share with you the presentation first. Can you see it?
Yes, we can see your presentation. Go ahead, please.
Okay. So today I'm talking about transformational leadership for healthcare transformation. I will start upside down, which is from healthcare transformation going to the transformational leader. The contents will be, as I said, healthcare transformation. Then the second part of the presentation will be transformational leadership. And finally, the implication and adaptation of transformational leadership within the healthcare sector or any even other sectors. Now here we can see during the history of technology and others that Nokia had refused Android. So then Nokia vanished, almost we could say vanished. Kodak also refused the digital cameras when it comes there. Now nobody is hearing about Kodak anymore. Blockbuster, if anybody remember it, it's a video store, a big video store. And he refused Netflix, and now Netflix is dominating in that filming environment or world. Finally, Yahoo which is refused Google, and the new way and new changes in that Google introduced into the networking. Now Yahoo is sold out by Google. So as I said, we need to transfer to be part of the future or risk being left behind. And an advance in technology and new entrants from outside the industry and changing consumers' expectations are driving a global shift in the healthcare landscape. At the same time, these chronic diseases and social determinants and resource limitations can continue to add more pressure on all governments and all countries. These powerful forces are pushing traditional models of care delivery to change. So if you didn't change, as I said, you were left behind. Here is a study from PwC, and they got four models, four healthcare models in 4 countries: Mexico, Saudi Arabia, India, and Singapore. PwC, they studied these healthcare sectors, and the result was that suggested a transformational model. And they said that healthcare is fundamentally changing around the world. Health startups are spiraling up across Singapore, and mobile health initiatives are helping India leapfrog over traditional healthcare systems into tech-based care. And in Mexico, the government is tackling diabetes with a holistic approach, including instituting community glucose monitoring centers and soda taxes. And in Saudi Arabia, it is modernizing its entire health system, rethinking where and how care is delivered. And recently, KSA is launching their healthcare sector transformation program, a huge program to transfer the whole healthcare sector in the kingdom. I put you the link here of the study. It is very interesting. If you can go and see it, and you will see the 70s initiatives that the KSA implement and started since 2017 for the healthcare sector transformation. This is another pressure for transformation in healthcare, which is the UN SDGs, the Sustainable Development Goals. And here in this paper of Sach and his colleagues, it's 6 transformation to achieve the Sustainable Development Goals, SDGs. I recommend everybody to read it. It's very interesting paper. And here they said that SDGs and Paris Agreement on a climate change call for a deep transformations in every country that require complementary actions by government, civil society, science, and business. They introduced 6 SDG transformation as a modular building blocks for SDG achievement. And each transformation identifies priority investment and regulatory challenges, calling for actions as by well-defined parts and of the government working with business and civil society. These transformation may therefore be operationalized within the structure of the government while respecting the strong independencies across the SDGs. And you can see here, these are the 6 transformations suggested. We need a transformation in education, gender, and inequality. We need a health, well-being, and demography transformation, energy, decarbonization, and sustainable industry, then digital revolution for sustainable development. And here where we harnessing the technology into the towards SDGs achievement, and then sustainable cities and communication, sustainable food, land, water, and oceans. Then if you can see in the right side of the slide, this snaky diagram illustrating the relationship between these 6 transformation and the 17 SDGs here. And the thicker line is the greater contribution. You can see here the second one is the health and well-being and demography, have a very strong with goal number 3 and goal number 4. 3 is the health and well-being, 4 is the education. And I'm not going to go through all of them. If you would like, as I said, I put you here the reference, you can go and read it. But what we are interesting is the health, well-being, and demography. And as the paper suggested, that this transformation promote key investment in health and well-being. Design and implementation will be led by health ministries in coordination with other ministries such as labor and industry, education, Ministry of, like say, Interior, and other ministries, Ministry of Transportation also. And as well, transformation is the key. This transformation is the key intervention. Under this transformation are synergetic without any major trade-offs, and provided the leave no one behind principle that everybody should be included and applied to everybody on these interventions. And under this transformation, particularly related to or others related to the health and healthy behavior and health environment, reinforce health outcome and well-being. The principal intermediate output in the universal health coverage, and it requires a publicly financed health system that interrogates prevention, therapeutic, and palliative services, an integrated information system, and disease surveillance and control. Health systems also need to focus on primary health care and other interventions for maternal, newborn, and child health, effective prevention and treatment of infectious disease and non-communicable disease control, including mental health and basic surgery, in combination also with improved girls' education and gender equality, because that will reflect indirectly on the health and well-being. And then they also include policies and metrics. Community also health programs can improve health outcomes significantly. And then health intervention outside the health sector will improve the social determinants of health. And they will include policy and metrics to raise well-being and equality of life. These changes to social norms and behavior will promote health lifestyle through a better hygiene and lower consumption of tobacco. That's what the paper suggested. And there is a lot of examples and a lot of details on that part. If you would like to, this is the reference, you can go there. Here, a model of our KSA transformation strategy. In KSA, since 2017, the Ministry of Health made a progress in developing the principal elements of its transformational strategy. And this strategy under the health sector program, which is one of the KSA Vision 2030 programs. And the strategy introduced a new model of care, which is this one. And this model of care program has 42 at that time when it started coordinated interventions. But now it's raised up to 70. And these across 6 dimensions, which is lost phase people, keep well, safe birth, planned care, urgent care, chronic condition, and lost phase. And these initiatives included defined patient pathways and key performance indicators to be measured, and including these measurements, which is safety and quality process metrics, clinical and patient-reported outcomes, finance performance also. These new models of KPIs will incorporate it into the KPI for essential benefits packages that this program has developed, and this to ensure that they are monitored and maintained when achieved. And I said earlier that recently also there is a new transformational healthcare sector transformational strategy was launched in KSA. What we need to transform for the healthcare, these are practical steps for transformation requirement, requires healthcare leaders who are willing to take bold steps to do these minimum 5 immediate actions, which is engage non-traditional value chain partners, adopt consumers-centric focus, shift to preventive and outcome-based card models, and embrace digital and technology enablers, drive improvement to access, equality, and affordability of care. And today, healthcare organizations can emerge as leaders in a new ecosystem of consumerized care, virtual access, and a rapid knowledge flows across a portfolio of providers. But the question now is what type of leadership requires to lead these transformations? And this is the topic of today. We have 3 types of leaders, and under each of them, there is more leadership styles. We have tactical leaders who's usually focused on solving straightforward problems with operations-oriented experts, and we have strategic leaders who are very future-focused with an ability to maintain a specific vision while forecasting industry and market trends. And we have our today's style, it's transformational leaders who focus less on making decisions or establishing strategic plans, and more on facilitating organizational collaboration that can help drive a vision forward. And why we need it in a healthcare transformation, because you need someone who coordinates this transformation across all country sectors. And one of the best uses for this leadership style is that when the organization that is outdated, also a very old organization, let's say a hospital with 100 years, and now they need to change and adapt with the global changes. And it's also perfect match for small organizations, and has a small organization with big dreams and wants to change and adapt to get there. And in both of these examples, the board of directors can bring the transformational leaders who will change the structure of the organization and also motivate the current workers to buy in into the new direction. Now, what is the transformational leader? This is 2 definitions you can see. And let's go with a history of this transformational leader. When it comes, it started with James Downton in 1973. So the concept is not new, it's very old, in 70s. And Downton, he was the first who invented this term. This was later added by James Burns in 1978, which is more known. And Burns was a leadership expert and biographer, and proposed that it was only through the strength of vision and personality that team members could be encouraged to follow. After agreeing to follow, members then are inspired to change their expectations, perceptions, and are invited to a higher level of morality and motivation. And a few years later, after Bernard Bass in 1990 added even more to that concept, and this known as Bass transformational leadership theory. The theory that Bass added ways to measure and rank the success of transformational leadership, as well as the idea of the leaders expressing authentic and focused energy to inspire the other team members and to become more like them. Bass felt also that the measuring the impact inspire more authentic community. He also explained the psychological mechanisms that are the base of the theory. And according to him, the followers of leaders must feel not only trust and admiration, but also loyalty and respect. And these emotions create an environment where the followers are willing to work harder than they originally thought, and they are able to. This is because transformational leaders usually offer followers something beyond self-gain, an inspirational mission and self-identity. And here you can see this is the definition that Bass introduced for transformational leaders. And he said that they are who stimulate and inspire followers for both achieve extraordinary outcomes and in a process develop their own leadership capacity. So this is where the transformation of, if we go back to the study of the SDGs, leaving no one behind, it's here these transformational leaders will take everybody to be transformed, so no one will leave behind. And these transformational leaders will help followers grow and develop into leaders by responding to individual followers' needs, by empowering them, and by aligning the objective and goals of these individual followers, the leader, the group, and the large organization. And even though in dates that this BASO model was in 90s, it still look much more like a transformational leadership today that we need it in this era. The basis of the transformational leader style never changes. Even if this model of BASO looks old, but it's still never changed. It's still valuable, and the only environment in which it must be applied is changing. Therefore, it can be applied for industry, for every industry, and especially team-focused work environment. The transformational leaders, they usually role model of integrity and fairness, and they set clear goals. They have high expectation, encourage others, and they provide support and recognition to their team. And they steers the emotions of people. They get people to look beyond their interest and inspire people to reach for the improbable. And they usually influence, engage, motivate, and they usually leading change, and they breach resistance by getting the buy-in of everyone in the organization. They usually building a strategic relationship with their team. They lead through a change and the change management, leveraging emotional intelligence by motivation and influence and engagement. They also translating the strategy into action. I mean, the organizational strategy into actions. And we will go through that later. Developing also, as I said, employee capabilities and improving them. This is the BASO model, transformational leadership theory model that BASO has introduced. And I said it's 1990s, but it's still valid. And it's introduced these 4 I's. And this one is labeled, these transformational leaders labeled as a healthy leader or the quiet leader. They don't make noise. They are so quiet, but so focused. So Basu suggested that there was 4 primary elements of a transformational leader, which is, as I said, the 4 I's. And it is the idealized influence, inspirational motivation, intellectual stimulation, individualized consideration. These 4 I's are back to the characteristics, the traits of leadership and transformational leadership. It's only categorized and how is it utilized. So individual consideration, if you go from here, it says that these transformational leaders listen to their employees' concerns and needs so they can provide an adequate support and encouragement. They also operate in understanding that the motivation of one person may not be motivated of someone else. So they understand each one of their team. And as a result of that, they are able to adapt their management styles to accommodate various individuals on their team. In other words, and in order to foster a supportive relationship between them and their team, the transformational leader keep lines of communication open so that followers feel free to share ideas and so that leaders can offer direct recognition of the unique contribution of each followers. And inspirational motivation, the transformational leader are able to articulate a unified, clear vision that encourage team members to exceed expectations. And they understand that the most motivated employees are the ones who have a strong sense of purpose. And these leaders are not afraid to challenge employees. They also remain optimistic about future goals and are skilled at giving meaning to the task at hand. And they are also able to help followers experience the same passion and motivation to fulfill these goals. Idealized influence means that these transformational leaders model ethical behavior. They always represent ethics, and their moral conduct earns a necessary level to respect and trust. And this can help leaders to steer decision-making that works to improve the entire organization. Intellectual stimulation means these transformational leaders regularly challenge assumptions, take risk, and solicit team members' input and ideas. They do not fear failure, and instead they foster an environment where it is safe to have conversation, be creative, and voice diverse perspective. That's why it's always a creative ideas and innovation. It comes from this part. This empowers employees to seek a question, practice a great level of autonomy, and ultimately determine more effective ways to execute their task. And I said innovative ways. Now, these are an important leaders and how they become, how you could become a leadership, a transformational leader. It is while it's important to look to the success and the growth of the organization, it is also important to recognize that most of these organizations and people did not start out successfully. It is important to recognize that these people and organizations were monitored and guided by transformational leaders. And the story here shows that this leadership style can help to transform you, yourself, your team, and your mission, and of course, eventually, the whole organization. And what can you do to become more transformational leader? It is one of the critical ways to start is by having a belief which is a vision, your personal vision. And you can start also with the organizational vision. You must believe in the vision and the path you have created or your organization so that you can inspire others to believe in your vision as well. Being charismatic, motivating, and focusing on each individual team member can help you also accomplish this through transformative leadership. If you are developing a vision for your team, start with your organization's mission and vision and explore the way in which your team can contribute directly to it, i.e. means you take the strategy, the vision and mission of the organization, the strategy, goals and objective of the mission, and you start to cascade it to your team level and see how each member or individual of the team contribute to the achievement of the whole organization mission and strategy. As a transformational leader, always clear communication is essential for you. So always keep clear communication channels and an open channels with your team. You as a transformational leaders need to inspire great loyalty and trust to your followers. And these transformational leaders also, they have high expectation and they inspire their people to reach their goals. And finally, keep in mind that to succeed as a transformational leader, you will need to work on your own skills and set aside a time and a space, a quality time and space for your personal development. These people did not succeed from nothing, from zero. They start from themselves, then their team, and then their organizations. Now, here in our third part of the presentation are famous examples. These are only 4 famous examples I brought, but there are many examples of transformational leaders. One is Opera, and the other is Nike. These are well known, and Nike with their slogan, "Just do it." Okay, but I will give a little brief about Mr. Engineer Edward Deming, that lived 1900 until 1993. Edward Deming, William Edward Deming, is known as the father of statistical quality control. And he's after getting his doctorate in mathematics, doctoral degree in mathematics and physics in Yale 1928. He spent most of his career working on or consulting in the US government. During World War II, Deming taught statistical process control techniques to military production workers. And after the war ended, the US Department of the Army sent Deming to Japan to study agricultural production and related problems. He convinced Japanese officials of the potential for industrial uses of statistical methods, and Deming's goal was to have Japan become a world industrial power in 5 years. Japan did that in 4 years. And Deming was asked to do the same thing to the US manufacturing firm, but his method did not take root until 1980s. And Japan, in order to honor Edward Deming, they created Edward Deming Institute, and they have Deming Prize for quality. It's an international award from Japanese International Award. Another one is the one in the left side, is John Rockefeller. He was a founder of a Standard Oil industry. It started as a single oil refinery and grew to a huge company. Much of the company's growth came through acquisitions, but Rockefeller also spent a considerable amount of time streamlining the organization as it's growth. So he did not forget to build up the organization as it's growth, not only a financial part. Rockefeller built his company earlier repetition by guaranteeing the quality of standard kerosenes. And he was known for his organizational tactics and for using disciplined strategies. One of the reasons for Rockefeller's success was he could align his company with one simple vision. And then he held everyone accountable for their part in making that vision happen. This is a transformational leader. There are other, but because of the time, I know I'm taking a longer time. You can go to Amazon boss, Jeff Bezos, Netflix, the Reed Hastings, Apple's Steve Jobs, and Peter Drucker, Ross Perot, and of course, for us in Saudi Arabia, His Royal Highness, the Crown Prince, Prince Mohammed bin Salman. He is one of the greatest transformational leader in KSA, who's leading KSA transformation and recognized by the whole world. What criticizing this transformational leadership theory, yes, we said it is really good, but there is a three criticism against this theory, that they makes use of impression management and therefore lends itself to a moral self promotion by leaders. The theory is very difficult to be trained or taught because it is a combination of many leadership theories. It's not one theory. So you can see one person, one leader, and you can say, yes, he is a transformational leader, but he has a different leadership traits and styles. Followers might be manipulated by leaders, and there are chances that these lose more than they gain. Here at a comparison between transactional leader and transformation, because these both concepts are usually confused with. But I put just a few points, and you can go back to any of the papers I reference in my presentation, and you will see much more details on this. But in a brief, transformational leaders working to change the system and the organizational culture. They usually play around the culture. However, the transactional leaders, they work within the system and its culture. The transformation solving challenges by finding experience that how that old patterns do not fit to work. They bring innovations and new technologies, a new mindset, a new way of thinking. However, transactional solving challenges by fitting experience to no pattern only. The transformational leader, they wanted to know what has to change. Where is the areas to improve and modernized, while the transactional want to know the step-by-step approach. They are very process-oriented and traditional and more. The transformational leader maximizing their team's capability and capacity. They give them a freedom to think and act. However, transactional, they minimize the variation of the organization. So you are focus-oriented and task-oriented. You have to finish this with this methodology. The transformational are leadership, proactive leaders, while the transactional are responsive leaders. As a conclusion for our today's talk, of course, the size of the healthcare economy. We go back to our first part of the presentation. Whether it's a government payer, a private, multi-tiered, and the maturity of the market may determine how quickly an organization can transform. We have an example in UK, which is the process of centralizing and streamlining its hospital systems. Transformation comes more slowly, but much like turning a massive ocean liner. But in an emerging market such as in India and KSA, transformation may come relatively quickly, with hundreds of startups leveraging technology to bridge the gap in access to care for the millions of customers living outside urban centers. On this, when this is clear, consumers, which is the patients and all the community, are driving this change, and most of traditional healthcare businesses will have to transform in significant ways to meet them where they are. And ultimately, the winner of this transformation are the agile and customer-centric Amazon or Googles of healthcare, and may surprise us all. And the transformation of healthcare and its leaders means to adapt, grow, and overcome hurdles. And no matter how they are assembled, the healthcare leaders ensure that the vision for the healthcare is ambitious, is aspirational, and delivers on its promises to their patients or their consumers. So therefore, the transactional, or any other traditional style of leadership is viewed as insufficient, but not bad, in developing the maximum leadership potential. It forms as the basis for more mature interactions, but care should be taken by leader not to practice it exclusively. Otherwise, it will lead to the creation of an environment permeated by position, power, perks, and politics. Therefore, we need a transformational leaders who will transform our healthcare sectors to the best that we want. And by this quote of Seth Godin, transformational leaders do not start by denying the world around them. Instead, they describe a future they would like to create instead. And thank you very much, everybody. And if you have any questions, please let me know.
Thanks, Ms. Ghada, for this interesting and informative topic. Actually, I learned a lot about transformational and transactional leadership while I'm preparing for my CPHQ certificate. And your example about Crown Prince Mohammed bin Salman as a transformational leader in Saudi Arabia is a perfect example. Let's move for my only small question for you. In your opinion, what do you think is the most transformational leader is effective, and why?
Which mean a trait of them?
Yes.
Yes. As I said, it's they understand the differences between each individual and their team, and their needs, their expectations, and they have the ability to take care of these people and align them with their vision and mission, and draft their goals, the strategic objective and goals to these individuals. So they buy in. The buy-in is very important, and they keep line of communication always. They are very active on that. I think this is the most characteristic or trait that this transformational leader, they are open also to the changes around them. They are not focused on what we need to do. No, they took their team, their organization, and themselves to transform and to be a better version of us.
Thank you, Ms. Ghada, for your answering my questions. Everybody, if you have any question, just write in the chat box or raise your hand. You can chat directly, Ms. Ghada.
Okay.
So because time is moving now, let's move to our next our next speaker will be, yes, Mr. Raul Salgado. I hope that I mentioned your name right, from Chile. And
Ormazábal Salgado.
yes, and he will speak about assessing the interpersonal relationships and assessment tool to improve nursing education. Welcome, Mr. Raul.
Thanks for the presentation. Well, I would like to talk about a nursing assessment form, which has been used with nursing students while they are learning nursing. Well, I will give you a little bit of context prior to starting the presentation, which is basically that I work as a lecturer in a university by training nursing students, undergraduate nursing students in Chile. So it's necessary to innovate in the practice of teaching nursing. So that's why we created a tool for the students to fully assess their patients while going to a clinical setting and assisting people with mental needs, mental issues usually. So they tend to omit crucial information about the assessment of the patients. So that's critical since they cannot elaborate a personalized nursing care plan. So the relationship is crucial to be understood in mental health nursing. So it's possible for the students to omit due to their lack of training and sometimes knowledge in this topic. So the creating a tool could standardize the process. So this tool was created and implemented progressively in 2 different years, 2019 and 2021. So this is supposed to be a tool for assessing the patient by identifying their needs and helping students to achieve what they are supposed to achieve during their undergraduate training as featured nurses. So the main objectives for this innovation were supporting the learning process of the students, promoting a systematic recording of the patient's examination because the students can write down some notes, key aspects that they detected during the interaction with the patient, but they could also omit, as I said before. The students also need to apply specific descriptors, so-called technical concepts, in order to fully integrate those concepts in nursing knowledge and nursing care. So this was a standardized tool it was created by following Hildegard-Piplo's middle range theory, which basically consists of 3 key aspects of the nurse-patient relationship. So it's composed of orientation, the working phase, and termination. Each one of them is dynamic. They could go back and forth since people are dynamic. So this is also known as the psychodynamic theory of mental health nursing. So basically, the students already know the grade they could obtain through this tool since they are clearly predefined in order for them to understand what they need to do. So the technical concepts are divided as well through sections. Some of them are some aspects influencing the relationship. These could be related to the patient directly, as well as to their environment. Description of phases of the therapeutic relationship, as we said before. Verbal and non-verbal communication techniques in full detail. Some difficulties observed in the interaction with the patient. So the students have to identify them and in order for them to go through that and assist the patient. So it's also important the implications of the nurse-patient relationship in terms of understanding the context where they are in their clinical experience. And finally, continuous improvement. So the last section is composed of 2 questions. These ones, where the students are asked to briefly share what they think about the tool, if that tool is self-explanatory, or how could they improve this tool. So this could help to validate the document and eventually implementing changes. So the methodology was learning about their experience, what they think about this tool. And this information was collected after the 79 students completed their training with that in that clinical setting. Their opinions were, like I said, collected and analyzed through thematic analysis. So from the content of their answers, 7 dimensions with their respective categories were identified as follows. So 7 of them with many categories that are divided according to the topic. And the first of them is about clarity of the tool. So the students agree that this nursing form is clear and self-explanatory. So they think it's simple and they understand what they are needed to do with this form. So they think that helps them to assess the patient according to the care standards that they need to comply with as 4th-year students. So the explanations for each item are also required. The students found them helpful for understanding what they needed to write in those sections. So it was useful for them to complete the report, and they already knew what they needed to do by only looking at the document. But additional information is also needed. Students think that instructions received by the tutor prior to using the tool were equally good and necessary. So these explanations basically help them understand, fully understand, with some examples given about the main instructions and how to proceed. So students also found helpful to use their prior learning and their knowledge they already acquired while training for this subject. So they think it allowed them to apply all those concepts and technical descriptors and assessing the patient accordingly. Other students think that there are no suggested changes. So they think the tool is good as it is, and they would leave it that way. Yet others think that the format should be offered in both printed format, physical, and digital. The extension of the form should be also reduced, but that means that one has to cut short other sections, as we will discuss later. This tool, designed according to the patient's needs, in general, it was designed that way, but students yet think that it could be improved and they could have more than one type or version of the tool in order to assess patients with different characteristics. For instance, there are patients that don't display a wide range of behaviors, or they don't have a lot of things to, their speech, their language is quite limited. So students found that characteristic from the patients very challenging to assess them by following this tool. So they think a different one should be designed and offered to them if need be. the many suggestions were mainly focused on changes in item 3, which corresponds to verbal therapeutic techniques. So students think it's challenging to understand what they need to do with each one of them, since they don't quite remember what they mean. They should thus see their, they should review their books, their classes that they already had, but that's still challenging for them to fully integrate into practice. The behavior of the patient is also important, not only with the student through the therapeutic relationship by itself, but also they think it will be helpful to incorporate a separate item and about that by assessing patient's behavior while the student is not interacting with them, how they normally behave. And some of them went even further by claiming that a section on recreational activities should be added in order to boost the therapeutic relationship. So students think that knowing, identifying their perceptions about the relationship could be equally helpful for them to fully develop as nurses, since they could get more insight about what's happening with their own emotions during and after the interaction with the patient and or patients. So it could be challenging for them to understand this. So they could be encouraged by adding a new item through this tool. So the patient's opinion about the interaction is also considered important, since one can have a better understanding about the patient, their preferences, how the nurse could engage with them in that therapeutic relationship. So patients change as all people do. So students want to have that represented in a separated item by describing the patient's opinion. And verbal and non-verbal techniques were also challenging for the students, especially considering that we are still going through the pandemics worldwide, and Chile is not the exception. So it was challenging to use non-verbal gestures and facial gestures with the patients, since we have to use face masks while interacting with them in order to protect ourselves and the patient's health. So it's challenging, and some students think that another section could be about nonverbal techniques in full detail, not only describing them briefly, as it was considered until now in the tool. Additional information is also required. Students earlier I said that students agree that information is required to know and how to use this tool, but also extra information like given examples, and some extra explanations in the tool itself are required by the students in some specific sections like item 1, item 2. So they think, for instance, adding an extra box to comparing the first encounter with the patient versus the last one. So they could reach a conclusion about the main changes experienced by the patient through their interaction with the student. Learning and experiences are really important for students. They think that previous training about the correct use of this tool is needed and encouraged by them. So they think that despite counting on all that information prior to using the tool, right before using that actually, they think that they could obtain greater benefits if they train with it before going to the clinical setting while studying in their classes, because they need to study the theoretical framework, so to speak, before applying that knowledge while assisting people in the real world. Students also think that explaining with examples is equally important, since they could fully understand what they are needed to do accordingly. So they can be guided, better guided, in order to know what to do with the instrument and the patient. So complementing the patient assessment, I mean, detecting the main changes is also encouraged. And they think that, I mean, one patient could be assessed by more than one student in the time where we are going with undergraduate students. We go to a clinical setting in a period of 3 months. So patients are repeatedly assessed by different students in different moments. Patients also change, so students think that those changes could be reflected and discussed later on in order for the students to fully understand the main changes that they have no chance to see during their clinical experiences, since they go there no more than 7 days in groups. And in this time of pandemics, that amount of time was even reduced. It reduced even more to up to 3 days instead of 7. So that's a short period of time where students have little chances to see changes and compare them. Nursing management is also important for students to be considered in this tool in order to describe how nursing management related to the therapeutic relationship is conducted in their clinical setting. So they also know that they have to count on those abilities if they want to become good nurses in the upcoming future. Sharing experiences for the students is a very important part or segment of their training, and they think that workshops could be carried out where they could discuss what they have learned from their experiences as a group, not only among their peers that went with them to that specific experience or training of 3 or 7 days. So they think that they should have extra discussions about that. And some think that this tool could be used in other subjects, for instance, surgery or primary healthcare. So since mental health nursing is really important across all the specialties of the profession, they think that this tool could be widely used. So basically, this collection of data and this tool started in 2019. And as students used that, they were encouraged by the instructor to suggest changes to that. So eventually they did. And over time, the tool became sort of validated. But as we can see from the data, it is still an ongoing process, and there is a lot of room for improvements on it. So students are asked to actively discuss that, or at least giving their opinions, since as nurses, they will have to take an active role in the elaboration and review of nursing forms, since they are part of nursing care. So this is a sort of cooperative enhancement of this tool, but not only the tool, the physical document, but the training. This document ultimately helps students to fully understand the process that the therapeutic relationship involves. It's not that simple as it seems, but it's simpler than they think after studying their classes. So in conclusion, this is a cost-effective tool that could be used in nursing training. Since student feedback was positive, and the biggest challenges are modifying some sections that students found quite challenging to fully incorporate and put into practice. So further research is needed. It could be an idea to implement these changes in the form, and in the future, researching about it again in order to get another feedback and so forth. So this is basically the tool as it are required in the first section. One can find the biological and social and psychological aspects from the patient. So you can see a brief description about what the students need to put there. The therapeutic relationship is also described. Students need to describe how they interacted with the patient throughout their clinical experience, not only one single day. So in the working phase, for instance, they need to add what they did with the patient, how did they assess them, and how did the patient respond to those nursing interventions. And the termination phase is important. Students usually overlooked that before elaborating this tool, but now they pay closer attention to that. They know that's very important to terminate and finish the interaction with the patient at some point. And they need to know or to identify clearly how the patient behaves when they said, for instance, goodbye, so to speak. This is the third item where students found challenging to understand the concepts, for instance, clarification. They asked that extra explanations about each one of them should be added, though that could be challenging, since the space left is just very small. So they are required to are encouraged to check their classes while using this tool in order to fully understand what they are needed to do, as well as asking the tutor during their clinical training. This is the item about nonverbal therapeutic techniques. So some students think this is insufficient to fully cover all the possibilities that they are required. So some of them suggested that a similar format than the previous one should be implemented. Yet others think this is enough. Difficulties are also important to be pointed out, and students usually found this helpful and they didn't have any opinion about it, either positive or otherwise. The implications of nurse-patient relationship is also necessary to be described, since these are fourth-year students. And we need to consider that in Chile, nursing training lasts up to 5 years. So fourth-year students are about to become nurses, so they need to fully understand what is happening in nursing management, for instance. And this is the last section, where the two questions that led to the data collected for this presentation were portrayed. So here you have some references that I used. And thanks for your attention. Do you have any questions?
Thanks, Mr. Raoul, for your presentation. Would you please close your screen? Thanks a lot for your presentation. It was an interesting topic. If anyone has any question for Mr. Raoul, please send him a direct message on a chat box or raise your hand. It seems there is no any question. Thank you for your attention and your time, Mr. Raoul. Please continue with our presentation. So let's move quickly to our next speaker. It will be Ms. Noor Abdul Malik from Saudi Arabia. She's the head of training and development at Ministry of Health, and her speech is about nursing and special events key considerations. So welcome, Ms. Noor.
Good afternoon, everyone. Is the voice clear to everyone?
Yes, we can hear you. You can start.
Okay. I apologize for the place. I had to leave my house to the near cafe because I'm moving out, so my house is a bit crowded. I apologize for the voices in the background as well. I will share the screen and start the presentation.
Yes, please.
Just a second. Can everyone see it?
Yes.
So thanks all for this opportunity to talk again during the conference. We're all here to help, to support and improve the nursing experience and knowledge globally. Hopefully it works today. Just a second. Okay. So we're talking today about nursing and special events and key consideration. Last year I spoke about mainly mass gathering only, but I wanted to shake it a little bit, and let's talk about what's happening worldwide in the case of conflicts, events, and also humanitarian relief, and what is the special needs and consideration that nurses must have during these situations. So the focus is on mass gathering. Due to my background, the past 6 years I was working in the Global Center for Mass Gatherings. I worked in communication liaison, risk management department, and recently in the risk management, the training and the development department. So we'll talk about also humanitarian situations such as natural disasters and man-made. So mass gathering, there was a lot of definition regarding mass gatherings. So what is mass gathering? It's a number of people that attending and insufficient to strain the planning and response resources of the community, city or the nation hosting the event. It means like, I cannot compare a small country or a small city that's hosting an event with a big city that's hosting an event. I cannot compare, let's say, Jeddah, Riyadh to a small city, let's say Qasim, or Dubai with a small Imara in the Emirat, or this is what I mean. So when we're preparing the event or a mass gathering event, we have to make sure that the planning is sufficient enough with the resources within the host country or city. So why it's important to have goals during planning the events? We have to make sure that there is a provision of care to all participants and visitors we have to make that there is protection of the continuity of medical services to the population surrounding the event as well. So we're not talking just about the visitors or the participants. Do not forget about the host community as well. Preparation for a surge to respond to extraordinary events during the event itself. So why mass gatherings are diverse? It can go from weather to sport to concerts to religious to any kind of cultural event. The participation, the behavior, the demography of the people within these events are unique in a different event. So people in a concert or a music event is not as people attending a religious event. It's totally different. Even the duration of the event is also important. Event that will have a couple of hours is different than event for 1 day or 2 days, 3 days. Also, the venue is very important. Like a venue in a wide space, there is no problem in the crowdness itself. Is different than it's too crowded. It's a small or not big enough a space for everyone. Also affects the event and the outcome of the event. So we have to think about the incidence of injury during and after. So during the event, we have to make sure that injury could happen, risks could happen, and post events could happen, like communicable diseases such as meningitis, STDs in concerts, or other events. And it could affect also the host community and the visiting community when the community, the visitors go back to their home countries. So preparedness and response activities should be tailored to mitigate the highest risk that will effectively respond to the illnesses and injury and reduce the dependence on the country health and medical care system infrastructure. So medical care team, what's the best model? There was a lot of debates about the model. Will we calculate it as operational modeling or conceptual modeling? Is it will be by workload, or will it be depending on the event itself? So there was a lot of debates actually in the literature, and there were no definite model used. What is the medical staff consideration? So we have to think about the expertise. We have to think about the specialities, the specialists, comparing to the existing resources. So I cannot get a cardiologist working in an event that there are no cardiac patients or cardiac visitors are expected, or a geriatric doctor with no elderly visitors expected. So we have to match our specialities with the resources available. Also qualification and training, so they can immediately respond to the quality till higher level care team arrives. It means before like a medivac arrives or ambulance arrives to the event, the medical team should respond quickly to the cases within this scene. Other consideration, event dedicated caregiver accreditation, proper training and orientation for unofficial caregiver to ensure their safety. We mean by that volunteers, medical students, any volunteers or unofficial caregiver. I mean the admin or the people who work to organize the event. Utilization of the centralized volunteer staging and training area. This we mean by training those people before participating in the event. So what's the definite number of medical care team? There was also a as I said, there is no definite number. There is a lot of debate in the literature regarding the definite number. However, it was proven by Martingale that having physicians and registered nurse and a paramedic at the site of a mass gathering event reduces the number of patients that needs transfer to hospital by 89%. So we're talking about a complete medical team, but how many teams are needed? How many physicians are needed, or nurses or paramedic? There was no definite number. However, there is two calculations in the literature, or two models were used. We have Wisen and Sphere. Wisen was introduced by the WHO, and it was based on the healthcare worker workload with activity or time standards applied for each workload component. The Wisen was initiated by the WHO for temporary medical hospitals that could stay more than 1 year in the host community. So when we talk about workload in an event, it's different than a workload in a small city that needs humanitarian relief, or a city, a small valley area that needs medical support for 6 months or more. So the calculation came by workload, total vacancies, and total working hours. So either 8 hours or 12 hours divided by 10,000. However, Sphere is more for short temporary medical centers for internal displaced population, refugees, and affected communities in a crisis and any humanitarian context. The core healthcare workers for macro planning was 28.7 over 10,000 in PHCs, primary health center. So Sphere could work in medical tents and temporary medical center, which is more applicable for mass gathering events without the idea of the crisis and the humanitarian context. So why nursing in mass gathering? Why it's important? There's a lot of people who said ER, emergency, versus mass gathering. So we can have a combination of that. But there's no, again, enough evidence on the criteria and role of nursing and mass gathering other than being trained to be an emergency nurse. So is it enough? Is it enough to have this in a mass gathering? So Kemp found that statistically having an advanced practice nurse at the site of the event reduced ambulance transport and referrals to external resources. There was another completed unpublished scholarly project concluded that an APN or a physician assistant at a community care unit reduced the transfers by 57% to the ER. The definition of APN is registered nurses with advanced education, training, and certification that allows them to provide more complex care to patients. Is everyone with me? Because I feel like the internet is unstable. Am I?
Yes, we are hearing your presentation.
If I am fast, just tell me, because
no worries. Go ahead.
I cannot see you, so I cannot see your faces. It's different when it's online than being face to face.
Absolutely. You can go ahead.
Okay. So Why nursing consideration in mass gathering? As we know, the workload is different. The turnover of the patients are different, and it's unique. It's not like going on day-to-day routine routine task. It's a different role. And it's not like you're going to the hospital, even if a crisis happened or a mass casualty happened, it's different. You're in your safe area, you're in the safe zone with your same team, with the same medical resources within the hospital or within the place itself. So the nursing consideration, there is a higher challenge like language barrier, medical seeking behavior is different. Excuse me. Language barrier, medical seeking behavior is different. The diversity of patient, culture, and the kind of diseases. We're talking about chronic diseases such as hypertension, diabetes, and the management of it. It's a temporary setting, so the working environment for the nurses and the medical team is new. Working under spotlight, everyone is looking, where's the nurse, where's the doctor, where's the paramedic? So it's a very stressful situation. Lack of training and experience in disaster and emergency. One of my experiences in a mass gathering event that we had a situation in the emergency. The patient was dying. We're trying to resuscitate the patient. One of the nurses collapsed. She cried. We had to pull her out because there was a rush in the ER. She could not keep up with this rush, and she lost it. Unfortunately, this is what we mean. It's not about just the skills and knowledge preparation. We're talking about even emotional preparation for such events. Lack of knowledge and information on emergency response will also be a challenge for nursing, and not assigning the right profile to the right task. What I mean by that is I cannot have a general nurse who works in a clinic, works in an emergency area, or a nurse who works in an OB/GYN or L&D, labor and delivery ward, works in a surgical or work in the emergency area. So I have to pick my specialities in the right place. So globally, there is no, again, global standards for nursing quality, or what is the qualification of nurses to work in a mass gathering. However, WISE, sphere, and quality of health services could help to tailor the right medical team within these events. So let's talk to special events, such as in humanitarian situation. Humanitarian situation provide critical health care to people who are in emergency situation. So it's responding to catastrophic events such as natural disaster and armed conflict or man-made crisis disaster. Nurses apply their expertise in providing holistic care under the most challenging conditions. So when we talk about holistic, it starts from basic nursing, ABC nursing, to high critical nursing skills. According to the UN, by 2022, 200 million people will require assistance. We can look at the history of the past 3 years, where we had the pandemic, we had the natural disasters, we had a lot of conflict that's still ongoing around the globe. So what is the level of experience that I need in humanitarian nursing? As I said, she has to have a background care, in emergency, she has to have pediatric, infectious disease, public health experience, all in highly demand for humanitarian nursing. just 1 minute. Too much sand around. Again, these nurses need to have the ability to make decisions independently. They have to be critical thinkers. They think outside the box. They can cope with stressful situations and ability to relate and motivate staff. And when we talk about relate and motivate staff, it means there will be a lot of breakdowns. There will be a lot of crying and a lot of situations that will be very stressful, that we need the team leader and the team to be working closely and in support. Climate-related disaster, it could go from storms, floods, earthquakes, droughts, wildfires. In 2018 alone, more than 17 million people suffered from displacement due to climate-related disaster. We know about the 2020 Australian, the wildfire that happened in Australia, in California. There is a lot of natural disaster that happened that pushed people to leave their homes. So humanitarian aid workers, especially nurses or including nurses, respond by setting up the mobile clinics, supplying clean water, distributing medical supplies, and vaccination. It is very important to make sure about regarding fighting infectious disease such as cholera, Ebola, influenza, yellow fever. And why it is very important. It's not just vaccination, and it's not about public health, wellness, and public health security. Again, make sure that your team is vaccinated and ready for such situation. Man-made emergency. Nurses also is very important to work in such situation. So the role starts from the basic, operating in stationary or mobile health clinic, providing service ranging from primary care up to critical care, reproductive health, disease prevention, surgeries, triage, and treating severe injuries. So let's talk about military nurse. Military nurses, I know that I had to do some research in the literature regarding military nurses, and if there is any preparedness course or any preparedness training for military nurse within the Middle East or within the country. We tend to send nurses or deploy nurses with emergency background and disaster response experience. So we'll talk about what are these roles and how can we tailor our nursing program or those nurses deployed, tailor for them a specific program that would help them to work easily and comfortably in such situation. So military nurses work in military clinics and hospitals. They monitor wounds for infection, prepare patients for surgical procedure, and administer pre-operative and post-operative care for those inside the military. Historically, we know that nurses work like for a very, very long time, even in the time of Prophet Muhammad sallallahu alaihi wasallam. We know that there was nurses that worked during the wars, World War II, World War I, Vietnam. There was the history of military nurse is endless. So what are these needs or these what do we need in any military nurse? She has to be effective. She has to be excellent in physical shape. She has to be able to think clearly under stress, to make life-saving decisions quickly, competence communication skill, adapt to change quickly, high stamina and endurance, able to work efficiently with little sleep. Again, nurses' role could be treating wounded soldier and other military personnel, treat service members' family, set up military triage in war zone, treat patients anywhere in the world, provide vaccination to children in developing countries, assist in any humanitarian relief efforts where the military might be engaged in, provide emergency care to victims affected by natural disaster, prescribe medication, and again, working in pre-operative setting and applying anesthesia. What are the challenges and risks? We have physical, and we have culture, and we have psychological. Physical, because of the location, could be very dangerous. It could be including war zone, refugee camps, and remote location that have very few resources. Cultural differences, nurses could perform work abroad with no experience or little experience in this country they're deployed in. Different culture, different religious practices that could cause some challenge and stress as well. Psychological stress, again, the place and location could affect the nurse or the personnel. There is some literature that showed nurses that work in war zones and such difficult situations experience PTSD. So these are the three main things that we need to consider when we're deploying our nurses and preparing the nurses when they're deployed to such events. So how can we overcome? I'm almost done. One slide more. So how can we overcome these challenges? So we have disaster education and training courses, drills and simulations, field training and exercises, postgraduate studies on disaster response, like online courses, diploma or masters, auditing clinical performance and knowledge at ZD competency, supervision and support of the team leader, manager, pre and during the event. And during the event, I mean after the end of the shift or after the end of the day, we need to debrief even emotionally. There was one experience in one of the events. One of the nurses made some, it wasn't a big mistake, but the resources that they needed in the area was misplaced, and unfortunately the nurse manager he was very stressed. So he vented out his stress on the nurse. So it was really emotional situation. The nurse cried, she left, and this is what happened. So even the nurse leader or the manager needed a debrief, not just the team. To make sure that during that day, try to be more patient at the end of the shift, gather the team, start to debrief what happened. You did this wrong, we did this right, we should do this, we should do that, why the items was displaced or misplaced. This was not enough, we need more resources. And if there is something major, it's nice to have the nurse on one-to-one meeting, so she won't feel stigmatized or feel humiliated in front of the team. Don't forget that most of these nurses, they don't know each other. Some of them are pulled from different hospitals. Some of them are even pulled from different cities or countries, and they had to work in one area for no one knows how many days. sometimes it's 1 day, 3 days, or if it's a humanitarian situation, it could go up to 1 month, 2 months, or 6 months, or even years. Recommendation is to have a military nurse preparedness course that could include emergency response, disaster response, pre-planning, planning, recovery, emotional and physical and psychological preparedness should also be part of this course. So the recommended nurses standard, after I had this literature search or research, experience in mass gathering events, minimum of 2 years, experience in emergency, especially those working in emergency department and emergency dispatch points and triage, a minimum of 2 years, experience in emergency response planning. When we talk about emergency response planning, I'm talking about where to build or to start your mobile clinic, or how many nurses should be there, what is the amount of resources and medical resources should be deployed in these spots. Nurses should be part of this preparation because they know the resources, they know their nurses, they know the situation closely than anyone. Certified in emergency pre- and in-hospital emergency preparedness and response, triage, ICS, incident command system courses, either tactical, operational, and strategic level. PICSTEL, which we call it the basic infection control course, ACLS, BLS, pediatric pulse, neonate, because we're going to have could have pregnant women that are nearly to deliver. So all these things should be considered to mitigate the outcomes or the risk expected or potential risks. Receiving also training in HRI management. HRI means heat-related illnesses. There is a lot of updates in the literature about the heat-related illnesses, how to treat a patient, how to manage a patient from the scene till he moves to the critical care area to be treated. Also, EWARS, it's the early warning system courses. It means how to which patient needs to, for the EWARS to make sure that no pandemic would happen. We don't lose any case that could be infectious or that would become a pandemic, inshallah. APRN or equivalent, which means the advanced practice registered nurse. These are very important recommendations of the standard of nurses in special events, and it's open for discussion and suggestion. If you would like to add it, or if you want to add anything or discuss anything, it's open for suggestion. Hopefully, this recommendation could be set as a policy and procedure for nurses deployment in special events. Another final consideration: in any event, be prepared for the unusual. Do not think that you know everything just because everything could happen in these events, especially in location where there is war zone or a relief after floods or a drought or a natural disaster situation. Think ahead, be familiar of what's around you, who and how and where is everything. Stay calm, don't stress and panic, and always support your team. React to patient calmly. Each patient will be different and will grieve different. People will in a war or during a climate disaster, they will lose their close ones, so they will become emotionally agitated, they will scream and shout and cry and even hit. Make sure that you are calm and respond to each patient calmly. Secure yourself in case it became more aggressive or uncontrolled situation. Go back to basics when you have this kind of this mental block due to stress and due to working hours. You're going to be very stressed, and you will have a mental block, and you will be very tired. Go back to basics. Remember your ABCs. Trust your instincts. When you feel something is wrong, report it. This is one of the things that we nurses are very good at. By experience in ER, by experience by those patients, we start to feel when it's something is wrong. Like we can go and call the doctor, the patient is not right. Yeah, the patient looks fine. No, I feel that the patient is not right. And in less than in a minute, patient would collapse and the doctor would look, how did you know? So I think we nurses develop this sixth sense, as they say. Debrief, always debrief yourself and the team daily or per shift. Thank you. Thank you, everyone. I hope I did not talk too quickly and too fast. So any questions? And I'm open for suggestion or any discussion. You have 5 minutes because I have an appointment in 10 minutes. I have to leave in 5 minutes. So anyone has any questions?
For this lovely and interesting topic, if anyone have any questions for Ms. Noor, kindly write in the chat box or direct message for her, or you can raise your hand. Raise your hand. Okay, it seems there is no any questions. Let's move to our last three speakers. Thank you, Ms. Noor, for being with us.
Thank you, Aman. Thank you so much.
Allah, see you soon again.
Thank you.
So let's move to our next speaker. He is being with us for the second time, Dr. George Vitalago from Belize, Head of the Intensive Care and COVID-19 Unit at Belize Healthcare Partner Limited, President-elect of the World Federation of Intensive and Critical Care Medicine. His speech is about species and overview. Welcome, Dr. George. The mic is yours.
Thank you for your kind invitation, and again, congratulations to put together an excellent conference, and of course with a lot of things to learn from many different backgrounds and also different ideas, and it's very interesting. I mean that thank you for the introduction as well, and in the following 40 minutes I will try to talk about what is the current situation with sepsis. I will give you an overview of what we are at this point and what are some of the things that we need to think about for the future. I mean that the first thing is that I don't have any conflict of interest with the presentation, and then the most important question that we have is what is sepsis, no? And then normally when we have a definition, and just to say it, but for definition we need to review it based on what is the actual knowledge and the actual evidence, and revisit it. And that's what is been happening with sepsis. No, we trying to understand the concept of sepsis, and as you see from 400 before Christ, we talk about sepsis as a putrefaction. In the 80s, 70s, we start to describe sepsis as blood poisoning or systemic infection. And then we came to the 80s, 60s, and 80s, 90s when we have the concepts of Louis Pasteur and Koch about the germs, the theory of the germs, and knowing sepsis as a Greek, as basically decomposition or decay. After that, in 1914, we have the first attempt to define sepsis by Hugo Scott-Müller from Germany. And he, at that point, talked about sepsis as a state of microbial invasion from a portal of entry into the bloodstream, which casts signs of illness. You know, that's the first attempt to define. And after that, we start to see more and more, and then we know that by epidemiology and based on CDC, estimate that 1.7 million people got sepsis annually in the United States, and about 270,000 Americans die from it. No? 1 in 3 patients who dies in hospitals have sepsis. I mean that it's a really important, and also is a really costly disease. No, approximately the Agency for Health Research, they say that the investment is around 24 billions annually for the health costs. No? I mean that that is basically what is going on. This is an interesting study that was presented in the Lancet, and it collect information from 1990 to 2017 about and trying to do a global burden of the disease and trying to see exactly what is the incidence and mortality on sepsis. You know, and it gives us a good picture of what is happening with sepsis. I mean that that is just to illustrate the importance of it, and then we see how many attempts we have to trying to get together and formulate ideas about what we want to how we want to define sepsis. No, and then we have the first conference and the first definition of sepsis in 1991 that was presented in Chest by Bond and the group. And then we have after that a second attempt to define sepsis in 2001 and 2002, when we have already a big collaboration between the several players, the American Society of Critical Care, the European Society of Critical Care, CHESS. And after that, then we have many of the efforts like the Surviving Sepsis campaign efforts to trying to have a guide and also some points to help us in the management of sepsis. In that the first international conference that was, as I mentioned already, leading by Pon and et al. And this basically defines sepsis as an infection that leading to the onset of 2 or more of the, at that point, the the inflammatory response syndrome, and then we have severe sepsis and septic shock. The second attempt to agree on a definition on 2001, when we have more players, then we basically say that at that moment, we didn't find any evidence to support a definition change. And then we came to the third International Sepsis Conference in 2016, where we have now the introduction of artificial intelligence, especially the big data, that help us to come out with a new definition. And basically, we will review it in the following slides. what exactly is sepsis as we know. But again, those are concepts that are on continuous evolution and evolving based on what is the current information. I mean, we know that sepsis is definitely a condition that we see every day in our hospitals, and it's a life-threatening event, definitely, and a global disease burden. And today, this heterogeneous syndrome is defined as a severe organ dysfunction that basically is caused by a dysregulated host response to infection. And of course, we know, and our knowledge in pathophysiology has increased a lot. We know more, and that is helping us to understand better. However, despite all those efforts, the experimental and clinical research in the last decades, the ability to positively influence the course and the outcomes of the syndrome, it remains very limited. And essentially, we are on the base evidence therapy, essentially leading to measures of support. I mean that the sepsis 3 definition is one, sepsis as a life-threatening organ dysfunction caused by dysregulated host response to infection. And the second is septic shock, that is essentially a subset of sepsis with a circulatory and cellular and metabolic dysfunction associated with a higher risk of mortality. That is the definition we have now. But again, based on the evolving knowledge, then probably we will see some changes in the near future in the probably next presentation of the Surviving Sepsis campaign. I mean that the other important aspects is to trying to understand sepsis. And essentially, when we talk about sepsis, we see and we realize that the normal and careful inflammatory balance is disturbed. And with that, we see an important, basically, activation of inflammation, of hyperinflammatory, that essentially goes together with the suppression of the immune response. And all this together essentially will lead to a failure to return to the normal homeostasis and will cause harms into the host, and it will lead to what we know a life-threatening condition or sepsis. Then we know that the sepsis is essentially a condition that affects not only one organ. We see in this cartoon that if we don't able to control these continued events of inflammation, then several organs are going to be compromised. And we will see the activation of several inflammatory mechanisms that essentially we need to be able to control. I mean that in our understanding of sepsis and developing concepts, we need to be able to try to stop the progress to sepsis. We need to be able to attenuate the organ dysfunction. We need to also be able to assist with the failing organs and trying to, based on that understanding, trying to see how we can basically impact and trying to accelerate the recovery of our patients. And with the main purpose to prevent secondary infection and as well as secondary injury. I mean that we have this article essentially trying to understand the initial concepts that we know. And as I say, initially, we have the concept of SIRS, that essentially or systemic inflammatory response. And when we have the SIRS also as a trying to reach a balance, we start to seen and listened about the compensatory anti-inflammatory syndrome to trying to balance this response. However, what we know now is that all these are a simultaneous and pro-inflammatory and an anti-inflammatory response that essentially is a persistent inflammation and immunosuppression and catabolism syndrome, as we understand based on the current knowledge and in this paper that was published in the Lancet Infectious Disease in 2019. I mean that what we agree is that one side doesn't fit all, no? And we know that sepsis is essentially an umbrella syndrome. And what that means is that that patients with had peritonitis, patients with had malaria, dengue, necrotizing fasciitis, COVID-19, those patients have sepsis, but each one have any conditions that are very unique and very particular, and then we need to try to address based on that particulars of each condition and each patient. I mean that with that, then we enter to the new age of what we know that personalized medicine or precision medicine, where essentially we're trying to understand what are the different phenotypes and trying to personalize the response. That means that, of course, the different areas of research and the way actually the clinical trials are designed, as we know, most of the trials essentially been failing, then we need to try to rethink and trying to see based on the current information, what is the way how we are going to redesign the clinical trials to try to increase our knowledge and also to try to redefine and redirect the treatments for sepsis. I mean, that sepsis, as we know, as I mentioned, is essentially an area where we see important inflammation activation, and we have, of course, the pathogen recognition receptors, the pathogen also that help us to understand. We have alarmins. We have all these different kind of receptors that basically leading to the activation of the target genes coding for pro-inflammatory cytokines, such as the tumor necrosis factor and many other interleukins. And of course, we have the important participation of the cytokines that, as we know, are small proteins that can regulate the host response both locally and systemically after their release for various type of cells, either monocytes or neutrophils. The other important aspect is the fact that it's important that either the pathogen must attach and cross the mucosal barrier, and most of the times when they have sepsis, they definitely have the ability to escape the host defense system and multiply to ensure its own survival, and all invaded microorganisms with a sufficient lot of virulence can cause sepsis. And however, we know that several pathogens that we know they have an impressive arsenal to attack the host. And the better example of that is the SARS-CoV-2 that we know, and we are basically fighting for the last more than 20 months with the pandemic. I mean that what essentially we need to know, and as also in this slide is the other aspect in the understanding of the pathophysiology of sepsis is the role on the endothelium, and we know that the endothelium plays an important role in all this process of inflammation. And as we mentioned already, the DAMPs or alarminants as the PAMPs, as well as the oxidative stress and the dysfunctional nitric oxide essentially will create a dysfunctional endothelium with a dysfunction on the glycocalyx, and all these events, it will perpetuate, definitely cause an alteration in the activation on the coagulation cascade. It will cause a dysfunctional endothelium with altered communication among the cells, and all those things at the end, it will cause an altered microvascular flow with endothelial leak and edema. Of course, we will see that all these mechanisms are going to essentially revolve around the loss of autoregulation secondary to the endothelial cell injury, and also the alteration of the retrograde endothelial cell-cell communication, and alteration in the red blood cells that will cause a deformability and increase of the blood viscosity. Also, as we know, is an important damage in the glycocalyx, and the glycocalyx plays an important biochemical role and activities that includes maintenance of the blood flow and also protection of the barrier function, platelet activation, leukocyte adhesion and rolling, and activation of the coagulation and the complement systems. And as we know, the complement plays an important role. We have several elements in our immune system and our capacity to respond, that there is a close collaboration between the complement system and also other pro-inflammatory stimuli such as cytokines. And the complement system attacks these dangerous cells or pathogens and phagocytic cells that can respond more properly after activation by the pro-inflammatory mediators. And this teamwork is dysregulated in sepsis, and it will lead to an inefficient use of the complement system. And probably one of the complements elements that we are more concerned is the complement Phi and because it's essentially linked with dysfunctional neutrophils, apoptosis of lymphoid cells. It will cause an exacerbation of the systemic inflammation, cardiomyopathy, disseminated intravascular coagulation, and complications associated with multi-organ failure. Then this is more or less what we see in sepsis with the different elements, especially focusing on the complement activation, the different anaphylotoxins, especially the C5A as one of the most important, and all these continuing events essentially if we are not able to stop that, it will lead to a cell and multi-organ dysfunction. The other important aspect is the pathogens recognition receptor, that essentially the activation essentially leads to an upregulation of inflammatory mediators, and all this will result in a systemic inflammatory response, including activation of the coagulation system and also the concurrent downregulation of the anticoagulation mechanisms. The coagulation abnormalities in sepsis, as we know, it can be as mild as just essentially see some small bruises to definitely clinically relevant fulminant coagulopathies. We know that the most important initiator factor for coagulation in sepsis is the tissue factor. And indeed, the inhibition of the tissue factor prevents DIC and improves survival in experimental studies. The tissue factor is predominantly produced by macrophages and monocytes, and its expression is enhanced by pro-inflammatory cytokines, exemplifying the close interaction between the inflammation and the coagulation processes. I mean, this is essentially to try to summarize what we are already seeing. We have the different areas. We have the pro-inflammatory response and the immune suppression, and the pathogen. We have the pathogenic areas as well as the alarmins, and also the different elements like lipopolysaccharides, lipopeptide, peptoglycano, in that area, the fibrinogen, hyaluronic acid, and then the pathogen recognition receptor that will cause activation of the leukocyte activation, the complement, the coagulation activation, and necrotic cell death. And in the other side, apoptosis of the immune cells. It will cause that we call it a reprogrammation of the cells and changes in the cellular metabolisms. And again, as we already mentioned, if we are not able to stop these continuum events, it will essentially lead to multi-organ failure. We have also the neutrophil extracellular traps that essentially the activation of the coagulation system and the vascular injury are amplified by the release of these nets by neutrophils. And the nets essentially are composed of DNA, histones, and neutrophils, derivate proteinase, and that can protect the host by eliminating pathogens. However, nets may also contribute to collateral damage and thrombosis in the dysregulated immune response. Of course, all those things, among many other aspects that it will alter, is the consequences that it will have at the level of the microvascular flow. We see normal flow, the homogeneous flow, and also the heterogeneous flow in sepsis. And then, of course, in the normal flow, we know that the amount of oxygen available, it will be enough to try to be able to maintain the normal requirements of the cells. In homogeneous, despite there is a decrease in the availability of oxygen, we still be able to control. But in case of sepsis, we will encounter that the heterogeneous flow, despite the preservation of the total oxygen delivery, only a portion of the capillaries are perfused. Mean that those cells that are with distance from perfusion, then doesn't receive enough oxygen to meet metabolic requirements and become hypoxic. And then that it will affects definitely at the level of the peripheral circulation. I mean that with all this, one of the other concepts that we also seen in sepsis is the possibility that the cells will cause a reprogrammation as a survival strategy. The cellular metabolic downregulation that we see, especially in the earliest stages of sepsis, is being proposed as an adaptive mechanism with the main purpose to do reprioritization of energy consumption to limit additional injury, trying to maintain energy balance, prevent DNA damage, and preserve the cellular composition. I mean that those are the different areas or the different essentially mechanisms that the cells have with the intention to preserve energy. And then we have some examples right here. Like example, we have the vectorial transport at the level of the alveolar epithelium. And as you can see, normally we have all these the sodium potassium ATPase membrane in on a normal circumstances, but in case of sepsis, the vectorial transport of in the alveolar cells are lost, and then that will lead to loss of polarity and injury, loss of alveolar fluid reabsorption, pulmonary edema, loss of barrier function, and we see some of the biomarkers participation. And if we are not able to control that, then the patients will end on pulmonary edema. At the level of the intestinal epithelium, we have the epithelial barrier, the tight junctions, and the participation of these inflammatory mediators. And then again, if we are if the epithelial barrier is damaged, then what we'll see is an important bacterial translocation, and then it will cause some clinical consequences like increased mucosal permeability, translocation of bacteria, increased apoptosis, and of course, we can have some additional infections in this type of patients. No? And at the level of the kidneys and tubular epithelium, we see also a communication and signal that are damaged, and it will cause some loss of the polarity, decreased tubular ion reabsorption, increase of the different other elements, and of course the patients can easily progress to kidney failure. I mean, those are in those areas. Of course, also we have the cellular regulation of the mitochondria or mitophagia and biogenesis that we call it the Warburg phenomenon, and essentially we go from one area of aerobic glycolysis as an adaptative mechanism, no? From the normal phosphoryl oxidation to an aerobic glycolysis with the main intention to preserve energy. And then we can, this area is one of the things that is been a lot of research, especially in patients with cancer, and there are some applications that we're trying to see in sepsis, where essentially the reasoning of this is that essentially we'll trying to preserve and trying to create some particularly key elements like amino acids, fatty acids, and also the preservation of the non-pH with the intention to give preservation of the oxidation of the cells. You know, those are some of the elements or the advantages that the proposers of all these concepts are saying with these changes in the cells. Then the other, and right here we see mitophagy and biogenesis, and as we see essentially that the cells have the ability to do, like in a simple word, say checkpoints in the process of the division of the cells in the different checkpoints. Then the cells will have the ability to see if to move into different step in the normal cycle of the cells is reasonable to move or is best to stop, again with the intention to do a regulation and preservation of energy or adaptative metabolic reprogrammation. And then we see the mitophagy and biogenesis, where essentially we call it a dysfunctional mitochondria. We have the metabolic adaptation that we know already, that essentially we go from glycolysis and phosphorylative oxidation and all those things, and the cell cycle arrests with the basically as an adaptative metabolic reprogrammation. And all those things, if happen, then it will end on damage in the endothelium and in the micro circulation that will lead to dysfunctional microvasculature and an important activation in this cycle of the different inflammatory mediators that we've been discussing during our presentation. The other aspect that also is important and have an important participation is the microbiome and the pathobiome, and essentially the microbiome that it consists on trillions of bacteria and is basically most found in the gastrointestinal tract. And we have also the concept of dysbiosis of the microbiome, meaning a decrease on the microbial diversity that has been associated with altered immune response, and for instance, altered cytokine production capacity of the immune system. As we know, the sepsis will affect the composition of the intestinal microbiome, and it will alter the diversity, and then the immune response that can be further compromised when a translocation of pathological microbes through the disintegrated epithelial barriers result in a systemic and lymphatic spreading of pathogens. I mean that all of that we already review is essentially bring us to what was released in 2016, with, as you know, the different points and how the Surviving Sepsis campaign and our understanding is been evolving and very dynamic and changing in a way. You know? I mean that and also, of course, some of these concepts has been reviewed, especially the early antibiotic administration is being in another discussion. The moment on and under what circumstances we are recommended the early administration of antibiotics. Of course, we'll do the early antibiotic administration once we already took cultures, and based on the different understanding of what are the most common germs that are in each of one of our facilities. Fluids, as always, is always a point of discussion. For now, colloids and crystalloids are the recommended. Starches and high chloride are not really recommended because they can lead to kidney failure, and also it can also increase mortality. Vasopressors, again, the understanding of that, based on what we know, norepinephrine is the first choice, epinephrine and vasopressin as a second choice. And dopamine, as we know, have its different areas of discussion, like the ability to cause tachyarrhythmias, and that's why it's not one of the initial choices. We need to start early nutrition to our patients, the glycemic control that is not too strict, and then the other different supporters. Before the pandemic, of course, we was basically advocating to trying to don't use too much sedation, and as basically focus on pain control and molecular target therapies, the lung protective ventilator in case of ERDAs related with sepsis, monitoring urine. We knew that basically the gold therapy oriented is not something that we are using now. And then after that, in 2019, we came to what we know the 1 hour bundle. That essentially is when we have the opportunity to see the patients at the very beginning. Then we initiate the bundle upon recognition. We measure lactate and remeasuring, trying to obtain blood cultures, before the administration of antibiotics. We will use the broad spectrum antibiotics based on what is our knowledge and the different germs that we are commonly seen in our facility. If the patients are not responding, we need to begin the administration of the resuscitation, to trying to control hypotension and trying to measure the lactate. And if we are not able to restore and to get a reasonable blood pressure, then we start with the vasopressors to trying to regulate the blood pressure. Then this essentially to say that the sepsis is a very dynamic situation. I mean that we need to be evaluating our patients constantly. Nothing is a rule; those just are a proposed guides for us to help us in the management and in the understanding of what is happening with patients with sepsis. No, mean that just to have as a last points to remember, our knowledge on sepsis and pathophysiology is evolving, is getting much better. We know more now. Definitely, we agree that one size doesn't fit all. Each patient of sepsis are different. Mean that sepsis is an umbrella syndrome, and we need to act accordingly. We need to, of course, with the age of technology, we know that the diagnostic possibilities are huge. What are the challenges that we have is if those diagnostic tools, it could be rapid, if those diagnostic tools can be reliable, and probably one of the most important things is if those diagnostic tools can be accessible and, of course, affordable. We need to, of course, trying to, as we mentioned before, rethink about what is the clinical trials design, the patient population, the optimized timing, doses, and the duration of therapy. And of course, we need to see how we can impact the severity of sepsis, as well how we can improve the survival of our patients. With that, I think so cover my time. It's 40 minutes. Thank you again to the organizing committee for your invitation, and hopefully we'll be able to stay together in the next conference in San Francisco. Thank you very much.
Thank you, Dr. George, for your informative topic. You have covered everything about sepsis. As usual, your presentation is important and interesting. I have one small question for you. It's the special features for the sepsis.
Sorry, can you repeat the question?
Okay, I will repeat it again. What is the special features for sepsis?
The special features?
Yes.
For what? For sepsis?
Yes.
Well, as you know, the essentially what we've seen as we ended and we emphasize that sepsis is an umbrella syndrome, and then each patient it will manifest different. Patient with peritonitis will have some manifestation. The patient with malaria will have a different presentation. Patient with Zika or dengue, they will have a different presentations, and hence the reason why we are now more moving to what we call it the precision medicine or personalized medicine. And it's a lot of emphasis now looking into the different phenotypes of sepsis, and probably that is the future of the treatment and management of the sepsis.
Thank you, Dr. George, for answering my questions. Please, I would like to ask you to keep with us for our next two last speakers. So thank you very much and have a nice day. Let's move quickly to our next speaker, is Dr. Nancy Steenbekers from Belgium. She is the infection control specialist and the CEO of Ultrasonic in Belgium and Dubai section. Ultrasonic originated out of 20s passion for clean solutions with a background as an OR nurse and infection control specialist. She's truly gets the current field issue. It was and still is here. Her mission is to do away with these cleaning mistakes with simple yet efficient cleaning solutions. Always being one step ahead is what unmistakably makes ultrasonic pioneers in this field. It's not without reason that they have developed the first device worldwide to automatically pre-clean multiple endoscopics at the same time. Just we have to say in a few words, Dr. Nancy is a team leader and team builder determined to take patient safety to a higher
Yes,
level,
thank you.
open-minded and optimistic. Her presentation for today will be about pre-processed endoscopy. Are they really clean? So let's welcome Dr. Nancy.
Thank you very much for your introduction. So to correct, I have to admit I am not a doctor. You know, I was a nurse for 20 years. So, but okay, it's not a problem. It's just a little misunderstanding. So we start with the presentation. Do you see the screen?
Yes, we can see. Go ahead, please.
Okay, perfect. Yeah, you know, as I was a nurse for 20 years, I started my own business a few years ago. And actually, this is our building. And we have a lot of marketing behind also, because starting a new business in cleaning disinfection is really a big challenge, because we have to fight, not a real fight, but you have a lot of competitors in the market. And you like Miele, Getinge, and so many others. So, but the thing is that actually, as I was a distributor before, I was starting my business as a 100% distributor. I found out that the washer disinfectors of endoscopes or washer disinfectors for surgical instruments are not magic boxes at all. So there really still are many challenges to clean the instruments. I know that there is still some discussions about doctors. They say, yeah, you know, you just put the instrument in the autoclave and then it will be sterile. But you can never achieve a sterile instrument when it's not clean. So, and actually, when we take more focus on the cleaning procedures, then there are still many challenges. And that's what I wanted to explain and show you what's happening today with the endoscopes. Because here in Europe, we have a kind of screening for colon cancer. So every person who's got the age of 50 and getting older, they all get the examination for colon cancer. And we see not only here in Europe, but also in the US, we see a lot of challenges, but not only that, we see also a lot of patients are suffering of cross-contaminations. And so that's what I wanted to explain. So my name is Nancy Steenbekers. I'm based in Belgium. And at the moment, yeah, I'm the founder, you know, suddenly it happens. You have a bright idea and then you are creating new devices and then suddenly you're the founder. So actually, you know, it's just a name. But I'm just not, let's say, I'm very proud that we achieved a new device, but it's actually, it's good to be a leader in cleaning of instruments. My age is 56 years old, so I'm not a young entrepreneur, although my mind and my ideas are really young. And as I told you, I was working 20 years in operating theater. As a nurse, so at that moment I had to give assistancy in the OR, and at the time after the examination or after the operation, I had to take care of cleaning instruments. At the end of my career in the hospital, I was a specialist in dentistry, so maxillofacial surgery, and we had a lot of customers, patients, let's say, they had little infections in their mouth after the surgery. And I really was warned of that, that the instruments were not that clean as usual, because, you know, the moment that you take your instrument and you have done a wider view with the microscopes and everything, then sometimes you see that the instruments are on the outside not that clean than when we only see it visually. How does it work here? Oh yeah, like this. Okay, so that's why we are thinking a step further. So we are always thinking outside of the box. And actually, I found this idea because I was talking with many nurses all over the world. I travel all the time, and many nurses showed me their issues at the endoscopy department, at the CSSD department. They say, yeah, you know, Nancy, we have this issue. Can you help us? So I'm always there to help them. But actually, you can help them, but when you don't find a device to help them further, because, you know, a device is a reproducible thing. As long as you do it all manually, you don't have any control on the efficacy of your cleaning. So, okay, so let's just focus on Belgium. Belgium is a small country, has only 11 million citizens. And actually in Belgium, there was a few years ago, just before Corona time, we had some visitors. They were visiting 12 hospitals in the Flanders, let's say, in the north part. And 9 of them, they were not succeeding the test. They saw all kind of mistakes, misunderstandings. Endoscopes were just laying down on the side and nobody had any control if it was clean or not. Okay, so that after that, of course, it went into the newspaper. And I can tell you also, you know, in Holland, in the Netherlands, when they have an outbreak of the endoscopes, they recall all kind of patients back, and it will be always placed on the first page of the newspaper. So the moment that there is somebody is attacking hepatitis or TBC, tuberculosis or something, then they say, okay, how can it happen that it was in that endoscope? And then they will recall all the patients to examine them again if they were attacked with the bacteria or not. But anyway, we are now in 2021. So actually every single sink or every single device has to be compliant with the new medical device regulations. So we achieved also that, and also every single distributor or every single manufacturer to clean instruments has to achieve also the ISO 13485. So we achieved it a few weeks ago, which was also a big challenge. But okay, we've done it. So actually, when you just will Google about nosocomial infections and outbreaks, you will be surprised how many reports and how many studies there are. And actually, I found out that in the Middle East, nobody is not that focused on that. So that's why I really wanted to join also this lecture. To show you that, you know, you have the US, we have Europe, we have Australia. There are strict regulations, and in the Middle East there is also some regulations, but not that strict as usual. And because we never found any study in the Middle East about dirty endoscopes or something, we only found it in the US, in Europe, or in Australia. So anyway, it's always helpful when you want to Google and find some really interesting studies about the issues with the endoscopes. So in Belgium, we have Julia Kovaleva. She's from Poland, and she is a doctor, and she also was researching, making a lot of research on cleaning of instruments, and for sure also the endoscopes. So if you Google just her name, you will find also all these studies and articles. Actually, this is a very interesting picture when you see it on the right side. So the moment that the endoscope is used with the patient, they have to flush. So that's called bedside cleaning. That's a pre-cleaning at site of use. Also there are some issues because doctors, they want to end up the examination, and after the examination, patient is leaving the examination room, and in the meanwhile, the nurse has to rinse and flush those channels, because every single endoscope has at minimum a working channel, like a biopsy channel, and the most complex, like a duodenoscope, they have 8 channels in total. So they have to flush all these channels, but actually nobody's taking care about the efficacy of the flushing. They just flush because they say, okay, no, flush, 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 and then it's going on. So then it will be in a tray, and the endoscope, it will be transported to the pre-cleaning site. And actually, when you go to the pre-cleaning site, it's a big challenge, because we only see a simple sink, and that at that moment there are many mistakes, human mistakes on that moment. So actually, we should have more focus on that side. So after the manual cleaning, which is with some steps, but I will show you later, then it goes into a tray again. It goes in the high-level disinfector. So actually, it's a washing disinfector machine. And actually, that moment, your endoscope will be disinfected. It will not be cleaned, because the cleaning has to be done during the manual cleaning or the manual pre-cleaning as you want. And the high-level disinfector is disinfecting the endoscope, and then it goes to the transport again, and then then it will be ended in a drying cabinet to dry all those channels under control, and then it will be stored till the next patient will be in the examination room. And of course, inspection is also very important. This slide actually is from Dr. Michelle Alpha from Canada. And she found out that the potential bacterial load after use is quite high, of course. You know, sometimes you have the colonoscopy, or you have a bronchoscopy when it's all kind of blood or really sticky stuff, then the bacterial load is really high, not only on the outside, but for sure on the inside. And then when you go to the next step in the middle, there you can see the potential bacterial load after cleaning. So as I told you, the endoscope goes into the bedside cleaning, and then in the manual cleaning. And that moment, you will find the result is already a little bit different, because some they're really focused on cleaning on a very, very good way. Others, they just, they don't have the knowledge, or they don't have the motivation. So then it will be different. But when you see that gray bar, and you have this cleaning efficacy, then you put the endoscope in the washer disinfector, and that's also the result that you see on the right side. So that's the potential bacterial load after high-level disinfection. That now it's improved, that the washer disinfector is only disinfecting the endoscope, but it's not cleaning anymore. So the cleaning focus has to be before, okay? So how will we avoid biofilm bioburden outbreaks? Actually, a few years ago, I went to a Belgian hospital, and the doctor, he showed me that type of, it's a duodenoscope. So what you see on the outside is bioburden, biofilm, because it's brown, it's dirt. And I can tell you on the outside, you'll say, well, what's this? But on the inside, it's even worse. And it's getting worse and worse, because those channels are very small and very tiny. And it's really hard and a big, big challenge to get all the dirt out of these channels. Anyway, what we see today also is that many hospitals are suffering about the budget to repair endoscopes. And a small hospital here in Belgium, they have a budget for every year, 100,000 euros. So it's approximately $100,000. And I could not believe that they just count on that budget every single year, because endoscopes will be damaged all the time. And I was really wondering how it happened. So I got also an observation in some hospitals. And actually, I saw that nurses or the technicians who are doing the job of cleaning, they don't inspect the endoscope. So when you have all that kind of issues, what I'm showing you now, it's always a risk to create a cross-contamination from one patient to another one. because when there is a rubber done, or there is a scar in your hand, it's always messy up with human debris, so you cannot clean it. And this one actually is because they are performing the manual cleaning in a square sink, so they're damaging it during the manual cleaning. And that's also something which is very important to have more focus on it. You can see this is the bad performed leakage test. So, and then when we go in and look into the inside of the endoscope, then you really are out of the blue. You're really amazing when you see that all kind of damages on the inside is really very dirt. And but actually you get these kind of situations when you are misperforming the leakage test. And actually that's the start of everything, but I show you in a few later slides. So also here you can see the damage on the inside. Of course, it will not appear only after one time. This is a situation they were performing the leakage test time after time after time on a wrong way, and then suddenly the endoscope is not working very well, and then of course then they see that it has to go to the repair. Also here on the right side you see all kind of corrosions. Of course, you don't want to have any examination in your own body when you know that the endoscope of the endoscope is in that kind of shape. So that's why I'm telling you, in Europe, more and more hospitals are investing in washer disinfectors. Most of the time at the moment also on two sides. So you have the dirty side, the dirty wet side on one side, and then they put the endoscope in those washer disinfectors, and on the other side they take it out. So actually that's the move that they do in hospitals, which is quite good. But of course it's expensive, and actually everybody thinks, okay, hospitals are now investing in washer disinfectors, now all the problems are solved, which is way far. It's not really not true. We have this experience now, and we see it every day that those things are still going on. So when you go and hospitals are buying Olympus endoscopes or Pentax endoscopes or Fujinon, there are many brands. Then they have to read the instructions for use. And for instance, when you read the instructions for use with Olympus from page 15 till page 37, it's announced how you have to perform the manual cleaning before it goes into the washer disinfector. Every time when I'm talking with nurses or responsible people like pharmacists or even doctors, they never were reading the manual. So actually they just believe the sales rep of Olympus or another one, they just believe him. And actually, because of that kind of situation, they are performing the cleaning as the sales rep is telling them. But it's not always that precise, and that's my point of interest, of course. So when you go to look into sinks, here on the left side you see some sinks. It's 5 sinks. They need 5 staff, of course. They have just a square sink where they can damage the endoscope. They have height adjustable, so for ergonomics, it's really good organized. But at the end, they have no control what's happening during the manual cleaning. On the right side is the same. That's one in Ireland. It's height adjustable. They just have the tap, and you see the line in the sink, and they just fill it up with water. There is no control on water temperature, no control on contact time with the chemistry. So actually they're doing some job, but at the end there is no result. Same here. So on the left side down, that's one in a hospital in Belgium. So hospitals are investing in a cleaning device to perform the manual cleaning. But at the end, when I was standing there, the sink was never used. So the nurse came in with the endoscope, goes straight into the washer disinfector, because she said to me, no, I don't have time. We don't have a staff extra to perform this job because it takes a while. It takes 15 till 20 minutes. And on the right side, you see that there was a guy also in Ireland. he was showing me how he was performing the manual cleaning. So he was skipping the leakage test. He was skipping to rinse all the channels. And then he took it out and he was just brushing 1 or 2 channels on the edge. So this is a total wrong way to perform the manual cleaning. And here it's one of my last slides. Here on the left side, you see this is a hospital in Amsterdam. They have 3 cleaning sinks, they have computers, they have everything on board. But at the end, the responsible, he knows that the endoscope is at that moment on the manual cleaning side, but has no idea what kind of steps they were performing for the manual cleaning. So this is really a wrong investment also. And you see also there are 5 people, 5 staff, and just to work with 3 devices. And on the right side, there's one in Denmark. And also there I was surprised because 8 o'clock in the morning, they were filling up the sink with water and detergent. And at 1 p.m., so 5 hours later, they were still using the same water. So actually you're not cleaning at all. And the nurse says also to me, you know, we have 8 of those stations, but we don't have the staff. So actually that's the organization of the endoscopy department has to have more focus on that. So, and then when you know that they had 8 of those systems, they were using the other systems as a stock room. So actually you see that hospitals are have high investments, but they're not using it as it should be. So hospitals, the instruments are suffering about that kind of organization, and for sure, the patient safety is in big risk, okay? So now these are actually it's just 4 lines. These are the pre-cleaning steps to respect. So you have the leakage test and it has to be performed on a dry way during 2 minutes and 200 millibar. Then you have to rinse all the channels with water and detergents. And you have to get you have to respect the contact time of the detergent, and you have to look after the water temperature should be stable. Then you have to brush all those channels, and then you have to after rinse the channels. That's actually a short overview what you read in the manual of Olympus. So at the moment on the left side, you see they're performing the leakage test just on the wrong way, because they just have a leakage pump, which is not announcing anything. They have to look after the bubbles themselves in the water. So when there should be a leakage, they will figure out if there are bubbles. If not, they take it right away out of the water and go further. And then on the right side, you can do it also with the manometer, which is really good. But you have to respect 200 millibar till during 2 minutes. So nobody has that time to stay like that. And even when there are tiny leakages, it's really hard to see it on the manometer. So luckily, also when you don't have the budget to invest in a decent cleaning sink, let's say, you can still invest in kind of automated leakage testers. And also they are announcing that it has to be done on a dry way. Okay. So, and luckily for everybody, Olympus, I was in Canada, and Olympus Canada, they have now a new leakage tester where you can perform two endoscopes at the same time. Then, of course, you have to rinse all these channels with water and detergent. It's also very, very hard to track and trace, because how can you control it? Nobody has the control on that side, which is most important. And then you have to brush. Sometimes you see also that the conditions of the brush, when it's a reusable brush, it's really nasty. Sometimes it's only 1 hair on the brush, so you cannot brush that time. But you know, I'm talking with the nurses, I'm talking with the infection control specialists in hospitals, and they are really open to tell me all their issues, and I'm always willing to help them how they can do it better, of course, without having heavy investments, because that's also an issue. So now we are talking about this device that we found out, and we just go step by step through to the presentation. So actually, when when you connect the endoscope in the device, there is a track and trace, and you know exactly which endoscope is entering in the device, and also which doctor was using the device, the endoscope, which patient had the examination. So you have the full control what happened during the examination, and then of course after that it has to be pre-cleaned. But here you can see on the screen what we have. It's a big computer screen on the device. You can really follow your leakage test. So it's climbing up till 200 millibar, and it stays during 120 seconds. So then starting from the 90 seconds, the machine will figure out if there are tiny leakages or not. So as long as the green light, the endoscope is safe and there is no leakage detected, you get the green light here in the console. And when there should be a leakage detected, then you get a red light in the console. Oops. After the cleaning, after the leakage test, the endoscope will be down in the sink. It's automatically going down. You will see it later in a little movie. And that time we have full control on the water temperature. We have the full control on the contact time, because we put all this kind of information into the system and you cannot change it. So it's after passwords, you know, so that's why I'm calling this kind of pre-cleaning. It's a reproducible pre-cleaning, that every single endoscope has the pre-cleaning as it should be. Then of course we track and trace all the info, which is important. And that's also always with the barcode scanner. We track and trace the endoscope, as I was explaining already, what kind of sink we are using it. And the endoscope lays really relaxed on that grill or on that layer, let's say. Okay, and the layer is the movement. So of course, when the endoscopes are broken, you have to get the possibilities to put the lone scopes into the system, because otherwise the machine will not accept the endoscope. So after password, you can add operators, endoscopes, physicians, even machine settings. You can add all kind of programs extra, which is really easy to do. So we connect the endoscope with the maximum of 8 channel connections, and all the channels will be flushed, which is not done today. Today they soak it underwater, and they don't even have a water pistol. So it's really hard to get all these channels flushed, but with us, it's all automatically. So the moment that we scan the endoscope, you get a clear view on the screen, what kind of endoscope you have and how you have to connect. So actually, even when there is somebody who has never had education, they can help themselves with all the screenshots that we give. I'm trying to open this movie. I hope it works. Do you see movement?
Yes,
is the movie working?
Yes, the video is working.
Okay, so the endoscope is now laying on that layer. It's connected and the leakage test is running. So, and you can see it in the screen. Now we are getting closer into the screen. You see that line is running, okay? So it's nearly at the end. So you will see right away after this leakage test that the endoscope together with the grill, with the layer, will bring the endoscope underwater, because during the leakage test, we are filling up the sink with water and detergent. So now it's going down. And you see also you don't need any staff anymore to stand in front of the machine. It's going all automatically. So you see that there is a green light in the console. So everything is safe, everything is controlled. Water temperature is controlled, detergent is controlled, and the flow of those flushing of the channel flushing is also controlled. It's on full control. So that's actually the first step. And then, of course, when the flushing is done, the machine will announce that you have to brush. And depending of the choice of your brush is depending the time that you are consuming. So actually, I'm a big fan. When you see on the right, there are there is a brush with wipes, and that brush of wipes is made in New Zealand, and they were testing all kind of brushes together, of course, with those brushes with wipes. And the wipes brush is called the pull-through. And the pull-through, when you only pass one time in a channel, they were testing it, and there was no soil anymore available in the channel. And when you go just with the cleaning brush with hair, they were passing more than 5 times, and there was still some scanty soil. And you can see it also here. They were testing it with the ATP in a hospital in Holland. Also here you can see that the pull-through on the left side, in every image that you see, it's really having a really high potential to clean the ends in the channels. But that's only because you were rinsing the channels with water and detergent. You cannot flush or you cannot brush. I mean, you cannot brush without flushing the channels. So here also there is another brushing, no brushing. It's red is increasing actually. So you see also here the difference when you're brushing in a dry channel or when you're brushing in a wet channel. So in a wet channel, you achieve the better the cleaning. That's on the inside, the picture where you can see that brushes actually makes all kinds of scars into the channels. And here is a study, a comparison of the efficacy of lumen cleaning devices for flexible endoscopes. And if you want, I can send it to you. Just send me an email afterwards, and you can get all these kind of information and reports from my site without any problem. But at the end, the conclusion is that the pull-through is really taking all the debris out from 96% even till 100% of the residual soil. And you can also find it, of course, yourself when you go to that website, www.pullthrough.nz. You will find all these kind of studies on their website. So brushing we've done. And actually the brushing, what we do is we have a camera in our sink, and the camera is taking a little movie during the brushing procedure. So actually there is no discussion anymore if it's brushed or not brushed. You can check it yourself. The responsible can check it herself if it was brushed or not. And when there should be an outbreak, hospitals can really give the full control that they were doing the job as it should be, which is not today with just a simple sink. So the channel brushing, then after the brushing, you get the after rinsing. Of course, it's because all the debris has to get out of the channels. And when the after rinsing is done, the layer will bring the endoscope back to the top, and the water is leaving automatically the sink. So you don't have to take focus if the sink is clean or not. It's all going automatically. And then, of course, that's the most important. Now you have the powerful reporting system while you were performing the manual cleaning. While today, no sink in the market can give you any idea about the procedure. So let's say that we have an outbreak. So then you can add here in the search bulk on the upper thing, you can put an endoscope, or you can put a patient or whatever. You can put some dates in it, and then when you click on that eye on the right side, then you get the individual cleaning report. So there you can see the leakage test. You can see on the left side the run number. You see the total cycle time. You see the brushing time. The endoscope was connected to which an operator there was. And at the end, the test was successful. There were no faults at all. Okay. So the extra safety features, because of course, when you skip the manual cleaning and there should be something wrong, and then you say, okay, hurry, we put it in the washer disinfector. Then you will have the issue that the endoscope will be not released in the manual cleaning, so it cannot enter in the washer disinfector. That's an extra safety feature that we provide now. The evidence, we have clean filters. So every morning we change the filter in our device. And actually, this is a dirty filter after 1 day. So actually, I don't have to improve it with a study. You can show it now visually, how much dirty that we get out of the endoscope only during the manual pre-cleaning. So the unique selling points actually from this device is actually in Belgium, the return on investment is in 9 months because our staff cost a lot of money. But at the end, you need less staff. You have the full control on each cleaning step. You have the control on brushing by the camera. There is 95% less damage of the endoscope. So you can imagine hospitals are not paying any more 100,000 euro because of damages. So, and also the material that we are using is HIMAX, which has a LGA certification. So that means there is no bacteria can grow into the tissue. And at the end, it's a hardware, software, and track and trace all in one device. And we have full control on human errors. So this is one of the last slides. So the result of colonoscopes, our procedure time is only 7.5 minutes. And you can see on the left side, that's actually the potential bacterial load. And on the right side, you see already how much dirt that we are putting down. But then when you go to just another sink, you take 15 minutes. You're not skipping any steps, but it takes the double of the time. And then you see also that the result is really good. But then you have to be assured that you're not missing any cleaning step. So reference that we have today is Belgium, the Netherlands, Sweden, Saudi Arabia, Switzerland, and now we are working on a big project in the biggest university hospital in London. And here are some pictures of it. So here in Belgium, that's in Brussels, they have 2 devices of ours. They have 4 sinks, and it's only operated with 1 operator. So, and still the responsible has the full control of the manual cleaning. This is another hospital in Belgium. This is also in Belgium. Then we have the Netherlands. You'll see they all take 1 device with 2 sinks because the wet room of the endoscopy department is always very small. That's in Sweden. They use it only for cystoscopes, so only for urology, which is they only have 1 channel, but they're still using that kind of devices in Sweden. This is in King Fahd Medical City in Saudi Arabia. So they have 2 devices with 2 sinks. So that's 4 sinks at the same time, but they're working with 2 operators. So you see that window on the left side, there are the examination rooms. So the endoscope enters through the window and goes into the manual cleaning. And on the other side, they have the same situation. So the moment when it's all cleaned, then it goes into the washer disinfector on the other side. And that's in Switzerland that we are working. So actually, the future will be a worldwide challenge to be sure that endoscopes will be clean. And actually, for me, it's the most important need for every single hospital with endoscopy examinations. So this is just a little movie. I hope it works, how it works. So I hope you enjoyed this little movie.
You're guided through the world's most advanced endoscope pre-cleaning device. Performing semi-automatically, our endo device makes sure no steps are missed or misperformed. First, make sure your endoscope is connected to the desired console and select the basin you will be working with. The buttons on the left side will operate the front basin. The buttons on the right side will operate the rear basin. You can do this by scanning the barcode of the basin or selecting the basin on your screen. Once all of the connection tubes are plugged in, scan the endoscope, the operator, the patient, and the doctor. As soon as you've scanned the endoscope, the selected basin will automatically be filled with the predetermined amount of water and detergent. In the meanwhile, the leakage test will already start. The pressure can be monitored on the screen. Our endo device performs the leakage test on a dry surface for 2 minutes, providing a clear, trustworthy test. Without damaging the scope, water damage will be prevented in any tiny leakages. After a successful test, the shelf lowers into the water and detergent solution, and the endoscope channels are being rinsed. As soon as the first rinse session is completed, a message on the screen will pop up, indicating the start of the manual brushing. After confirmation, the shelf moves upward. Before starting the brushing procedure, make sure the endoscope is disconnected. Now brush the endoscope according to manufacturer's instructions. This action will be recorded with the built-in camera system. A detailed report containing this video can be opened as soon as the procedure is finished. When the brushing time has elapsed, reconnect the endoscope. Push the Acknowledge button to move down the shelf, allowing the second rinse session to start. The elapsed time of both rinse sessions is equal to the minimum contact time specified by the detergent manufacturer. The shelf moves up again while the sink is emptied and flushed. Push the Acknowledge button if the procedure is finished. You are now automatically redirected to the Start screen, where you can start a new procedure if necessary. The pre-cleaning procedure is finished. You can disconnect the endoscope, which is ready for final disinfection. Afterwards, you will receive a detailed report, allowing you to check all reprocessing details.
Okay. Oops, sorry. Yes. My next slide is not working. Oh yeah, there. Okay. So thank you very much for your attention. Is there somebody who has some questions about this kind of technology?
Sorry, if anyone have a question, just raise your hand or write in the chat box.
There is some.
Let me check the chat box.
Yeah, I'm checking the chat box, yeah.
Actually, there is no questions. Thank you, Ms. Nancy, for this excellent
Okay.
Okay.
Thank you very much.
From Ms. Ashley Brock, she is asking about, is this product available in the USA?
Yes, we are ready for the USA, but we don't find a distributor at the moment. So if you can help me with a distributor, it should be very helpful. Actually, it's available all over the world. So, but we don't have a reference now in the USA. But we know there is a huge interest in the USA. So we are ready to enter USA without any problem. So we have the CE, we have the FDA. The FDA we don't need because it's a class 1 device, but we are ready for the US. So if you can help me, maybe I can send you my email address or something, and just maybe we can keep in touch with each other.
Okay, I have one small question. Ms. Nancy, what was your passion to open your business, and what was the challenges that you have faced about dirty endoscopy? Why is this an important issue?
Well, I have an autoimmune disease. I have celiac, so I had by myself a lot of examinations with endoscopes. And luckily, I never had any infection. But the moment that I became distributor for Cantel, for washer disinfector manufacturers, we had quite easy the first conflict in the hospitals that they say, you know, there is a bacteria growing into that specific endoscope, and we cannot kill it anymore. So and that moment we were figuring out, okay, what's happening? So you have this washer disinfector. It has to kill normally all these bacteria, but it's not. So in the real life, it's not. So that's why I'm talking with a lot of infection control specialists in hospitals, and they all admit the issue that we have today is the manual cleaning, because on manual cleaning, we don't have that much focus. And then start my own business is it's a challenge because of the financial situation. And also, of course, we had now COVID. So I was nearly more than 6 months not working. It was not possible to enter any hospital, but we are doing good. The financial situation is okay. We found one investor a small investor, and we can do it on that thing. But of course, you know, opening a business, leading, because we have some staff in our company, leading those staff, find the good staff with for technical support and everything. There were quite a lot of challenges before, but now we realized, and we really found very nice staff to support all those devices all over the world. So we have other devices also. It's installed now even in Taiwan. So we are growing. So if you have an idea, or if you need some help, I'm always there to help you. You don't have to buy my device. I just want to give you my advice for free. Okay, so that's the point.
Thank you, Dr. Ms. Nancy, for your time. And now let's move to our last speaker.
Yeah.
Okay, from Saudi Arabia, Ms. Afnan Al-Shahri. She's a nurse intern at King Fahd Medical City, and her presentation is about awareness of Saudi registered nurse about nursing informatics. So let's welcome Ms. Afnan.
Thank you so much, Mrs. Amal. It is really a pleasure to be here with you all. Unfortunately, I planned to attend in Dubai, but unfortunately I couldn't. But thanks to the technology that made us all closer, regardless to the distance. I won't be taking a lot of your time. I'll just like to introduce myself, and then I will be showing you my poster. But if you just give me a minute, I'm trying to share the screen.
Okay, yes, please. Press the share screen.
Yeah, you can see my screen now?
Yes, I can see it.
Okay, good. So my topic is going to address the informatics and the nursing informatics, the importance of the informatics in the healthcare and patient safety. During my experience and in the field, and when I did my master's degree, I noticed, even though the importance and the digitalization in healthcare, yet the nurses who are the frontliners in Saudi Arabia, they're still, I would say, in my own experience, or in my own, what I noticed is that there is still a novice about informatics in general. So, I was interested to see, because there is also the, the transformation of in Saudi Arabia, the Vision 2030. They are going toward the digitalization. So with all these moving, so I wonder, where are the nurses, the Saudi nurses going, or where do they stand within these changes? So that's the question that came up to my mind, is the nurses really aware about informatics? And in the United States, they already dedicated a whole role and called it nursing informatics. So in Saudi Arabia, there is the vision, they made a whole vision to transform the healthcare to purely digitalization. And here's some pictures that I took from the government site, which is the Vision 2030. This is the plan they want to do, and this is the current state. And if you can see, there's, they are already doing a lot of digitalization services. Telehealth already started, especially after the COVID. Already the technology is ahead of us. So this is the poster that I did. It's about the awareness of Saudi registered nursing, about nursing informatics, and it's a survey. And I choose those topics because the nurses are the backbone of the healthcare, and they are the one who's taking care of the patient. And literature has proved that the informatics and technology will improve the patient safety. So where the nurses are the nurses really aware of this, and do they really understand what's informatics and what are their computer skills? That's in general, this is the poster what's about. And if you can see, there's the nurse informatics role. So the nurse informatics role, she evaluates the need for applications. She evaluates if there's the hospitals or the institution needs some applications or improvement in the electronic health records or the portals, so that it will all leads to improvement of the patient experience and patient safety. Also, the nurse informatics ensure the standards documentation in the electronic health record. And there's, I've been reviewing the literature, and I've seen a study that's done in Hayel in Saudi Arabia, that there's a survey distributed to nurses. They want to measure their informatics literacy and computer literacy and informatics management knowledge. And if you can see, the informatics literacy scored the lowest. So there's definitely need for the nurses, the Saudi nurses, to be more aware about what's informatics and how can the role of the nurse informatics specialist pave the way toward the future of the healthcare digitalization. I proposed a solution to the problem, which is the teaching session, teaching session, and it could be done by different ways. We doing a pre and post test session to assess the improvement. The methodology also, I will do. The survey will be using a HIMSS survey questionnaire. They did it previously, and they distribute to nursing to see the general perception of nurses toward the nursing informatics and nursing informatics specialist role. So this is it in a nutshell. I wanted to be very quick, concise, and to the point. Thank you so much again. And if you have any questions, please.
Thanks, Ms. Afnan, for this lovely short topic. I have actually two small questions. The first one is, how do you think that the nurses' awareness in health informatics topics is important? And the second question is, what is the long vision or long objective for the future of the health informatics in Saudi Arabia, as it's a new teaching and new working measure?
Thank you so much, Ms. Emel, for the questions. The first one, you said that how do I think that nursing informatics role is important?
Yes.
Yes. So as the role of the nurse informatics, she will be in the middle of linking between the technology or the IT specialist and the healthcare providers. And the good about nursing is that they already see the patients, they already deal with the patient every day, they already know what are the difficulties while dealing with the patient and dealing with a new system or new technologies. So by standing in the middle of those two, she can recommend a lot of improvement and system process modification, so that it will lead to a better healthcare service and better patient safety. I'm sorry, remind me of the other question.
Okay, the other question is, what the long-term objective or future vision for health informatics in Saudi Arabia, as it's a new measure for working and a new measure at healthcare field?
Yes, thank you so much. Also, that's a very, very important and good questions. Actually, there is a lot of courses and master programs that are done in the field of health informatics that really they are encouraging nurses to assign in these courses because they are the future leaders, definitely. And there is, maybe you've heard of the, the initiatives that Prince Mohammed bin Salman, he did to support the Saudi nurses. So they are the nurses are definitely the future, and because we are going also through privatization, the role of the nurse is very huge, and she really needs to be very conservative when it comes to technology and informatics. Does that answer the question?
Yeah, thank you very much. You are answering my questions very clear. If anyone has any more questions to Ms. Afnan, just raise your hand or write on the chat box for everyone or for her direct. Okay, it seems that we run out of time, and I guess we finish everything for today. Could I have your attention, please? I would like to mention that we will distribute the conference certificate, the recorded videos, and the conference photos by December 25. And thank you very much for joining us for the 3 days. Hope to meet us at our 2 next conferences in Dubai, July 2022, and the other one in the USA on San Francisco from 15 to 17 November 2022. Now I will open the stage for anyone to, if he wants to say anything or any small words, just for a few minutes before we are leaving. So if anyone is there anyone who wants to say anything? Just raise your hand. Okay, I will start reading the chat box. Ms. Ghada Naimi, she said, many thanks to Ms. Amal and UCG. It's a great 3 days. You are more than welcome, Ms. Ghada. Hope to see you at our 2 next conferences. Ms. Manuel from Italy, many thanks. Ms. Afnan, thank you for this opportunity. Ms. Ashley, you are more than welcome, dear, and hope you are enjoying our conference, and hope to finish and graduate your nursing study very quickly with excellent achievements, and meet you in our next conference as a registered nurse. Is there anyone who wants to say anything? Okay, I'm reading now the chat box. Miss Khadija, okay, Miss Fabrika from UAE said, thank you so much, Amal. You are doing great job, and all speakers. Thank you, my lovely. Miss Khadija Salem said, really, I'm interested in this conference. I learned a lot of information. Thank you so much. You are more than welcome, Miss Khadija. So I would like to say thank you very much for my colleague at the UCG team, Dr. Pascal Ani, the head of the organizing secretariat, Mr. Max, Ms. Freya, and Ms. Bianca. Hope to see you, all of you, physically shortly, inshallah, and I hope to meet all of you at our next conference in Dubai and the USA. If you have any questions or any new idea and suggestions that we have to work on during our next conferences, I'm happy to hear from you. And Ms. Khadija writes again, I hope attending the conference in next year. Inshallah, you will join us at our 2 next conferences. So thank you very much. Thanks for your time and effort. Hope you are joining our 3 days conferences, our 3 days networking and debates, and see you again. Before I'm leaving, I would like to mention again that the conference certificate, the conference photos, and the recording video will be submitted to all participants within December 25. If you have any ideas or suggestions to work on for our next conferences, I will be happy to hear from you. You can contact me on WhatsApp, LinkedIn, Gmail, Twitter, telephone, or email, or anything. Thank you very much for your time and have a nice day.